Good morning, ladies and gentlemen. Welcome to day 2 of the 16th National Health Research Conference. I am Norlet Reddy, Training and Education Nutritionist within the Nutrition Unit of the Ministry of Health and Wellness. We will start today's proceedings with a blessing. I now invite Mr. Keith Fogel, Director of the Health Promotion and Education Unit, to offer prayer. Ms. Fogel.
Thank you. A pleasant morning. Let us pray. Heavenly Father, we give you thanks for this a new day. We thank you, Lord, for yesterday and the wonderful presentations and all that was shared yesterday. Lord, we pray that today you will bless every presenter, every moderator, everybody who has anything to do with making today a success. Lord, we look to you, Lord, for your presence amongst us, Lord God. And that which we learn, Lord God, we praise it to inform policy, programs, and all the things that will make our health better. So
Thank you, Ms. Fogel. It is indeed my pleasure to introduce our distinguished guests for today. Excuse me, sorry for the break.
Good morning, everyone. Unfortunately, there were technical difficulties and we couldn't hear the prayer, but we want to stand in good stead for the rest of the day. We want to thank Ms. Fogel for her dedication to attempt to make the prayer while on her way to a meeting. So we want to thank her for that. Let us pray. Father Lord, you are great and greatly to be praised. We want to thank you for all that you have done and are doing. We want to thank you for your many blessings upon this endeavor. Thank you for the presentations that were made yesterday and for those that will be made today. We ask for the covering of your Holy Spirit. We ask, O God, even as we begin this presentation, we want to magnify you and recognize that your word says, "Lo, I am with you always, even to the very end of the ages." And so we know with expectation that your presence is here. And we ask, Lord, for your continued blessing, as well as a special blessing on the technical aspects of this meeting. We pray, Father, for the GIS team. We pray, Lord, for the Zoom team, and that you cover every technical aspect, Lord, of this conference. For those who are in the diaspora, we give you thanks, Lord, that they are able to join. For those who are in parishes, we give you thanks. And so, Lord, we just honor your name, and we pray this in Jesus' name. Amen.
Thank you very much, Dr. Grant. It is indeed my pleasure to introduce our distinguished guest speaker for today, Mrs. Marshall Thurner Miller. Mrs. Miller is the Director of the Nutrition Unit within the Ministry of Health and Wellness. She has been employed by the ministry for over 10 years and has over 20 years' experience in the field of nutrition and dietetics. Mrs. Miller studied at the University of West Indies, Mona, where she attained a Bachelor of Science degree in Chemistry and Food Chemistry, and the Master of Science degree in nutrition. She is passionate about infant and young child feeding and has presented Jamaica's situation in international, regional, and national settings. Mrs. Turner Miller, ladies and gentlemen.
Thank you so much, Ms. Reddy. A pleasant good morning to everyone, especially our online viewers. So, in 2025, the Ministry of Health and Wellness commissioned a survey to look at the media promotion of breast milk substitutes, particularly to assess the implementation of the International Code of Marketing of Breast Milk Substitutes in Jamaica. Now, the International Code of Marketing of Breast Milk Substitutes that was adopted by the World Health Assembly in 1981, and Jamaica is signatory to the code. It covers infant formula for infants, follow-up formula for children 6 months to 12 months old, growing up milks for children 12 months to 3 years, any other milks, complementary foods, and feeding bottles and teats. So the assessment aimed at measuring the scope of the promotion of breast milk substitutes, which we mentioned just now across the media, and to evaluate the compliance of those products to the code, and to identify strategies that companies use to promote breast milk substitutes across media, both digital and traditional media. So we reviewed 174 promotion entries across digital platforms and 599 ads on traditional media. And we gathered evidence to guide policy enforcement and public education. Now we know that breastfeeding saves lives. It contains all the nutrients that a child needs to survive, and the WHO recommends that the child should be exclusively breastfed for the first 6 months of life, which should be followed by continued breastfeeding up to 2 years or beyond, as long as mommy and the baby chooses to, along with the addition of complementary foods from the family pot after 6 months or at 6 months of age. We also know that breast milk substitute marketing undermines health. In fact, it undermines the confidence that a woman may have in her ability to breastfeed, and that will lead to negative outcomes, such as acute malnutrition, which may lead to death if not identified and treated early. The International Code of Marketing of Breast Milk Substitute, it provides the global safeguard to protect breastfeeding and protect infants as well. In addition to the adoption of the code by the World Health Assembly in 1981, since that time, there has been a number of resolutions that speaks to different aspects of the code. Now, to monitor the marketing or the implementation of the code internationally across regions, WHO developed a net code, which is a monitoring toolkit. And so the study used the net code toolkit to monitor the media promotion of breast milk substitute. Now in Jamaica, the protection of breastfeeding is a national priority, and a code of marketing of breast milk substitute, the implementation is also a priority for the country. And that is why, one of the reasons why the study was commissioned. Now, we took a digital-first approach, meaning that we went on different digital platforms and we examined for promotion of breast milk substitutes. We found 174 digital entries, as well as we looked at social media platforms as well as e-commerce. And the e-commerce are platforms that the products are sold on. We also examined the Meta Ads library, which is a global library that keeps a database of all the ads placed on Facebook and Instagram. And we examined traditional media, meaning the television, the radio, and newspaper placement. And again, we used the netcode monitoring framework. There are a number of limitations pertaining to the data. For example, coverage gaps. There were incomplete TV logs, partial or radio print, and that is because we did not get the information directly from the TV companies. We got it from a secondary company. So the data is about 98 or 99% accurate. For the cost estimates, it's based on open rates and not actual spend, and so we were not able to see whether or not the companies got any discounts. We weren't able to capture that, or if they went into any negotiation and got a cheaper price, which would be different from the open rates. There are some classification issues where on some media platforms, the promotions were not flagged as ads based on how they were placed. And then there is a short window of monitoring. For the digital assessment, it was done in August last year, and so that was only 1 month. However, for the traditional media, it was done over 4 months, from May 2025 to August 2025. And because of resource limitations, we did not include the assessment of promotion on billboards or at events. We collected data on retail promotion. However, we have not yet analyzed that data, so it's not a part of the report. So let's look at our findings from digital media promotion. Now, each entry is counted separately, even if the ad appeared on more than one platform. So, for example, if there's one particular ad and it appears on 3 different platforms, it is counted as one entry, right? The good thing is that the way the data was collected, it captures the unique exposures across platforms and contexts. So we did not only look on the manufacturer's websites or their pages, we also examine different pages. For example, if there is a social event and a manufacturer is a sponsor of that event, then based on the foundation, for example, that is putting on the event, that web page, if it's promoted on that web page, then it would be captured. The data also provides a clear picture of how often consumers encounter breast milk substitute promotion. Now, if we look at the brand share of promotion, we see that across different brands, we have a difference in how the products are promoted or the number of placements of ads from the brands. For example, the study found that Lasco has the largest share. So if we look on the table to the left, you'll see that the total number of ads, 172, of that amount, Lasco has 79, or they had 79 entries for that period. And that was followed by Nutriborn, Massey Distributors, Chas-E Ramsey, Nestle, and Enfamil. 2 companies, Abbott Nutrition and Seprod, did not have any media placement during the period of assessment. Most of the ads targeted products for children, in the age group 6 to 12 months. And most of the products promoted were complementary foods, followed by follow-up formulas and growing up milk. Infant formula had the smallest amount of promotion, about 5%. And you can see that on the graph on the right of the screen. Now, companies promoted the breast milk substitutes during that period in a number of ways, using cross-promotion. So they use, for example, mascots, or they use a particular logo for one product type and then use that same logo for different product types. They had health and nutrition claims. They use influencers, and for some companies, they gave discounts and giveaways. The health claims varied across product types, but the most common ones were boost immunity, support brain growth, claims, and there are claims in all product types. And again, the product claims were in product mostly formulated for children 6 to 12 months old. The violations occurred across different platforms. Meta ads were common, and the meta ads include the ads on Facebook and Instagram, Google Ads, Instagram, and again, e-commerce platforms such as iLo, PriceSmart, and Cool Market. This is an example of ads placed on digital media. So let's look at the findings for promotion across traditional media. So for traditional media, we reviewed 5 ads, and of the 5 ads reviewed, 80% of those ads had health claims, and 1 ad, 20%, had healthcare endorsement, meaning that they use what appears or who appears to be a healthcare worker in the ad to endorse the product. So the common brands are the Alacta Plus. The ads are for the Alacta Plus across both radio and TV, Clim Gum, and Nestum. For the media mix and investment, the companies invested a lot of money on the promotion of breast milk substitute across traditional media, not as much as the digital media, but still a significant investment. So there's an overall spend in the period based on the market estimate of 5.2 million Jamaican dollars. And if we look at it by brand, based on data collected, Alacta Plus used approximately 2.4 million Jamaican dollars, followed by Nestum, 1.6, and then Clim, 1.1. And if we look by media type, most of the money was spent on radio. And that was followed by TV and then newspaper placement. The newspaper placement was very limited. But for radio placement, they used some of the most popular radio stations that would have a wider reach, and then they would have frequent ad placements on those stations. For the market share, Alacta Plus, Nestum, and Clim Gum together captured over 95% of all traditional media spend. So let's look at the ads by brand. There was a total of 599 ads across traditional media. And as you can see by the graph, Nestum had 248 ads, Alacta Plus 235 ads, and Clim Gum 115 ads. And Gerber had 1 ad. And the graph also shows the spend by media houses. All right, so based on our time-based analysis, we saw that the trends showed that there was investment levels that varied significantly from one month to the next. And so in May, you had a large spend. However, as you move towards August, the spend decreased significantly. And if we look at the table, we saw that between May and August, there, for Alacta Plus, for example, which has the greatest market share, there was a 41.8 decrease in the amount of money spent on the promotion. More research needs to be done to determine the reason for the decrease month by month, but what we know is that during the month of August, we usually have World Breastfeeding Week promotion, and that may have influenced the decrease around that time because there would be more monitoring of the International Code of Marketing of Breast Milk Substitute closer to that time, as well as more promotion of breastfeeding. So we had mentioned the decline in spend. Okay, coming out of this study, there are a number of recommendations. So we have seen that in Jamaica, most of the promotion is across digital media. However, there is still significant investment in traditional media promotion. And so we have to ensure that in promulgating regulations that we have a wide coverage that would cover online ads, the use of influencers, and traditional media. There's also a need to ensure that there is a strong legal definition in the legislation that would close cross-promotion loopholes. In a number of countries that have regulations pertaining to the promotion of the code, because media promotion is somewhat new, the wording in the legislations do not adequately cover the cross-promotion loopholes seen in the media, online media. And so it's important that when we're putting together our legislation, we ensure that we close the gaps for that. There is a need to institutionalize monitoring in Jamaica. So for Jamaica, we do not have legislations. What we have is a gentleman's agreement. And so the companies more or less agree that they will abide by the International Code of Marketing of Breast Milk Substitute. And so there's no teeth. In addition to that, the monitoring is limited where persons may report breaches to the National Infant and Young Child Feeding Committee. However, the monitoring framework needs to be strengthened, which means that there needs to be a budget for it, there needs to be capacity building as well, and we need to use the netcode monitoring tools to ensure frequent monitoring of the implementation of the International Code of Marketing of Breast Milk Substitutes. There's also a need to strengthen advocacy and awareness by engaging the media houses and platforms, health professionals, and the general public so that we can build shared responsibility for compliance so that everyone can own it. There's a need to strengthen enforcement, as mentioned before, where I told you that there's no teeth because we do not have a legislation. And so it's important that we put in place sanctions for breaches and have public discourse to discuss that. There's a need for a whole of society approach and advocacy to include civil society, academia, professionals, and everyone should be a part of it. And there should be regional cooperation, which are regional groups and other Caribbean countries, so that we can monitor the promotion across the region, because for digital media, what we see happening in one Caribbean island usually happens in the next Caribbean island. So for online, it's usually by regions. Thank you.
Thank you very much, Mrs. Turner Miller. At this point, we are open to questions. No questions? Right. Thank you very much for joining us. Oh, sorry, we have a question, Mrs. Miller.
Good morning.
Good morning. So we have a question on Zoom. So the question is, do we support breast milk substitute or encourage breastfeeding?
Okay, thank you for that question. Now, as a country, the feeding method that is promoted is breastfeeding. We recognize that in some instances there will be the need for breast milk substitutes for infant formula. For example, if a mother is taking some form of medication, she may not be able to breastfeed. And so the International Code of Marketing of Breast Milk Substitute it does not say that breast milk substitutes should not be used. What it does, it regulates the marketing of breast milk substitute. And so to answer your question, we recognize that breastfeeding is the best option for infants and for mothers as well. And so that is the recommended feeding method, unless the mother is not able to breastfeed for medical reasons. Good morning.
Morning, sorry. My question is, is there a reason TikTok as a social media platform was excluded? Because I am a new mother myself, and I get a lot of my news or information from TikTok because it's easier to consume. So I guess my question is, why would you exclude TikTok? Because it's very popular now, especially among millennials and Gen Z, and yeah, that's all.
All right, so for the other digital platforms, it was easier to collect data based on the international library. So it was easier to collect data from that. The international library, the meta library that I had mentioned before, because it collects that information for all ads ever placed on those traditional media platforms, it was easier to go back. So for example, the assessment was done in August. However, we were able to go back a few months and collect data about placement from those months. It doesn't include data from TikTok. And so it wouldn't give a true representation of the breach in comparing one media platform to the other. Any other questions?
We do. We have another question. It is there a document to affect policy that ensures breast milk is the better option in all advertisements?
Right. I am so... In all advertisements? All right. So the International Code of Marketing, it has a section or a component that speaks to the label of the products. So on the label, there should be a statement that speaks to the danger of using breast milk substitute and also highlight the benefits of breastfeeding. So the International Code of Marketing covers that. The ad did look, the assessment did look at the advertisement and whether or not those statements were placed, and the survey found that there was approximately 97% breach in terms of not having the statement about the danger of formula feeding or the benefits of breastfeeding.
Okay, we also have a question from Dr. Olonge. So I'm going to ask if she could ask her question.
Sure.
Bless you for your excellent presentation. We are
Thank
really
you.
grateful for what you have presented. So my question, some of them have been answered, but what I'm asking, the breast milk substitute that is being promoted, is it a case of it's a one type of product, or there are several products?
Okay, so based on the findings from the survey, it's a wide range of products ranging from complementary foods, infant formula, follow-up, or growing-up milks as well. So it's a wide range, and they're promoted across various platforms.
Okay, thank you.
You're welcome.
Now, that takes me to the last question or comment, that the parents, there was a recent recall of products. I believe maybe you would have been aware of that. So the problem with such substituted product is that when there are contaminants, I just use that word loosely, contaminants, could be anything that impacts the life of the baby. It is difficult for us in a country like ours to be able to know, because most of these things are imported. Is that true?
Yes, a significant amount of our products are important. They are imported, as you
Okay, so-
mentioned. And I
Yes.
agree with you about the dangers of using the infant formula and the risk of contamination, because we know that powdered infant formula, they're not sterile. And so at times we have outbreaks, and that is why it's important that as a country we monitor the marketing of breast milk substitute, because of the danger that the contamination may cause to the child. As you mentioned, it may cause severe illness, which may lead to death if not treated early or effectively.
Okay, now the last comment, Miss, is that do we support a breastfeeding mother, a healthy breastfeeding mother, to help breastfeed other babies? Can that be done? Is this something that is known and can be promoted?
Okay, so as healthcare workers, as policymakers, we know that that is an option that could be considered. It is done in other countries. However, our local survey dictates that it's not culturally appropriate, and so it would not be accepted by our population. Based on assessment done in community pertaining to breast milk and even expressing breast milk, some fathers, for example, or family members believe that touching the expressed breast milk is nasty, and that is the milk of someone that they love, and they think that it's nasty, they don't want to touch it, and so it's an hindrance to continued breastfeeding even when mommy needs to go back to work. And so you can understand why, as a country, it would require a lot of education and a lot of cultural changes for it to be accepted. But at this point, it's not accepted by the general population.
Thank you for your presentation. God bless you.
And thanks for your questions. Any other question?
Yeah, a few more questions.
And just to note that I appreciate the engagement, as it's an opportunity to promote the word about breastfeeding.
All right, so a question online. Is there some form of testing done for each brand of formula product, especially those that are imported, post-imported?
All right, so testing of products, just to ensure compliance, that's usually done by the Bureau of Standards, where products are randomly removed from shelf and tested. However, because of limited capacity for products in general, not just breast milk substitute, it is not done as often as it should be.
All right, another one. Can you consider the policy document including withdrawal of ads that breach supporting breast milk use?
If that can be considered?
Yes.
Okay, so in putting together legislation, because we do not have a legislation as yet, then it would speak to that where current ads would be removed. Just to note, though, that even though we do not have a legislation in support of the implementation of the International Code of Marketing of Breast Milk Substitute in Jamaica, we do have a national policy on infant and young child feeding, which was approved by Cabinet in 2018, and it speaks to promotion of breast milk substitute. As a country, we also implement the Baby Friendly Hospital Initiative, and that is a national priority where we are having now most of our hospitals being certified. In fact, today, in the next hour at 11 o'clock today, we'll be having certification of Percy Junior Hospital. Right, now the National Infant and Young Child Feeding Policy and the implementation of the Baby Friendly Hospital Initiative ensures that all hospitals certified abides by the code. And so outside of the marketing on the media, it ensures that the representatives from the breast milk distributors, breast milk substitute distributors, are not able to go into the hospitals and have direct contact with healthcare workers and mothers to do promotion. It also ensures that the babies get the best start in life, which is breastfeeding, because it creates that supportive environment for it, and mummies get the best care while they deliver in our hospitals that are certified.
Okay, so a few more. Breastfeeding is the best. However, which one of the breast milk substitutes would you highly suggest to mothers who are unable to breastfeed because of various reasons?
All right, so we're not able to endorse a particular brand, but usually what is done during counseling, when a mother meets with her healthcare worker and she discusses feeding options, based on the decision, if a mother is not able to breastfeed, the healthcare worker will discuss the options with the mother. She'll also teach a mother how to prepare the breast milk. He or she would teach a mother how to prepare the breast milk substitutes, and based on their conditions, the condition of the mother, social condition, etc., they will together decide on the best options.
All right, so what are plans to support breastfeeding policies within the workplace?
Oh, I'm happy for that question. So the Ministry of Health and Wellness is actually implementing an initiative where we're promoting workplace wellness in general. And one component of that initiative is the promotion of healthy eating in workplaces, which includes a component on breastfeeding promotion and protection. And so we have been working with over 100 workplaces just to start, to help them to put things in place to support breastfeeding, including the implementation of maternity leave. And you know that as a country, we have endorsed paternity leave as well. Some workplaces have a space where mothers are able to express their breast milk and then store it so that they can take it home to feed their children. we have developed guides for the promotion of healthy eating in workplaces. And within those guides, we have outlined strategies that workplaces can put together or implement to support parents as they breastfeed. Now, as part of our workplace promotion, what we have recently done is that we have implemented sort of a corporate challenge for workplaces where we go in and we assess the healthy eating environment of those workplaces. And what we're moving towards is certifying workplaces as healthy eating promoting workplaces. And one aspect of that is whether or not they promote, support, and protect breastfeeding of their staff. And the workplaces will be awarded at the end. They will get a platinum or gold or silver certification or a certificate of commitment to the process. So as a ministry, as a body, we're working to work with the workplaces to put things in place to protect breastfeeding. And we have been able to do that through support from the workplaces as well as our international partners such as UNICEF and PAHO.
Hi, morning. All of that sounds lovely. And I want to add on to that. Is there anything in that policy or guidelines to promote or to encourage workplaces to have a place to encourage pumping?
All right. So I'd mentioned before that as part of the guideline where we look at strategies that workplaces can put in place to promote healthy eating or support breastfeeding, one recommendation is a room, which is a private room separate from the restroom, where mom can go express her breast milk or pump her breast milk. And so she would not be penalized in terms of getting a reduction in our pay for time taken off to do that expression. So we're working with workplaces for them to allow even a 15 minutes break where mothers can go and express their breast milk in that safe and private space where it can also be stored until she's ready to go home. Feel free to clap a little louder. All right. So, okay. See that we're going to be here for a while.
No, where are we with that policy internally?
Which one of the policies?
Within the nursing room then, or for breastfeeding or time.
All right. So we do not have a workplace policy. As yet, we're working together with the workplaces to develop a workplace wellness policy, which would include that component of it. So we have developed the concept, which should be submitted to Cabinet by our policy division.
Oh, so we're not able to implement that internally or cross-government until it's approved by
It's
Cabinet?
not mandatory as yet, but the workplaces are implementing it voluntarily.
Okay, thank you.
You're welcome.
All right, last one. Any strategies to engage our fathers more to support breastfeeding?
Yes, so we have a social media campaign or communication strategy for infant and young child feeding. And one focus of that, or one target group, is fathers. And so if you have been to Portland and some other parishes, you would see billboards with fathers, with messages for fathers to support breastfeeding. We also have within communities, community infant and young child feeding support groups, and we encourage fathers to be a part of it because we recognize that fathers play a very important role in promoting breastfeeding or ensuring that mommies breastfeed. Studies that we have done locally indicate that mothers listen to grandparents and they listen to mother-in-laws, and they're also influenced significantly by fathers.
All right, thank you.
You're welcome. Okay, thank you very much for your questions.
So thank you very much for joining us today. And at this point, we will break for commercials.
I was first diagnosed with cervical cancer at the age 33. The treatment was not pretty. It was terrible. I couldn't go to work, and I spent the whole 5 years out of work. The pain, the struggle, I removed my womb. I thought, I'm finished with cancer. 2016, cancer come back. There's hope for your daughter. My experience don't have to be her experience. So mothers, give your children the vaccine. It will be good for your sake and for the children's sake.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
I love my children, and I will do anything to protect them. So that's why, as a mom and as a doctor, I made sure that my daughter got the HPV vaccine to protect her from cervical cancer later in life when she becomes a woman. The HPV vaccine is very safe and effective.
I was afraid of the injection at first, but I got it and it really wasn't that bad after all.
If there was something you could do to protect your child, wouldn't you do it? Protect our next generation. Ensure that your daughter gets the HPV vaccine today.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
I want to see a Jamaica that is cervical cancer free. Cervical cancer is one of the leading causes of cancer in women in our nation, and I want this to stop. The HPV vaccine has been proven to be the most effective method to prevent cervical cancer. It is a safe vaccine, and it is best to give the vaccine to young girls before they've even been exposed to the HPV virus. So parents, I want to encourage you to let your daughters get the HPV vaccine. Let us protect our next generation against cervical cancer.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
Meet Jess. Jess knows a thing or two about her health.
Measles and rubella virus still circulate in the world, right?
Yes, Jess.
So could I possibly get sick if I travel to those countries and I am not vaccinated?
That's right.
Wow. We all need to be vaccinated on time.
She understands the value of vaccination.
Mommy, did you know that vaccines work to prevent 2 million deaths in children each year?
Wow.
Mommy, thanks for ensuring that I'm vaccinated.
You're welcome, Jess. Let's give our children the gift of health. Vaccines strengthen their defenses against harmful diseases for life. Get vaccinated.
A message from the Ministry of Health and Wellness and PAHO.
Your health is your wealth, so come we start the conversation. Make we rise and immunize all across the nation. The ministry is giving us the motivation to get your infants routine immunization. Protect the toddlers from all diseases. Tetanus, rubella, whooping cough and the measles. Polymyelitis, mumps and the flu, plus tuberculosis to name a few.
Rise to immunize. Eliminating diseases saves lives. Visit your nearest clinic or health center for more information or log on to www.moh.gov.jm. A message from the Ministry of Health and Wellness.
Vaccines are the safest, most cost-effective health measure, saving over 2 million lives a year.
Every year, over 1 million children die from measles, meningitis, and pneumonia.
Jamaica has had its own immunization program for a number of years, and because of that, our children have been living longer and healthier.
I'm a mother, and all 4 of my children are fully vaccinated.
It is our responsibility to ensure that every child is fully vaccinated.
Today, only 2 countries have wild polio.
If our children are not fully vaccinated, polio can come back.
Vaccination is a gift of love.
Do your part.
Get vaccinated!
A message from the Ministry of Health and Wellness and PAHO.
I was first diagnosed with cervical cancer at the age 33. The treatment was not pretty. It was terrible. I couldn't go to work, and I spent the whole 5 years out of work. The pain, the struggle, I removed my womb. I thought, I'm finished with cancer. 2016, cancer come back. There's hope for your daughter. My experience don't have to be her experience. So mothers, give your children the vaccine. It will be good for your sake and for the children's sake.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
I love my children, and I will do anything to protect them. So that's why, as a mom and as a doctor, I made sure that my daughter got the HPV vaccine to protect her from cervical cancer later in life when she becomes a woman. The HPV vaccine is very safe and effective.
I was afraid of the injection at first, but I got it and it really wasn't that bad after all.
If there was something you could do to protect your child, wouldn't you do it? Protect our next generation. Ensure that your daughter gets the HPV vaccine today.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
I want to see a Jamaica that is cervical cancer free. Cervical cancer is one of the leading causes of cancer in women in our nation, and I want this to stop. The HPV vaccine has been proven to be the most effective method to prevent cervical cancer. It is a safe vaccine, and it is best to give the vaccine to young girls before they've even been exposed to the HPV virus. So parents, I want to encourage you to let your daughters get the HPV vaccine. Let us protect our next generation against cervical cancer.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
Meet Jess. Jess knows a thing or two about her health.
Measles and rubella virus still circulate in the world, right?
Yes, Jess.
So could I possibly get sick if I travel to those countries and I am not vaccinated?
That's right.
Wow. We all need to be vaccinated on time.
She understands the value of vaccination.
Mommy, did you know that vaccines work to prevent 2 million deaths in children each year?
Wow.
Mommy, thanks for ensuring that I'm vaccinated.
You're welcome, Jess. Let's give our children the gift of health. Vaccines strengthen their defenses against harmful diseases for life. Get vaccinated.
A message from the Ministry of Health and Wellness and PAHO.
Your health is your wealth, so come we start the conversation. Make we rise and immunize all across the nation. The ministry is giving us the motivation to get your infants routine immunization. Protect the toddlers from all diseases. Tetanus, rubella, whooping cough and the measles. Polymyelitis, mumps and the flu, plus tuberculosis to name a few.
Rise to immunize. Eliminating diseases saves lives. Visit your nearest clinic or health center for more information or log on to www.moh.gov.jm. A message.
Can you hear me now? Good morning, ladies and gentlemen. Welcome back to the special abstract presentation on AI and robotics in healthcare. I am Nastasia Sanko, a digital health analyst in the Ministry of Health and Wellness. The special abstract presentation is a unique segment where we highlight technological advancements in public healthcare. Our presenter this morning is Joel Christian. Mr. Christian is the co-founder of Elecare, where he leads client relations and implementation. He ensures the digital transformation journey is human-centered and impactful. He believes that technology should not only improve how we work, but how we live. Elecare was a solution that he created with childhood friends who shared his vision. Mr. Joel Christian, ladies and gentlemen.
All right. Good morning to members of the Ministry of Health and Wellness, my fellow researchers and clinicians. Thank you for the opportunity to discuss the ELICARE journey and how we are working together to strengthen Jamaica's digital health maturity. My name is Joel Christian, and I'm the co-founder of ELICARE. Today, I will speak about three things: the current reality that our clinicians are facing, how the AI-powered electronic health record system we created addresses these realities, and how we can collectively scale this nationally. I will start with a story from a general practitioner out of St. Anne, who I will call Dr. Lewis. Her typical clinical day starts with managing two patient registries, transcribing lab results by hand, and at the end of the day, spending about 2 hours reviewing her notes. This is not a unique situation to Dr. Lewis. A lot of our systems across the Caribbean still operate at a level 2 and 3 on the PAHO maturity scale, and this leads to clinician burnout, mistakes. This leads to clinician burnout, preventable mistakes, and systems that can be prevented. The most up-to-date data is not accessible because of these reasons to our health officials. So when interventions are being planned, they don't have the most up-to-date information to guide their interventions. ELICARE was founded because we believed that Jamaica can leapfrog directly into integrated and intelligent care without having to wait decades for incremental changes. Our vision is simple. We believe that every medical interaction should automatically produce structured, analyzable data which give clinicians more time at the bedside. To achieve this, we needed a platform that integrates all the current workflows that practices go through on a secure cloud platform. But technology like this, the tools are not enough. We also needed to integrate AI that meets clinicians where they are, respects data privacy, and also follows the governing structure of the PAHO regulations. We approached the design with 3 steps. First was to augment the clinician, which consists of using AI transcriptions to move from written notes to automated notes so clinicians don't have to spend time writing and more time listening. The second was to harmonize the operations of practices, which was the aforementioned tool that unifies all the operational aspects of the practice and allows hospital administrators and financial officers to have that same source of truth to work from. The third is activating the patient, and it is provided through telemedicine, secure messaging, and a patient portal that works even on low bandwidth. ELICARE was designed to be encrypted, and it is hosted on the AWS in the Caribbean region, and it is role-based, and the permissions are granted based off of user, which allow us to remain HIPAA and GDPR aligned and also help to respect the Jamaica Data Privacy Act. The work submitted to the National Health Research Council was a comparative study. So we took the PAHO's maturity level and mapped it against the ELICare features and noted how our technology will help to move practices from a level 2 to 3, from a level 2-3 to our level 4+. We used the data from our pilot practices to cross-reference information from documentation timelines to revenue cycles and every inventory shrinkage reports. The analysis shows that ELICare helps documentation process to drop from about 60 to 80% because of the end-to-end voice-guided notes. Administrative operations are reduced costs-wise by 20%. The throughput for clinics are improved by about 40% because the staff spends less time trying to reconcile disparate systems. Most importantly, though, the data exhaust from every visit becomes research-ready, de-identified, codified, and accessible to authorized partners. That means our epidemiologists, health economists, and medical schools can finally analyze data in real time rather than waiting weeks and years. Technology alone, we know, will not deliver these numbers at scale. We also learned lessons about change management. And in the first 90 days of our pilots, we embed our team with the physicians, nurses, and co-design note templates, run evening office hours to ensure no one is left behind. We also work with practices to invest in education around data stewardship, defining who governs the terminology and technology, and who has access, how patient content flows, and how do we escalate privacy incidents. So the partnerships that we have that give us confidence in this solution, one of which is the CSMSJ, which use ELICare to train the next generation of physicians in digital-first care. And together, we are not just a software, we come in and we help the students learn the technology and how to manage patients and be prepared for the medical future. This system keeps practitioners medically aligned and policymakers informed. Today, we are asking for two things. First, to continue to treat digital health maturity as a national health priority, and to help ELICare extend its pilot program. With the support of the NHRC, we can bring level 4 capabilities to rural clinics and maternity wards and specialist centers that are often left behind from digital conversion. Oops. So I will finish where I started with Dr. Lewis, who told us that if I can finish my clinic on time, document accurately, and know that my data is helping inform national policy, then AI is not just a buzzword to her, it's a lifeline. And that is why we have built ELICare, so we can provide this lifeline to all clinicians, so we are able to show the wider Caribbean and the world what patient-centered care looks like and how we can revolutionize care. So thank you for your time. And I welcome your questions.
All right, so first question, is there a backup system for the data collected?
Yes. So the data is automatically synced to our servers every day, and backups are made every 60 days as well, in perpetuity. So there are direct images of file systems that are saved on our database that are accessible by the required practices, if anything were to happen.
All right, Dr. Alonge has a question, so she will go ahead and speak.
Okay, thank you. Thank you very much for your presentation, sir. Please, the question I have has to do with the issue of data. And you said it's backed up. And what about the protection of the data from being hacked and the information that is stored being utilized by others globally?
I barely heard your question. Could you repeat
Okay.
or type it in the chat? Maybe someone can read it for me, please.
Can you hear me? Is it better now?
Maybe just type the question in the chat. I think someone could read it for us. Not really hearing you very clearly.
Anybody
All right.
hearing? I'm asking hacking.
Yeah, so your
data.
question was around data
Yes.
security and the backups, hacking,
Yes,
and how
as well
that is
as-
prevented. Yes.
Yes.
So we utilize Amazon Web Servers, which has their own in-depth security as well as our own security measures to help secure data. So everything is encrypted. Information isn't stored plainly. There is measures in place to help anonymize data, and data isn't revealed until it is actually at the person's machine and their account has been verified, and then the information is decrypted and they're able to view it. So all the information is encrypted.
Hi, morning.
Morning.
Dr. Garvan from Health Informatics Unit in the MOHW. So you had mentioned that the data is structured, analyzable data. How is it structured in terms of, well, let's just leave it here. How is it structured on the back end?
When you say structured, in terms, well, it's de-identifiable. So it's, the information is, so if you have the patient information is stripped of all the personal data, and it only has the results and the conditions. So it's, when in terms of structure, is that what you're talking about in terms of identifying who it's associated with?
No, I was thinking more the clinical data.
Mm-hmm.
How is that structured and stored? Is it free text? Is it coded? If it's coded, what are the coding system or systems used?
Well, it would be coded and encrypted, and as I say, it's only accessible through people who have specific permissions. So once someone is granted access to that information based off of any partnership that that specific institution has with that person, then they're able to access that information and see it as text.
Okay, I do have another.
Well, and in terms of building it out as well, things like graphing and statistics can be drawn from that information as well.
In the global digital health space, a lot of work has gone and research around digital health standards,
Yes.
like, you know, HL7 Fire, Open Air, SNOMED CT, and etc. What are the standards, the digital health standards that you are familiar with, and what are the standards that Elicare supports, if any?
Okay, well, we go by the GDPR and HIPAA compliance, and the Jamaica Data Privacy Act are the main things that guide us. The technical team would probably have more answers around what specific security measures they use, but I know those are the main ones that we have used to guide how we make sure accessibility and anonymization of information is handled.
Okay, thank you.
Yes. Sure.
Good morning. My name
Good morning. Oops. Sorry.
Yep. Leslie Ann Wilson. I'm the Acting Director for Strategic Health ICT here at Ministry of Health. I do have a question around patient consent.
Yes.
So do you have, forms or protocols that are able to capture patient consent, and how is that stored and managed? In relation to the Data Protection Act, they can revoke consent, etc. So do you have that mechanism within Elicare?
Yes, so we work with practices to find out what their onboarding flow is and ensure that patient consent is a part of that. And we have a form system that allows patients to fill out forms and grant consent. And that same system allows them to also reach out to say, okay, we don't want to have this information with you anymore as well. So they kind of create an account with their practice and their doctor, and there's a front end that we have developed, which is like a patient portal for patients to use and have their information and be able to speak with the practices that they're engaged with. So they can speak with them in terms of revoking and updating privacy requests in that way.
Okay, and one follow-up question to that. You mentioned a patient portal.
Yes.
Could you give us an idea of what kind of information is visible to the patient on that portal? And is that something that they can share with others, for example?
Well, it's shareable with their doctors. The information that's there is more geared towards medication reminders, being able to track your health and stuff. So it's more about personal care. And when a doctor partners, so if your doctor uses Elicare, they're also able to share results and certain files with you. But the sharing of the files is really up to the doctor as well. He chooses what he wants to share with you. And if you need to come in, you need to come in, and he says that. But it's more geared towards your personal health and well-being and tracking statistics, and also being able to send notifications to your doctor as well if analysis of your results look off.
Okay, thank you.
All right, so a few questions online. First one, what would be a realistic timeline for a hospital operating solely on paper records to achieve full implementation of an electronic health record system?
Hospital, I guess they have various sizes, but I think maybe 6 months to a year, depending on the size of the hospital. We have equipment that does scanning pretty quickly, and that is digitizing, and the AI is able to read these documents and pick out the information and parse it and sort it. So the act of scanning also indexes the information, so it's not necessarily too much of a manual process to put everything in the right place. So I would say with training and coming in and the size of the documentation, where they're fully paper-based. So yeah, I would say about 6 months to a year.
All right, thank you. All right, next question. How compatible is this with other existing electronic records, and how does it pull in laboratory and radiological reports?
Okay, so it is something that we built from the ground up, and that means that we are able to create API calls and processors that will work with any kind of health records system that you may want to integrate with, as long as they are open to sharing information with third parties as well. And since being built from the ground up as well, we have full control over the technology, which allows us to now integrate with these machines. So yeah, So we see what the models of the machines are using, and we are able to build technology that can communicate with the machines and pull over the images into the software.
All right, thank you. All right, next question. Why a cloud-based system and not a server stored locally in a secure network or cluster, and how are online entries accommodated or offline accommodated?
Online is traditionally more secure, especially with physical things, especially like the hurricane that happened. We wouldn't want to have that kind of risk where all the information is in a place that can actually be destroyed. So we prefer the cloud-based for that reason. And what was the second part of the question? Sorry.
Or offline entries accommodated?
Okay, and offline entries are accommodated, but they currently aren't accommodated for certain parts of the app, but we are currently working on a mesh system that will allow devices to talk via Bluetooth and information to be stored that way. So when you do regain connectivity, it will be transmitted into the cloud.
All right, thank you. Next question. Who will own the data once it is stored on the servers?
It is owned by the practices and the clinicians. We don't take ownership of the information.
All right, another one. With AI already disrupting jobs in the fields like modern languages through tools like advanced translation softwares, what assurance or strategies can we as healthcare workers rely on to ensure our roles aren't eventually automated or disseminated or diminished by these technologies?
We personally don't view AI as a replacement. We use words like augmenting, which means help the clinicians do their job better. I don't think we'll ever reach a place where these are fully replaced by doctors. I think everyone should view it as a tool that helps you to do your job better, reduce burnout, paperwork, help you to do research more efficiently, to treat more patients. All the practices we've been to so far really don't view it in that sense. They really are, they seem overwhelmed genuinely and welcome the opportunity to work more efficiently and serve more people actually. So that is kind of how we view AI and how it works with doctors, as a augmenting kind of technology instead of a replacement.
All right, thank you. How dependent on the internet is this system?
Well, it is dependent on internet connectivity, and we do work with practices to go online in terms of having redundancies, like having Starlinks, and to also address that. I think I earlier mentioned that we're developing a mesh system that works with Bluetooth, that stores information encrypted across devices, that when connectivity is reestablished, it can actually beam back up to the internet and the servers, but it can still work within your hospital mesh, is what we call it, and it can communicate with the devices in your area.
All right. Can patients opt out of the use of AI in their clinical care?
Yes, so I mean that would be a conversation with your doctor to say what tools you're comfortable with them using and not using. I guess similar to what medications you would rather not want to be on.
Question, is there a website can people
Yes.
observe our use?
So elicare.ai is the website that you can find us on.
All right, thank you. That's it for the online.
One more question over here.
Okay, I have another question regarding the AI.
Sure.
So, I'm kind of curious, what you would have used to train your AI, and who has access to that kind of training data? So, is it like a popular or a common AI that's used out there that is accessible?
It's a combination, actually. So it is We have the APIs to the different AI models that we use, and we conglomerate them basically. And so basically when things are put in, they are referenced across different AIs, and the results are compared. And we also have medical journals that are also inputted into the system as well to help train it. So it's kind of like a robust solution, not dependent on one model, but trying to use as many as possible that we feel are good at medical care to kind of give you the best result out of the results that the AI kind of spits back out at you.
Okay, so the underlying data that the AI would have, learned and store, and it's processing this data as a part of how it works. Is that data accessible by any other system externally anywhere, or is it only within the Elicare solution?
It's only within the Elicare system. So as we kind of use it at a kind of like a base API level, where we just so we have multiple of them, and then it comes into our system, which is where the actual computation and everything happens, and then those are also trained by medical journals as well. So it is really our kind of proprietary, I guess you could say, AI that is a combination of multiple things.
Okay, thank you.
You're welcome.
All right, one more question for online. Can the data at Elicare identify disease outbreaks before it is identified by doctors, or even where it might have originated from?
Yes, so once we have widespread adoption of this, that is what these things really will help us with. Once people are putting information into these systems, being able to track things in real time, we're able to now triangulate where sources have come from, and be able to just have that much more information to deal with outbreaks early. Yeah.
All right, thank you.
Thank you for joining us, Mr. Christian, and thank you for your presentation. Thank you for joining us, everyone. We will now take our coffee break.
understand how visually challenged I am, you know. If needed. Okay, so.
Good morning, everyone. Welcome back. And this is Scientific Session 4 on AI robotics in healthcare. My name is Leslie Ann Wilson, and I am the Acting Director of Strategic Health ICT in the IS4H branch at the Ministry of Health and Wellness. So for our session now, we will have 3 research presenters during this session, and they will present first, and then there will be a combined question and answer segment at the end. So each presenter will move seamlessly from one to the next. Allow me the distinct pleasure of introducing our presenters for this section. So our first presenter will be Ms. Shauna Rose. She is a health records technician at the University Hospital of the West Indies. Shauna is a student in the College of Health Sciences at the University of Technology, where she recently completed the Health Information Technology course. She is a God-fearing mother and a Sunday school teacher. Ms. Rose believes that when you put God first, all else will fall in place in His perfect timing, because with God, everything is possible. Our second presenter will be Ms. Jada Howard. Jada Howard holds a Bachelor's of Science in Computer Information Systems from the University of Technology, where she majored in technology entrepreneurship with a minor in data analytics. Ms. Howard was a 3-time Dean's List recipient and Most Outstanding Student awardee. She placed second in the 2025 Sagicor Innovation Challenge for leading a team that developed a LiDAR-based AI crash detection system to improve emergency response coordination. In 2024, she was ranked in the top 10 of the Huawei Seeds for the Future Tech for Good Latin America Challenge with a project focused on improving public transportation logistics. JADA has a strong interest in how digital innovation can strengthen national health and emergency systems. And last but not least, the thorn amongst the roses, as some may say, Mr. Amoy Thomas is a dedicated data science and public health professional pursuing a bachelor's degree in data science while concurrently, at the same time, completing a master's in public health. He has a strong interest in applying data analytics, machine learning, and artificial intelligence to strengthen national health surveillance and support evidence-based decision-making. Amoy is committed to advancing public health innovation in Jamaica through data-driven insights and modern digital tools. Please make them welcome. Ms. Rose.
Thank you. Good morning, everyone. All right, so our judges, organizers of the conference, other members of the Ministry of Health and Wellness, the media team, specially invited guests within this space, as well as the online platform, pleasant morning to everyone. My name is Shauna Rose, and it is my pleasure to present this research today entitled The User's Perception of the Jamaica Healthcare Reporting and Visualization System, Jarvis. Permit me to acknowledge my colleague, Ms. S. Bryan, and our co-author, Dr. Haleberry. All right, so this study was conducted at two of the largest healthcare institutions in Jamaica, namely the Kingston Public Hospital and the Jubilee Hospital. And it was done with the aim of investigating the user's perception of the Jamaica Healthcare Reporting and Visualization System, Jarvis for short, its effectiveness in supporting healthcare decision-making, enhancing statistical systems, improving patient care, as well as enhancing patient care outcomes. Right? And who best to gather this information from than the persons who use the system themselves, right? All right, so by gathering insights from the system's users, this research should assist in the continuous development and the improvement of the system, which is expected to further enhance healthcare in Jamaica. All right, so the background to the problem. Jarvis is meant to be a web page application which has been designed to facilitate entry, storage, and analysis of statistical and medical record case abstracts, and this is according to MOHW 2021. Jarvis was implemented in 2020. It was developed in 2018, but it implemented in 2020 with the aim of enhancing statistical reporting as well as healthcare data management in Jamaica's healthcare delivery system. Among emerging concerns regarding Jarvis, however, is that there were delays in generating reports. They had errors in statistical reports, and the adoption rate was minimal. All right, so as aspiring health information technicians, curious minds, we wanted to delve into some of the issues with the hope that by the time we are back in the system, and because we might be assigned to use the system, so we're hoping that by the time we're able and by the time we're assigned to that, then some of these problems will be minimized or eliminated. All right, the study was done with the following objectives in mind: to determine users' perception of the user-friendliness of Jarvis, to determine the extent to which users believe the system improves their ability to access, understand, and act on healthcare, as well as to determine the users' views concerning Jarvis and its impact on the statistical reporting system. Our literature review. The Jarvis was developed by the Ministry of Health as a part of the Electronic Health Plan of Action, with the key features being real-time data, which means data is supposed to be updated instantaneously, and this helps to support decision-making. Another one is that it should help in disease surveillance, which would highlight and track the outbreaks and other public health threats, which give room for rapid response. Data analytics component, which is used to analyze data to make it more easily understood. The Jarvis has a visualization component, which utilizes charts and maps to display healthcare trends. There are several benefits to the system, and this includes, but not limited to, data-driven insight for stakeholders and policymakers, and this is according to Ministry of Health and Wellness 2020. The main goal of Jarvis, however, is to offer instrument for inspecting, evaluating the performance of specific facilities over the country's overall healthcare. The benefits of this system, as well as other visualization systems, include more informed decision-making, improved disease diagnosis and surveillance, enhanced patterns of detection and trends, and also to reduce errors in data collection and data statistical reports. All right, so generally when persons have a system that they can trust, data quality improves, and it allows for more accuracy and better analysis, and even better allocation of resources. But if we do have a system that you can't put your trust in, or it's unreliable, then you're not going to be so confident, and sometimes things will get overlooked and irregular updates and distorted statistics. All right, so methodology, that was used is that we conducted using a 15-item questionnaire, 13 of which were closed-ended questions and 2 open-ended questions. The population for this study consisted of 15 Jarvis users from the 2 major institutions. And because the population was rather small, we used a census sampling to capture the information from the users of Jarvis. All right, small-scale study with only users of Jarvis, total number of participants, 13, 77% of which were health records technicians, and the other remaining percentage were health record administrators. All right, so as per appendix, the following questions were asked and the information gathered. Training modality for users of Jarvis, of which over 30% said in-office training that was led by the supervisor. Users' perception of the adequacy of the training. So most of the persons thought that the training was fairly adequate, but there was a minimal percentage that said it was inadequate. Ease of navigation on the platform. Over 50% of the persons thought that it was fairly easy, but that was very easy, it's just a small percentage, and percentage thought that it was difficult. All right, so the key findings of this study were that the data entry in Jarvis was time consuming. There was also issues with login credentials, as the system was unable to accommodate new users, and this resulted in the sharing of particular passwords to access the system, and we all know that can be detrimental because that is a breach of confidentiality and a breach generally under the Data Protection Act. Some persons also said that data often disappeared and they were unable to retrieve data for research and statistical purposes. There were also missing data fields, and the ability to access some components of the system was also an issue. All right, so in the literature, Abu Diab et al. 2022, the name of the literature is Visualization Techniques in Healthcare Applications. So the author highlights that the benefits of visualization systems, which include better or informed decision making, improvement in disease diagnosis and surveillance, enhancement in pattern detection or trends, as well as mitigating errors in data, and by extension, the statistical report. The benefit of Jarvis could be similar if the system is improved. When consumers trust, as I said before, an efficient system, then there will be improvement in reporting data quality and also resource allocation. All right, so in order to improve the system, we have come up with the following recommendations. And some of these are to conduct regular audit checks. By conducting regular audit checks, then this will ensure that the guidelines of the Data Protection Act is maintained at all times. Increase the allotted funds. Additional funding could be earmarked for the improvement of Jarvis. This way, when the challenges arise, the funds are already secured and in place to have the problems rectified. We also think that the network could be broadened to accommodate more end users, and this should eliminate the issue of login and password sharing. Regular systems and software checks. That's another recommendation, and also we believe that further studies to see if other regions are having the same issue could be continued, and for us to get a better idea as if it's just contained within the two institutions that were mentioned, or it is a countrywide problem. All right, so in conclusion, while the findings have not reflected the vast problems that were previously highlighted by the users of Jarvis, and some of the users were able to execute their functions, there were still challenges that needed to be addressed, mainly information system updates. And we believe that it is imperative that the recommendations be considered to promptly address the challenges that were identified in order to maintain the effectiveness of Jarvis and to improve the efficiency of the statistical reporting system. Thank you for listening.
Good day, ladies and gentlemen. My name is Jada Howard. Firstly, I'd like to start off by thanking the Ministry of Health and Wellness for this opportunity. My team members and I are very grateful for it. Now into our presentation. The title of our research is Acceptability of Online Hypertension Health Education with Student-Led Interventions. Now, the background. Hypertension has been linked to health conditions such as cardiovascular disease and is said to cause 20% of death globally. In Jamaica, in 2017, stroke, which would have been caused by hypertension, was one of the leading causes of death in the country. However, hypertension does not always lead to death. Studies have shown that when individuals become educated on hypertension, they go to a doctor and they get medication, and they oftentimes change their lifestyle practices. This is where digital health interventions can come in, or DHIs for short. This offers a promising solution for hypertension education and self-management through technology-enabled support and monitoring. The research problem statement. There's a need to determine the acceptability and effectiveness of educational DHIs among hypertensive patients and university student family members, as well as to explore the barriers and facilitating conditions to their adoption in Jamaica. The purpose of the study is to determine how acceptable and practical it is to utilize educational DHIs in addressing hypertension management among Jamaican hypertensive patients with university student family members. The purpose is also to explore technology adoption factors and implementation strategies for effective educational platforms for hypertension. Research questions. We have 3 research questions. The first one is, what is the extent of technology acceptance among university students who will use educational DHIs to assist their Jamaican hypertensive family members? The second research question is, what is the extent of technology acceptance among Jamaican hypertensive patients to use educational DHIs for their hypertension? And the third research question is, what are the barriers and facilitating conditions to the adoption of educational DHIs for hypertension in Jamaica? The significance of the study is this study highlights the impact of hypertension on Jamaican patients and their families, as well as to assess technology acceptance among our focus groups, and the study also aims to develop a culturally appropriate educational DHI. Now onto methods and procedures. The study was conducted with a cross-sectional study was conducted with mini software development. As for the population for hypertensive patients, in a 2016-2017 survey, it was reported that 1 in every 3 Jamaicans have hypertension. For the university student relatives, we used the students from 2 prominent Jamaican universities, one being University of Technology Jamaica, which has approximately 11,000 students, and the other, UWI Mona, which has approximately 17,000 students. As for the healthcare professionals, it's approximately 9,000 healthcare professionals in Jamaica's public sector. For sampling, for hypertensive patients and university students, we used a quantitative convenience sampling method. We anticipated 100 responses from each group respectively, but for the patients, we received 69, and for the students, we received 74. For healthcare professionals, we did a qualitative sampling method with interviews, which we interviewed 5 healthcare professionals. For the data collection instruments, we used an electronic questionnaire for both the patients and university students with a modified UTAUT 2 framework. And as for the healthcare professionals, we did semi-structured interviews. Now onto the methodological limitations. The study has limited ability to generalize due to the small sample size and that we use convenience sampling, as well as cross-sectional studies cannot capture long-term trends, and there may be some reporting bias from data collected from the questionnaires. For our prototype, we developed a educational DHI that can basically teach people about hypertension. Here you can see the home screen as well as the login and the dashboard with all the different courses. People can then see the definition of hypertension, and there's also a link that carries you to the original source data. There is also a quiz you can take, and after doing the quiz, you receive answers from the quiz. Then if you successfully get 80% or more, you will then get a certificate, and there's also an AI chatbot that is designed to only answer questions on hypertension. On to the results and findings. Now, before getting into technology acceptance, let's first look at the demographics of our participants. For the patient's demographic, the majority was female, and they were between the ages of 50 to 69. For student relatives, the majority for the gender was female, and they were between the ages of 18 to 29. Now, this figure here represents hypertensive patients' intention to use online health education for hypertension broken down by age. Now, patients 40 and under showed less resistance to using the online health education tool, whereas patients 50 and over, they were very resistant to it. This could be due to a lower digital confidence in older people. This figure looks at if patients felt like they would receive help when using online tools. Most patients agreed that they would have assistance from family members or caretakers when it comes to using online tools. This helps to make digital health interventions more feasible for the targeted group. Now, This table represents university students who have hypertensive relatives and their willingness to help using online tools. 75% of students either agreed or strongly agreed to willingly help their family members. This table right here shows the statistical relationship between different factors and patients' intention to use the app. We see positive correlations between behavioral intention, performance expectancy, effort expectancy, facilitating conditions, social influence, behavioral expectations, mobile literacy, and mobile self-efficacy. This shows that patients are more willing to use digital tools when they feel capable, supported, and convinced of the benefits. Similarly, with the students, behavioral intention was strongly linked to performance expectancy, effort expectancy, facilitating conditions, social influence, as well as behavioral expectations. This shows that students who believed the app would be helpful, easy to use, and felt socially encouraged were more willing to help their hypertensive family members. We also spoke to some healthcare professionals, and they agreed that they do think the app has the ability to help hypertensive patients, and they also suggested that we have a daily logging and reward system to keep people interested in using the online tool. They also said that the design for it needs to be simple, and we should address any access issues before real-life implementation. On to conclusions and recommendations. As for the technology acceptance among university students who are willing to assist their hypertensive family members, over 80% showed intention to use their educational DHIs, indicating high acceptance and readiness to assist relatives. This could be due to the tech-savvy nature of university students. As for the patients, acceptance was low to moderate in comparison, with only 1/3 of patients being willing to use educational DHIs. However, the positive correlations with behavioral expectations and mobile literacy suggest that targeted training could help to improve acceptance levels. And as for the barriers and facilitating conditions to the adoption of educational DHIs for hypertension in Jamaica, major barriers would include limited digital skills, poor access, and the need for a culturally relevant and simple design. Facilitating conditions would include support from healthcare professionals and family members. Recommendations for the practice would be to integrate the app into clinical health education programs, and recommendations for future research would be to conduct a longitudinal study to assess long-term engagement and health outcomes of hypertensive patients that use the app, as well as to replicate the study with a larger sample size. Thank you.
Good morning, everyone. I am very nervous. Let me start off by saying that, but they say if you're nervous, just look in the crowd, and if you find a familiar face, you should be okay. Plunkett, can I look at you? All right. So the PowerPoint presentation will be short. I was hoping to do an actual demonstration of the development. Hopefully, we can get it done afterwards. All right, so this PowerPoint presentation, all right, the background is on AI-guided predictive mapping and surveillance. And this is, of course, of NCD hotspots in Jamaica. Non-communicable diseases are the leading cause of morbidity and mortality in Jamaica. High prevalence of hypertension, diabetes, and obesity, alongside major behavioral and metabolic risk factors, has been documented among the Jamaican population. Recent national estimates indicate persistently high NCD risk, with approximately 61.1% of Jamaican adults classified as overweight or obese. Non-communicable diseases impose a major burden on health systems, increase healthcare demand and cost, and reduce economic productivity, especially in low and middle income settings, where preventative and surveillance capacity is limited. So, why this project? Existing surveillance systems are mostly retrospective, facility-based, limited granularity for local hotspots, delayed response to emerging NCD trends, reduced effectiveness of targeted interventions, resource constraints and geographic disparities. Artificial intelligence holds great promise to improve public health functions, include predictive analytics and decision support, when deployed responsibly, of course, within ethical and the governance frameworks. Aim and objectives: build a voice-enabled AI-powered web platform to predict and map NCD hotspots across Jamaica. Objective: integrate geospatial data with predictive models to identify population and individual level risk. Provide interactive GIS maps, risk dashboards, and of course, voice-driven summaries for hands-free use. Design a modular, scalable system suitable for low-resource environments and Ministry of Health and Wellness integration. Supervise machine learning pipeline trained on a geocoded 5,000 record dummy dataset. Right? This is a simulated NCD prevalence, demographics, socioeconomic status, environment, and healthcare access. Right? Never utilize real data. Right? We just wanted to prove the concept, and so we created synthetic data. Right, and we trained the model. Of course, we cleaned, standardized, and geocoded performance with this in Python. Right, random forest classifier was utilized with spatial analysis, stratified cross-validation to evaluate performance, predictive risk scores for hypertension, diabetes, asthma, and cancer. And of course, deployed as a web app with interactive GIS and natural language voice assistant for spoken queries. Findings: model prototype achieved over 85% classification accuracy on test folds. Predictors with strong associations, household income, healthcare access, population density, environmental exposures. Risk maps highlighted underserved rural and urban periphery hotspots for targeted intervention. Individual level risk profiles enabled stratified outreach and resource prioritization. Interactive GIS map with zoomable layered views. Voice-enabled assistant for hands-free queries and spoken summaries. And of course, the dashboard, aggregated indicators, trend graphs, hotspot alerts, and patient-level risk lists. And of course, we have the feature to export, whether by CSV or PDF. Implementation steps from prototype to deployment. Data partnership with Ministry of Health and Wellness. Secure de-identified datasets and metadata. Model retraining and validation on real-world data, external expert review and bias audit, user-centered testing with Ministry of Health and Wellness staff and field teams, pilot deployment in selected parishes, monitor, evaluate, and refine, scale up, integrate into national surveillance and training for Ministry of Health and Wellness personnel. The benefits to the Ministry of Health and Wellness in Jamaica: early detection of emerging NCD hotspots, provides targeted interventions, efficient resource allocation, supports evidence-based policy, planning and localized prevention campaigns, improves equity by identifying underserved communities and enabling targeted outreach, builds national capacity in digital surveillance, and sets a regional blueprint for the Caribbean. And of course, this is where I should demonstrate my application, but we're not able to at this time. And so these are my references. Thank you very much.
All right, let's have another round of applause for our presenters this morning. Miss Rose, Miss Howard, and Mr. Mr. Thomas. All right, so now we're going to open the floor to questions from the room and from online. Any questions? Some technical difficulties.
Can I? Oh, can hear. Okay, great. My question is for Mr. Nervous. You did quite well. I think you did quite well. It didn't show. You're an excellent presenter, I think. You spoke well.
Yes, thank you.
So I'm curious as to how would you get backtrack. Most of our institutions are paper-based for now.
Yes.
So how are you thinking of getting that data from the paper into this tool?
All right. So essentially, it would have to be a national effort. The idea is to carry out screenings, right, and gather the data into CSVs, right? If you're talking about information that is already on paper, we might have to consider getting data entry persons. We could get those persons to enter the data, along with other public health professionals who can also validate the information that has been entered, right? So we can then get the correct data to train, so we can able to develop the proper model and so forth. Yes.
All right, Mr. Thomas, good morning. Dr. Campbell here. All right, your report on a geospatial data set of 5,000 records.
Yes.
All right, but can you say what specific variables were simulated?
Okay. Yes, I can do that. So, by the way, I must say, I'm not seeing Mr. Burrows, he's not here, but when he came by the Southern region to do a training, he was able to provide me with some shapefiles, and that was instrumental in developing this application. Now, in terms of the parameters, separate apart from the shapefile coordinates and so forth, we have parameters such as distance to clinic, right? Distance to hospital. We have the age. We have the sex, right? We have household income, right? We have education level. We have industrial exposure. We have traffic density. We have air quality index. We have green space index, water quality index, persons who have health insurance, healthcare access, persons who smoke, alcohol use. We also have physical activity, diet quality. So we have a lot of parameters that we utilize in the data set.
Right, and I guess you'd have to have some distribution in the model, right?
Yes.
So how were these distribution chosen to match Jamaica's demography?
Okay, so essentially, we would have researched online, right, and utilizing different papers that speak on NCDs and the different factors that contribute to NCDs and so forth, and then we're able to actually simulate, based on that information, what it would be like in the dummy data set. Yes.
Also, you reported 85% classification accuracy.
Yes.
Was this broken down by disease? Did you check for sensitivity or specificity?
All right. So currently the application targeting only 4 NCDs at the moment, right? And as a matter of fact, my abstract said 85%, but afterwards I was able to actually retrain, and I was able to get like 90%, over 90% in each model for each NCD.
I thank you for that. Miss Rose.
Okay. All right.
All right, you report that data entries disappeared. Were you able to quantify how often they disappeared?
Well, some persons reported that monthly when they were there to generate their reports, that the information that they know they had sent in, they couldn't find it.
All right. Were you able to identify like technical failure modes, like why they could disappear, possible session timeout, drop network, or database transaction failure? Because we want to know the root cause, why they are disappearing.
Well, there were no specifics to say that they thought it was because of session timeout. That was not mentioned. Maybe we could have asked specifically, or to get some more information as to why.
All right, thank you. Ms. Howard. All right, for me, it was unclear how the data was collected, meaning how the data tools were administered, meaning how did you find the 74 students with hypertensive relative and the 69 patients?
Well, my team and I, we went to school and we just walked around school and we asked people if they would like to fill out the questionnaire, basically. And we also we asked people that would go to UE, because we go to UTech, but we also know people that go to UE. So, yeah, just send it out.
All right, so you use the UTAU T2.
Yeah.
I think you could have...
You taught.
You could have said what it is. And the health belief model. Were these scales adopted or psychometrically evaluated in the Jamaica sample?
Sorry, can you say?
Are they validated to be used in Jamaica?
To be used in Jamaica?
Did you check validity? Did you do comeback alpha or factor analysis?
We consulted our supervisor, and I think it is okay to use in Jamaica. Yeah.
All right, thank you.
Yeah.
Good morning, everyone. My question is for Ms. Rose. All right. Thank you so much for your presentation.
No problem. Thanks for listening.
Okay. As it relates to the Jarvis,
yes.
No, you might have said it, but I'm not sure if I had heard it. But what specific design, or in terms of the changes, would you recommend to make data entry in Jarvis more, less time-consuming for healthcare workers?
All right, so a design, the visualization system could be updated in terms of, well, it wasn't specific to say that this part of it, they didn't specify to say which part of it was actually time-consuming, in that to put in the data, or maybe they have had too many fields or or they needed more fields, right? So maybe we could investigate further to see exactly why they thought it was time consuming, if it is that it need more fields to be placed on the dashboard or wherever it is that they enter the data, or whatever else the issue might have been.
Thank you so much.
You're welcome. Thanks for your question. Any other questions?
Yes, a question online from Dr. Alangi. So she'll unmute.
The quick question I want to ask Miss Rose.
Okay.
Would it have been a case of, Miss Rose? Would it have been a case of the education level of the people or their location?
As it regards to the data entry being disappeared?
Yes.
Well, the majority of the persons said that they were adequately trained, so I'm not thinking that it has anything to do with the education level. However, we recommended continuous training because some persons are not so much technologically inclined and could use further training as it regards to the entry of this data as well.
Okay, were they saving the data? Because it can just disappear. That's why I asked the question.
Well, as I stated before, maybe they didn't say if it was, as Dr. asked earlier, if it was because of a timeout or other specific reasons why the data was disappearing. So I can't specifically say that it has anything to do with the education. But it doesn't hurt to get a little more extensive training in that regard.
Can I say that the AI took away their data?
You can say, but I can't confirm.
So that's a joke. All right. So the next one is my friend, Mr. from the Ministry of Health, sir. The quick question I have for you.
Yes.
Just give me one summary of what you found out with your data of presentation.
Okay. So in terms of a summary, I would say that the models they worked, and of course over 90% accuracy, and of course the application was developed successfully. I would say the project was a success, and if implemented, it would make a change not only to Jamaica but even the far-reaching Caribbean and the entire world.
Thank you.
Yes. Oh, Mr. Thomas, one more question online. How adaptable is your proposed system to other systems within the MOH&W? Is it separate system or will it be integrated?
Okay, very good question. Now, it is a case where it can be integrated. What we would have to do is we would have to look at the already built systems and take a look at the database structure, right, and see how the information is being stored. Take a look at the different fields and see what they provide, and of course we can easily extract the data, right? We can extract the data, put it into a CSV, and of course train our models. Yeah, it wouldn't be a issue. It wouldn't be an issue. as long as the data is being captured by the different agencies and so forth. It wouldn't be an issue. Yes.
All right, thank you. That's it.
All right. Thank you, everyone, for your questions, for your participation. Thanks again to our presenters. We will now go to a commercial break.
I was first diagnosed with cervical cancer at age 33. The treatment was not pretty. It was terrible. I couldn't go to work, and I spent the whole 5 years out of work. The pain, the struggle, I removed my womb. I thought, I'm finished with cancer. 2016, cancer come back. There's hope for your daughter. My experience don't have to be her experience. So mothers, give your children the vaccine. It will be good for your sake and for the children's sake.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
I love my children, and I will do anything to protect them. So that's why, as a mom and as a doctor, I made sure that my daughter got the HPV vaccine to protect her from cervical cancer later in life when she becomes a woman. The HPV vaccine is very safe and effective.
I was afraid of the injection at first, but I got it and it really wasn't that bad after all.
If there was something you could do to protect your child, wouldn't you do it? Protect our next generation. Ensure that your daughter gets the HPV vaccine today.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
I want to see a Jamaica that is cervical cancer free. Cervical cancer is one of the leading causes of cancer in women in our nation, and I want this to stop. The HPV vaccine has been proven to be the most effective method to prevent cervical cancer. It is a safe vaccine, and it is best to give the vaccine to young girls before they've even been exposed to the HPV virus. So parents, I want to encourage you to let your daughters get the HPV vaccine. Let us protect our next generation against cervical cancer.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
Meet Jess. Jess knows a thing or two about her health.
Measles and rubella virus still circulate in the world, right?
Yes, Jess.
So could I possibly get sick if I travel to those countries and I am not vaccinated?
That's right.
Wow. We all need to be vaccinated on time.
She understands the value of vaccination.
Mommy, did you know that vaccines work to prevent 2 million deaths in children each year?
Wow.
Mommy, thanks for ensuring that I'm vaccinated.
You're welcome, Jess. Let's give our children the gift of health. Vaccines strengthen their defenses against harmful diseases for life. Get vaccinated.
A message from the Ministry of Health and Wellness and PAHO.
Your health is your wealth, so come we start the conversation. Make we rise and immunize all across the nation. The ministry is giving us the motivation to get your infants routine immunization. Protect the toddlers from all diseases. Tetanus, rubella, whooping cough and the measles. Polymyelitis, mumps and the flu, plus tuberculosis to name a few.
Rise to immunize. Eliminating diseases saves lives. Visit your nearest clinic or health center for more information or log on to www.moh.gov.jm. A message from the Ministry of Health and Wellness.
Vaccines are the safest, most cost-effective health measure, saving over 2 million lives a year.
Every year, over 1 million children die from measles, meningitis, and pneumonia.
Jamaica's had its own immunization program for a number of years, and because of that, our children have been living longer and healthier.
I'm a mother, and all 4 of my children are fully vaccinated.
It is our responsibility to ensure that every child is fully vaccinated.
Today, only 2 countries have wild polio.
If our children are not fully vaccinated, polio can come back.
Vaccination is a gift of love.
Do your part.
Get vaccinated!
A message from the Ministry of Health and Wellness and PAHO.
I was first diagnosed with cervical cancer at the age 33. The treatment was not pretty. It was terrible. I couldn't go to work, and I spent the whole 5 years out of work. The pain, the struggle, I removed my womb. I thought, I'm finished with cancer. 2016, cancer come back. There's hope for your daughter. My experience don't have to be her experience. So mothers, give your children the vaccine. It will be good for your sake and for the children's sake.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
I love my children, and I will do anything to protect them. So that's why, as a mom and as a doctor, I made sure that my daughter got the HPV vaccine to protect her from cervical cancer later in life when she becomes a woman. The HPV vaccine is very safe and effective.
I was afraid of the injection at first, but I got it and it really wasn't that bad after all.
If there was something you could do to protect your child, wouldn't you do it? Protect our next generation. Ensure that your daughter gets the HPV vaccine today.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
I want to see a Jamaica that is cervical cancer free. Cervical cancer is one of the leading causes of cancer in women in our nation, and I want this to stop. The HPV vaccine has been proven to be the most effective method to prevent cervical cancer. It is a safe vaccine, and it is best to give the vaccine to young girls before they've even been exposed to the HPV virus. So parents, I want to encourage you to let your daughters get the HPV vaccine. Let us protect our next generation against cervical cancer.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
Meet Jess. Jess knows a thing or two about her health.
Measles and rubella virus still circulate in the world, right?
Yes, Jess.
So could I possibly get sick if I travel to those countries and I am not vaccinated?
That's right.
Wow.
Good morning, ladies and gentlemen. My name is Stephanie Bernard Stevens, and we're getting back to our policy spotlight. Now, I am the Acting Senior Director for Planning, Performance and Project Development in the Ministry of Health and Wellness. This session will focus on research and the 2030 agenda. And we have a panel of reputable experts to lead this discussion. Now, allow me to introduce them to you. We have Mr. Carlos Applewhite. He is a researcher and development professor with over 10 years' experience in governance, trade, and macroeconomic development. He holds a Bachelor of Science in Economics and Political Science and a Master's of Science degree in Government from the University of the West Indies, Mona. Mr. Applewhite currently serves as a development analyst at the Planning Institute of Jamaica, contributing to the communications, advocacy and acceleration of the implementation of the Sustainable Development Goals. Our second panelist, Mr. Howard Lynch. He is currently the Chief Technical Director of Policy, Planning and Development at the Ministry of Health and Wellness, Jamaica. Mr. Lynch holds a Master's of Science degree in Health Policy, Planning and Financing from the London School of Economics and Political Science, London School of Hygiene and Tropical Medicine. He also holds a postgraduate diploma in Public Sector Senior Management and General Management. Mr. Lynch's other activities include being a member of the Kiwanis movement, serving as a distinguished president for the Kiwanis Club of Spanish Town from 2018 to 2019. He enjoys reading nonfiction and watching the English Premier League. He is a husband and a father of 3. He's also my boss. Our third panelist, Dr. Peter Figueroa, is a professor of public health, epidemiology, and HIV/AIDS at the University of the West Indies, Mona. At the UWI Mona, Professor Figueroa led the development of the Doctor of Public Health program. Professor led the National HIV and STI program from its onset in 1986 until 2008. Some persons in this room weren't even born then. Professor has served on numerous technical committees in the Caribbean and at the Pan-American Health Organization, the World Health Organization, and the Joint United Nations Program on HIV AIDS. Professor has published widely on HIV, STI, communicable diseases, and public health, including 200 peer-reviewed articles and 3 books. He has been the recipient of several awards for his work, including the Order of Jamaica in 2008 and the Leadership in Global Health Award in 2019 from the WHO. Our final panelist, Dr. Morton Frankson, is an established general practitioner and public health specialist who has served the medical community throughout Jamaica and the Bahamas. Dr. Frankson, a proud graduate of St. Mary College and Kingston College, has been a leading researcher, lecturing in epidemiology, biostatistics, community health, and medical humanities, ethics, professionalism, and history of medicine. He has supervised over 150 Doctor of Medicine degrees. Dr. Frankson presently serves as the Northern Caribbean University campus physician and the Director of Research and Statistics. Dr. Frankson is a husband, father, and grandfather, and he has served the Seventh-day Adventist community in several capacities. Please join me in welcoming our panelists today. Come on. So coming with our first presentation is Mr. Carlos Applewhite. Please make him welcome.
All right, good morning, everyone, those in person and those online, and to the very, very esteemed panel that I'm here sitting with. Somehow they put the Arsenal fan next to the Chelsea fan, so it's good to see that we have some diversity in the room. This morning I'm just going to set the stage because we're not just talking about health research, but I'm glad that I invited someone here to represent the 2030 Agenda for Sustainable Development and the SDGs. I think I'm setting the stage because my panel is clearly quite gifted and very, very experienced and are going to provide a lot more research about health and achieving the goal 3 of the SDGs, which is for good health and well-being. I'm just going to, not to minimize my presentation, but to just go into a little bit about what is happening for the SDGs and the 2030 Agenda for Jamaica and how we at the Planning Institute of Jamaica especially are navigating health as what we now call an SDG accelerator. And since around 2022, there's been a lot of discussion on SDG acceleration, and that's because globally we've recognized that we are not currently on track to achieve the SDGs in the 2030 Agenda. And by we, I don't just mean Jamaica, I mean the rest of the world. We had obviously the unfortunate impact of the COVID-19 pandemic, and across the world we're facing what's known as the triple planetary crisis. So a lot of countries, not just small island states, but developing countries and some large ones, are facing unique challenges. And these are all leading to a little bit of deleterious effects in achieving the 2030 Agenda. That, however, doesn't mean that we in Jamaica, and even us here at the PIOJ, and many of the researchers here today, are going to give up necessarily. We still have to enact the plans and actions, and I think we're going to hear a little bit more today about what's happening in that. But how do we actually try to accelerate achieving the 2030 Agenda? We have about 4 years left for the 2030. And we don't want people to think that we have given up or that there is nothing left to do. Life goes on. January 1st, 2031, we will all still be here, God willing, and we will have a job to do to make Jamaica, as my DG says, the place of choice to live, work, raise families, and he's added on recently to retire. And in my case, to migrate, since I came here from Barbados. So, you want to keep attracting talent. Thank you, thank you. All right, so as mentioned, I'm just going to give a little bit of an overview here in terms of our SDG performance. And we use this SDG score known as the SDG index. You can look to see that we have pretty much plateaued since around 2020 after recovering from the pandemic. But if you look at 2015, Jamaica's SDG score, and we use this as what we call a percentage achievement. So it's around 66% in 2015. And since then, we've only moved about 3 percentage points. So since the implementation of the 2030 Agenda for the last decade, we have moved 3 percentage points in terms of achievement. This isn't necessarily bad. I want to remind that this is what we call percentage achievement of the goals. And we use this data set because it allows us to compare across the rest of the world. So the unfortunate thing about the SDG framework, I can say, is that it does not allow for aggregation because not all of the targets and goals are quantitative. Anyone who's a little more familiar with the indicator framework, you'll know when I speak a little bit further on health, of all the indicators, we have 230 indicators across the framework. Around 150 of those are actual quantitative indicators that you can track progress on, which makes it a little difficult to aggregate and create an index, especially at the country level. What the Sustainable Development Solutions Network has done is allow us to provide a compendium of indicators to have progress compared across countries. So at least for us in Jamaica and other developing countries who have problems generating data and producing data, we can still compare our progress and see how we're achieving using this, in a way, call it a distance to frontier approach. So the assumption is that once you reach 100, you have achieved the 2030 Agenda. Point to note, no country is at 100. The highest ranked country is currently, I believe, Finland, who are in the 80s. So there's no country in the world that has actually can declare they have achieved the 2030 Agenda, especially before 2030. I like to use this chart just to kind of provide an overview of how we look at development progress. We have social, environmental, and economic dimensions to development. So I've pulled out a few of the highlights and no lowlights there, I'd say, because these are all good, positive things. In terms of our environmental achievement, Jamaica consistently is, I would say, ahead of the curve in Latin American Caribbean region as it relates to our environmental protection. We do try to balance environmental protection and economic development. Sometimes there are criticisms, but again, as a small state, you have to balance these things with the greater good. We continually try to advance our climate change adaptation and mitigation effects. As you can see in the first highlight on the dashboard, we're now at our third, what we call nationally determined contribution, and our aim is to essentially reduce our emissions by about 26.2% from our baseline and our business as usual target. We've had an increase in forest coverage despite the impact of Hurricane Melissa last year. Unfortunately, we had this land use cover assessment in 2023, which showed that 47% of the island's total land area is forested. I do believe that after Hurricane Melissa, that probably has gone down. One of the important challenges, especially for us as a small state, and we're going to get to that, and I think we'll discuss that later on today, is how frequently we can collect data. A land use cover assessment is done every 10 years. So we won't necessarily get that immediate data on what the impact of Melissa was on our forested areas for maybe like a year or two, simply because it's very costly to carry out some of these assessments, even in terms of the improvements in technology, especially using GIS analysis that was done, used heavily in this. We look at per capita GDP. Well, the economy grows slowly. I think a strange juxtaposition is that the population has been growing even slower. So our per capita GDP has actually grown quite fast, while the country's GDP has actually been growing slowly, and that's really just a function of the slow population growth. We have a labor force that is relatively well educated. We recently changed how we classify this in terms of, before we would say certified labor force, now we say persons have at least an upper secondary level education, and that is pretty much the bulk of the labor force, around 60%. And there are persons in labor force, unfortunately, who are still, with primary and lower level education, but that's around 5 to 6%. So at least the labor force, we can say, are improvements, and these usually then lead to better outcomes in terms of our economic growth. One of our criticisms, and I think the Prime Minister talks about this all the time, we have productivity challenges. And you have productivity challenges if your labor force is not necessarily most skilled and most advanced. And these, again, will lead to our low GDP numbers. A really great highlight that we've been talking about, and unfortunately we will not be able to talk about for at least 2 years, again because of the impact of Hurricane Melissa. Our poverty rate has been declining over the last decade. And we look at the baseline year for the SCGs, it was around 22%, and as of 2024 it had fallen to below 8% to about 7.8%. Of course, we now know that with the impact of Hurricane Melissa in 5 parishes in the island last year, that poverty rate is expected to spike for 2025 and expected in 2026 as we go through the recovery efforts. So, and we don't necessarily know how long we'll be able to recover. If we use COVID as an example, the impact of COVID, we saw the poverty rate spike to around 16% in 2021, but our recovery time from COVID was a lot faster because COVID didn't necessarily devastate economic output and industries, whereas this did. So we do expect to see a little bit of depression in terms of that indicator for the next few years. And then as it relates to population, as I mentioned earlier, this one I wouldn't necessarily call it a highlight, but because we've recently got some census data and I want to show it at least just to see 2011, which is the outer chart, and 2022, see how the population dynamics have moved. So a lot of you who live in Kingston metropolitan area, you're probably wondering why there's so much traffic. But that's because 61% of the population now resides in urban areas as compared to 50% back in 2011. So over a decade, you can see there's a shift about 11% in terms of the rural to urban population demographics. So you're not losing it. More people do live in town. All right, and while we do have some highlights, of course, we still have challenges to development. We know that food security is a concern for Jamaica, disaster risk reduction, obviously, and climate change. I've separated climate change and disaster risk reduction because it is important to know that climate change is something that is much broader. Disaster risk reduction can be mitigated. It's just a simple matter of resilience. Well, no, I shouldn't say simple because it is costly to develop resilience. Very, very costly, especially for infrastructure and other areas. But we do face these things. We face climate change daily. And we face disaster risks for at least 6 months of the year, which is an extremely troubling thing. But again, if we can develop resilience, we can combat these. And then technological innovation. As mentioned, we have a labor force that's not necessarily highly skilled, and this is a gap that should at least allow us to achieve some of our more important development aims. Now, to the matter at hand, I just want to use this to speak a little bit in terms of how we relate to health and how we monitor the SDGs, especially at the domestic level. So as I mentioned, we have around 230 indicators for the SDGs, but for Jamaica, we speak to 223 unique and applicable indicators. Our challenge is a small state, and while it is a challenge, I want to again say Jamaica is actually very, very ahead of the rest of the Caribbean as it relates to reporting our SDG indicators. So right now we have 88 of our indicators, or about 39.5%, that we can say we have metadata for and we are producing. We have another 22 that we have proxies for and we are producing. However, we have about 130 indicators that we're still not able to produce. When you have that bit of a data dearth, it then, we're no longer able to actually have that composite or aggregate score like how I showed you for the SDG index, because you can't necessarily have less than half available indicators and then make proper pronouncements on our progress on achieving the SDGs. So unfortunately, that's why we aren't able to do a composite score similar to what is done for the SDSN. As it relates now to health, let's get a little bit deeper now. For SDG 3 and 4 have the most indicators and targets across the 2030 agenda. And this comes from one, especially for health, we have gotten very, very good at the international level at collecting data on health. We haven't gotten that good at collecting health data in developing countries, unfortunately. And that's why for us in Jamaica, although we have 13 targets, 23 indicators, we're only producing 14 of the indicators. And of those 14 indicators, we're able to have trend analyses for around 7 or 8, which again makes it difficult for us to present on the performance of Jamaica's achievement of SDG 3. We don't necessarily have the data that can allow us to give that full coverage, and it is definitely a gap. It's something that we're working to improve. Colleagues here, actually on the panel, have been quite helpful. In 2022, our last voluntary national review, which is a review of Jamaica's development performance, was actually written entirely by colleagues from the Ministry of Health, and we're definitely very grateful, and they continue to support us in monitoring and reporting on SDG implementation and progress. So just to kind of say, I feel anything I say here will probably already be known, but in terms of the goals or indicators that are declining, specifically we know, and in terms of declining, we also have some stagnant ones too. So we know the maternal mortality rate, the suicide mortality rate, and road traffic deaths are included in those indicators that we have data for, and we have a proper trend that we can see over the years. But then in terms of advancing, we know the neonatal mortality, under 5 mortality, new HIV infections and tuberculosis rates, we can see those rates going down. So that's why I say they're advancing. So we've seen improvements in those areas. And again, I pull out these because these are the ones that we can see a trend over a period of time. I think that's my next slide. Yes. So I'm going to jump to the bottom of this slide just as a segue. One of the challenges we have, and I know as there are a lot of health researchers here in the room and online, the ability to have continuous data, time series data. A lot of the data that we use right now comes from administrative data, or it comes from surveys. So whether it's the reproductive health survey, whether it's a health survey, these things don't allow us to be able to track the pace of progress in many of our development indicators. And this then affects us in terms of policy making and making recommendations. For us in the PIOJ and in making recommendations to Cabinet, we know that there's very low awareness of the SDGs. We did a survey around 2 to 3 years ago, and it seems 20.8% of the population actually knew what the SDGs were in the 2030 agenda. It wasn't surprising, but then when we started using certain development terms, like we told them about climate change, we told them about access to water, people know. People are very aware of the development issues that they face. They just don't necessarily know that there's a plan to remedy them, there's a plan to fix them. If I was to mention the MOH's 2030 plan, I don't think many people know that. People probably think that there's no plan to fix the health sector. But again, that's just a lack of awareness that we have to face, and we usually try to combat the misinformation. Nonetheless, the work continues. As I mentioned earlier at the beginning about SDG acceleration, now, when we look at health, we did a study between 2024 and 2025 looking at the progress of the SDGs, and we realized, okay, again, we can't throw our hands up in the air. We know that we can accelerate the agenda. How do we do this? We carried out an analysis that looked at our gaps, our rate of achievement, and we use a systems approach to then come up with 4 goals, looking at their correlation analyses to what we call lagging goals, and we identified that health, education, industry, innovation, infrastructure, and having sustainable cities and communities can allow us to achieve the outcomes of the 2030 agenda. And quickly to the end here, why we now look at health as an accelerator and cross-cutting issue. If you just use this chart, we know that health most definitely has impacts on education achievement and labor market productivity. But we also know that health is impacted by poverty and levels of poverty, environmental sustainability, especially as a result of climate change. I only recently found out at one of these such conferences that heat stress can lead to issues with your liver and your kidneys. I didn't know that. And so again, this helps us now as policy, when we develop policy and when we make policy recommendations, how can these have an impact on our broader outcomes. And then of course, safe societies. I think this one is the simplest thing. If you have safer societies, you have less people in the accident and emergency and hospitals or the different institutions. So we are now looking at how do we use the available data that we have to not only look at health as a cross-cutting issue, but look at health as an accelerator to achieve the broader 2030 agenda. I thank you for your time, and I hope I did not go too far over.
Thank you, Mr. Braithwaite. Our next presenter is Mr. Howard Lynch. Please make him welcome.
Okay. Good morning. It's afternoon? Oh, my apologies then. But I know it's morning somewhere. So good afternoon to the audience here and to those online. And my task is to deal with the role of research in the 2030 agenda. Let's hope I can get the clicker thing to work. Is there as you press? All right, so before we get into the meat of the matter, let us speak about some background issues that are critical and important to this intervention. So the first thing is that research and a strong science policy interface are central to delivering the 2030 agenda, right? We have some global frameworks, the UN 2030 agenda and the Global Sustainable Development Reports, right? But we need to emphasize that timely, country-specific research is essential to identify gaps, prioritize interventions, and accelerate progress towards the SDGs. So basically, as a background, we need to strengthen the national health research systems. I know annually we have this research conference, right? But the question for us, especially in the Policy Planning and Development Division, is the evidence that is generated from the conference that feeds into policy planning and so on. So a strengthened national health research system is necessary, right? So through better data, implementation science, and local evaluation, these are preconditions for achieving the SDG health goals and delivering Jamaica's vision for health 2030. Now, in the Ministry of Health, we know that there is a vision document for the country. But the ministry itself also has a vision document, which is the Jamaica Vision for Health 2030. And it runs the period 2021 to 2030. And it is aligned to the government's vision, and it's aligned to SDG 3 as well. Now, within the Vision 2030 document, the focus is on ensuring safe motherhood and newborn health, disease prevention, focusing on communicable and non-communicable diseases, and also achieving universal health coverage. However, to meet these goals, Jamaica must monitor progress and use research to inform policy, converting the policy decisions into plans, and then implementation of those plans, and that is practice. Now, I won't spend a lot of time on the goals themselves, just to tell you that through the lens that we looked at them, and we're hoping that they synchronize with the PIOJ's view. But we are saying that for some, we're making progress in terms of maternal mortality. But no, sorry, I should step back. I was looking at the arrow the wrong way. Stagnating is the term I should use, right? For preventable deaths, we are improving. For epidemics, AIDS, TB, hepatitis, other communicable diseases, we are on track. For NCDs, mortality, we are improving. For, well, this goes without saying, motor vehicle accidents, road traffic accidents, stagnating. Universal health coverage, I guess it depends on how you look at it. We're on track, stagnating, depending on what you look at, right? Now, for us to plan, we need data, right? And there's a table there, almost like a traffic light. No red, though, just amber and green. But the amber, or yellow, gold, depending on what, if you want to, which color you choose, the label you choose to give it, it predominates the table, though, which, in a sense, indicating that there are challenges in terms of data, right? Now, what are some of these challenges? Limited, reliable data for some indicators. Routine data are sometimes incomplete or missing. Few recent surveys on mental health or NCDs. We don't have a lot of disaggregated data, and if we do have it, it's unavailable, so it hinders equity analysis. Monitoring systems are also a challenge, right? For safety of water, air quality, injury surveillance, all these need strengthening. All right, so having told you all of that, how can research close the gap, though? Research is a mechanism for filling gaps and guiding action, right? We've highlighted 4 areas in the table. So research enables the generation of knowledge, right? Locally led studies and targeted surveys produce the missing indicators and context-specific evidence that we need. Program evaluation, we need to know what works, right? So we have to implement operational research to test interventions. We have to have policy translation. We can't just pick up a policy from some other jurisdiction and just drop it into our context. Policies are usually context specific, right? So we can be guided by the policies in other jurisdictions. But once we decide to utilize it, to adopt, we have to adapt, right? So we have to translate global guidance into Jamaican policy and financing, right? So if we're adapting health technologies, disease management, we have to localize it to the Jamaican context. And just dwell on the context question. In terms of context, in any jurisdiction, the context in terms of policy is generated from history, from experience, from how those countries have operated over time. We don't share that history. We don't operate like that. So we have to contextualize it. Now, in terms of innovations, new solutions, we need to pilot them. We can't just get up. We have this thing in Jamaica that we say we're going to pilot something. And in the piloting, the thinking is that you can just do a little piece of it. No, you have to pilot the full thing to determine what works, right? When you have done your evaluation to see what you need to do if you intend to scale up. You can't pilot a piece, right? And the next thing we do with pilots is that it turns out to be a phase, right? So we say we're going to pilot, the pilot running for a period. We don't test it, right? And then we say, okay, let's do the other piece, right? But piloting is important because we need to know what can work and we need to test innovations, right? Telehealth, we have been talking about it, right? We have not fully tested it, right? Because it enables you to extend the delivery of healthcare. Community health workers, to also extend the delivery of healthcare into the community. Yes, we know in the past community health workers were were out there as part of the primary healthcare intervention. However, this is the 21st century, so we need to change, evolve them to do other things in the community. And we also need, we mentioned data. We need to have the data platforms, right? We're running behind with that. So we need to make applied implementation and quality research a formal input to the MOH policy planning and budgeting, right? So we need to know, we can't have the plan, the policy isolated from the resources we intend to expend, and we need to know what resources we need to expend on the things that we're planning to do. Now, what is the role of the Ministry of Health and Wellness? To turn research into policy. Firstly, we can provide leadership and set priorities. Align research questions with Vision 2030, SDG 3, and national targets. We also need to set the national research agenda. I think that is being worked on somewhere, I think. Yes, I hear yes over here. Right? Publish these priority topics, right? The target populations and the methodological standards. We need to integrate evidence into policy and budgets, right? This catchphrase, evidence-based policymaking or evidence-informed policymaking, but we need to make it real, right? So require research outputs for policy approvals and budget allocation, right? We need to build data systems and analytic capacity. This is what the Ministry of Health's role is. Invest in registries, dashboards, and modeling tools. We need to convene partnerships. We have been doing it, but we should not limit our partnerships to local. We can go international because we can learn from the international experience, but remember to contextualize the solution. So we foster collaborations with universities, donors, NGOs, and the private sector. We need to translate, pilot, scale, and then have governance arrangements. So we need to ensure that pilots have clear evaluation and scaling pathways, right? So we need to know if the thing does what we are trying to find out it can do. So we need evaluation, right? The part of the problem, is speed, right? Things move slowly in our world, right? But decisions needs information at the snap of a finger, right? So, and we have a whole heap of problems. So, but we just need the discipline to apply these interventions. And we need to safeguard data. So the Ministry of Health must ensure applied research, stressing it again, applied research, not research for academic purposes. Yes, that's good, but that's not for the Ministry of Health. Applied research is funded and required for policy approval. So when we provide the advice to the government, it's based on some evidence. And also to inform the budget that we request. All right, so I gave you the Ministry of Health's contribution, but what can the Policy Planning and Development Division do in this regard? And, if I dare say, some of it we are doing. All right, so PPD, Policy Planning and Development Division, stewarding evidence into policy and practice for Jamaica. Right? So number one, evidence-based or evidence-informed policy. Right? Providing the technical analysis and recommendation to improve Jamaica's health system. Number two, health economics and data science. Conducting health technology assessments and modeling using mixed method economic analysis, which we have done, to advise on the decision to continue a particular pilot, I'm going to call it pilot, intervention, right? We applied economic evaluation tools to the thing and made the recommendation. Policy monitoring and evaluation, track programs' performance and evaluate the outcomes. That's what we can do. Information systems for health, because that resides in the PPD too. We can strengthen the country's health data infrastructure and lead the piloting of electronic health records. Currently, in a way, it's being done, and other information systems for accurate monitoring. And number 5, last one, strategic planning and performance management and monitoring and evaluation. That is aligning the MOHW initiatives with Vision 2030, setting health targets, and then monitoring the progress. Having said all that, there are a number of recommendations to build on the ministry's strength. Address data gaps with research. Commission studies on missing areas to fill SDG monitoring gaps. Strengthen data system, conducting regular national surveys on health behaviors and outcomes. Fostering partnerships, encouraging collaboration among government, academia, civil society, and the private sector. And finally, we can integrate research into policy, building capacity for knowledge generation and evidence synthesis so that the policies, my apologies, are driven by data. Ladies and gentlemen, I share the references with you. They're just behind me there if you can see them. And that ends my presentation. Thank you.
Thank you, Mr. Lynch. Professor? All right.
Good afternoon. I'd like to thank the organizers for inviting me to present on this panel. I'm going to ask that the technical people keep my slides on full screen because I want to try and just go through them quickly. No need to show my face at this point. I want to focus on the importance of health research. The objectives are just to share some reflections on this topic. I ask you the question, or let me encourage you to reflect on your role in health research. Should every health program have a research component? And how do we strengthen our capacity to do research? Research is a systematic investigation, testing, and evaluation designed to develop or contribute to generalizable knowledge. Why is research critical? It improves the quality of life. It builds credibility by providing evidence for decision making. It drives progress forward. It engages our curiosity and increases awareness and knowledge. It is an essential component of building science. The nature of knowledge or of science is very powerful, but it's also dynamic. It's not just a static collection of facts. Knowledge is also incomplete and often flawed. It may be lost, rediscovered, renewed, deepened, or advanced. There is a quote that I like in Latin, ars longa vita brevis. The craft of developing art or science is long, life is short, opportunity fleeting, experimentation perilous, and judgment difficult. So we can make mistakes. We have to be humble and modest even while we pursue science and evidence. And we also have to look at what people who have gone before have done and how we better pass on to people who are younger and developing their craft and science, because that is what is long. Our lives are short. The value of health research, we all know it, because it gives us the causes of disease, methods for prevention, techniques for diagnosis, new approaches to treatment, for increased life expectancy, reduced infant mortality, controls infectious diseases, improves outcomes for patients, with all kinds of conditions. It's an essential component of public health because it helps us to assess and improve the effectiveness of programs and interventions and to monitor progress and measure health outcomes. Now, research in health has many dimensions. It helps us to measure the magnitude and distribution of health problems. It helps to give us insight into the causes or determinants of the problem, and of course develop solutions and interventions. But we also have to look at carrying the solutions into policy and programs and evaluating the impact of these solutions on the actual problem that we are dealing with. Part of this requires us to develop norms and standards for best practice in the management of research. This includes ethical and expert review, reporting of research findings, sharing research data, registration of clinical trials, and use of evidence for policy development. As Howard mentioned, the importance of research translation. This is a process by which the evidence produced through research is translated into policy, practice, and product development. And of course, we have to communicate health information and evidence to different target audiences, including the people themselves, the population. The scope of health research is broad. There is biomedical research, which is very, very important. We also have our clinical and behavioral research. We have our population health research, and we have health systems research. And there's an intersection between, as you can see on the diagram, the clinical and behavioral research, population research, and health systems research in relation to health policy research. Now, I want to just say something quickly about health systems research, because this is an area where I think we need to do more. Health system research studies governance, financial and delivery arrangements for healthcare and population health services, and the broader context in which these are negotiated, implemented, and reformed. It is essential for strengthening health systems, improving cost effectiveness and efficiency, and enhancing health outcomes. So we've got to build our national capacity for health systems research. This requires building individual, organizational, and system capacities. You have to have multidisciplinary teams, funding mechanisms, and collaboration with universities, national and international agencies. We must apply health systems research in decision-making processes and use evidence syntheses to inform decisions. And of course, conduct rigorous monitoring and evaluation of health systems performance and reforms. So we need indicators to judge how our health system is performing and whether it meets the principles of equity, justice, social justice, and robust outcomes. Now, this is a diagram on the WHO strategy on research for health. You have to systematically build capacity in health research. You have to ensure that you are doing it in a way which promotes quality in relation to best practice for research. You have to pay attention to that, otherwise the standards slip. You need to ensure that you're focusing on your key priorities. And a huge challenge is, having done the research, identified the evidence, put it together, made the case, is to translate it into policies and programs that are effective and efficient. And there is usually a huge lag period between creating the research and the evidence and putting it into practice in specific policies and programs. And this is an area where we have to improve, and this goes internationally. This is just a quick word on one aspect of health systems research, implementation research. Why is it needed? Because it informs how best to deliver efficacious interventions. Implementation issues often arise due to contextual factors that policymakers or program planners may not have considered. It improves our understanding of the challenges interventions face in a variety of real-world settings. And it gives immense value in clarifying the difference between what may work in theory and what actually works in practice in our context. Implementation research addresses any aspect of implementing health programs, including factors affecting implementation, the process of implementation, and the outcomes or end products of the intervention. It often focuses on the strategies to deliver or implement new interventions. Now, in doing implementation research, always remember it is better, you could say it is essential, to use a framework for conceptualizing and measuring implementation outcomes. A conceptual framework simply summarizes the previous evidence and experience. So you're building on that in conducting your research. This is just one of the many implementation frameworks where it shows you that you bring together whatever evidence is available, you develop your implementation strategy, bearing in mind those factors listed in that box, the environment, the group learning, the supervision, etc. Then you look at the outcomes. They're very important outcomes because you have to measure are you sticking to the design, the fidelity? What is your coverage, your reach? Is it acceptable to the target audience? Is it sustainable? You also have to look at service outcomes, how efficient, safe, effective it is. Does it meet equity criteria? And then, of course, their actual client-oriented or person outcomes to do with their symptoms, functioning, quality of life. So this is just one framework. Another framework that is used often is the RE-AIM framework, where you look at the reach of the intervention, how effective it is it fully adopted, and then you look at the implementation aspects, and can you sustain it, or do you have to adapt it, or, rethink the approach. So those are just two frameworks that I have shared. Now, we're just going to shift a little bit closer to home now, but first, I want to go to China, because China has shown remarkable growth, poverty reduction, and advancement over the last few decades. Their research and development spending is pretty close to 3% of gross domestic product, and they're now above the average for the OECD. These are the developed countries. Enterprises actually contribute 78% of the investment into research and development. And you can see the significant growth in high technology manufacturing, 3D printing, civil drones, robots for industry. So they're creating a lot of patents now. Now, we shouldn't really compare China to Jamaica, but in Jamaica, our research and development spending is less than 1% of gross domestic product. It's way below the global average. So we spend too little on research and development, including too little on health research. What is more is that the international funding for health research that we used to be able to access is not as readily available now. In the 1990s, Jamaica was actually rated in the top 10 countries globally for health services efficiency based on the health outcomes for money spent. And this is the chart in the BMJ publication by Evans, BMJ 2001, showing the efficiency performance rank of Jamaica. It was ranked number 8 globally. This is good health at low cost. We were able to really be productive with the limited resources available. And this is what we must strive for. If we look at Jamaica health spending, the budget overall, I think, is about $140 billion. Staff take up much of the budget, $94 billion. It used to be a much bigger proportion of the budget. It's good to see the National Health Fund Research for Wellness Fund, $50 million. And NHF also funds some of the UWI research, and UWI Mona finds other funding for research. Scientific Research Council is over $800 million. But when you think of the percentage of GDP, we have to be able to go further in terms of investing more in health research and development. Now, if we were to look over the past few decades, you could say that there's been significant research that has been conducted in Jamaica, and much of this research is in keeping with our health priorities. The research findings have been used to improve health status significantly, but there are still significant gaps. We need to strengthen the research capacity and funding and improve the use of research to guide policy and action. Now, there are many areas for which the evidence is clear. So this leads us to priority policies that we need to implement. Some of these are partially implemented, but we need to do more. Tobacco control measures. This is the most important preventable cause of death worldwide, controlling tobacco. Mandatory vaccination for children, very, very important. Nutrition policies, including support for breastfeeding, but we have to look also at the ultra-processed food, sugary drinks, and salt intake food labels. I know that negotiations, discussions are going on, but we need to get these things fully implemented. Now, there was recent debate about the Sexual Offences Act, and I went back and looked at the report of the Joint Parliamentary Committee on this subject over 10 or 15 years ago. They actually agreed that there needed to be a close-in-age clause amendment to this act. Yet after 10 years, having agreed in the Joint Committee, it is still not implemented. We know the importance of healthy food in schools, sex education in schools, ending physical punishment of children. I have many friends and colleagues who felt because they were beaten as children that it's good for them, it gave them discipline. The evidence shows that physical punishment of children is not appropriate. So we need to educate our parents and move towards ending this. Reducing plastic pollution and promotion of solar energy. Similarly, there's evidence for priority programs. And I come back to the promotion of full breastfeeding for 6 months because the percentage of women who fully breastfeed for 6 months is far too low in Jamaica. But the women are not going to do it unless they get the adequate support in additional maternity leave, as well as support at the workplace and other supports. We've got to expand the early childhood stimulation program that is now at last in place. The research for this was done in Jamaica at TMRU at least 30 years ago, and it took us several decades to implement this in the health service. Vaccination across the life course, we have done extremely well, but we have far more to do. We have to get HPV coverage up to 95%, introduce pneumococcal vaccine, which is underway, but there's also RSV, respiratory syncytial virus vaccine, and flu uptake is far too low. HPV screening could reduce cervical cancer. It is superior to pap smear screening, and new evidence is emerging that shows probably with just 4 or 5 screenings over the reproductive life and beyond could take care of that problem. Other screening programs, something that really concerns me is that we need to put much more resources into community mental health services so that we help to support families who have persons who are mentally ill and we keep them out of hospital. Sex education in schools, reducing alcohol intake. Now, preventing cardiovascular disease. I just want to focus on that. There's not enough time to talk about all chronic diseases. If we want, I heard one of the presenters say 60% obesity, right? Why don't we have more safe places where people can walk? Safe parks. National Heroes Park should be like Emancipation Park. If you want people to increase physical activity, they must have places to walk safely. The food policies on salt reduction. The most important thing is how do we improve hypertension control? And I would say that maybe 50% or more of people with hypertension are not adequately controlled. In the United States, with the more stringent standard for hypertension, only 30% of the persons with hypertension are adequately controlled. Yet at Kaiser Permanente, their health program is able to achieve 90%. I don't have time to go into detail, but we need to look at that because it is a simple, focused approach. You have to be able to control hypertension. And it requires better quality assurance, regular audits, and we have to improve health literacy among the population and tobacco control. There's a recent study that shows that 99% of persons with heart attacks or stroke have at least one of 4 risk factors, and often more than one. High blood pressure, high glucose, high cholesterol, and they smoke. If you address those, you can make a dramatic impact on cardiovascular health. Where do we have some priority areas that are actually in need of health research? Much more than is being done. Chronic diseases, maternal mortality, health-seeking behavior. And how do we encourage persons to take more responsibility for their health? We also need to think, we need to do much better on ensuring that our health services are really person-centered. We have in too many accident and emergency departments persons sitting in wheelchairs for 24, 48 hours. And this is not only in the public sector, even in the private sector there are problems in A&E departments. We need to research this, address it, and improve. We need consumer surveys in our hospitals and outpatients and primary care. And this is related to improving our health system, which also requires health systems research. Finally, how do we improve our knowledge translation? That is bridging the gap from research and evidence to actual implementation. We've got to improve the training of our public health leaders and managers, streamline the human resources for health between the ministry and the health regions so the best staff can move readily into senior positions anywhere in the island without losing any benefits that they have. We can't be turning the island into 5 different operations. We need to require the DRPH or equivalent for senior public health appointments, closer collaboration between the health services and universities, ensuring multidisciplinary research teams, increasing funding for health research, and we can do this also if we're better at reducing waste, and I'll call it leakage. Establish a unit, consider establishing a unit in the ministry to facilitate knowledge translation. The UK actually has an institution called a National Institute for Health Research, Healthcare Excellence. And then finally, we've got to strengthen the capacity of the ministry to conduct health research. Thank you.
Thank you very much, Professor. Now we're inviting Dr. Frankson to come with his presentation.
Okay. Could you launch my presentation for me? While that is happening, good. When the Vision 2030 Jamaica and Sustainable Development Goals effort, that wonderful development plan, was launched, I left UWI in Mona and went to UWI in the Bahamas. And I just came back 2.5 years ago, so I don't know what I'm talking about. However, I'll give it the best shot, and I'll keep it as short as possible because of that reason. I thought that the topic I'd use was transformational health research complementing Vision 2023 Jamaica. And I'll just say next, and you change for me, please. Oh, I have the device here, sorry. Alrighty, yeah. Coming from Northern Caribbean University, I have to leave you with a Bible verse. My adaptation of it. Miraculously be ye transformed by the renewing of your minds to evidence what is good, not goose, acceptable and perfect, as you choose to, with committed sacrificial ways, embrace edifying life ways. Well, you know where that is from. It was actually the first text I said in church, and it has molded me. That verses 2 and 1, of course, where we are Paul is beseeching us to really get things right because of how blessed we are and how marvelous the future has been ensured for us. I really have only that as a declaration, and I'd like to focus on the fact that we are looking at elevating Jamaica to developed country status in 4 years' time. In 4 years' time, so much time has passed. And in the health sector, we're focusing that around healthy and sustainable populations. Very, very admirable. By transforming the healthcare system into a first world standard, focusing on promoting wellness rather than solely disease, illness-focused therapeutics. What I'd like you to do is not say that we are moving out one and replacing the other. We can walk and chew gum at the same time. We can continue to find wonderful ways to treat illnesses, but now we really need to close the gap on things that are related to prevention. And what a lovely set of presentations my former three presenters have given you. And they've really made my work easy. And they've given you a master class in this area. Healthy lifestyles and a healthy environment producing healthy people is no wonder why we can say with these goals that what we are really about is Jamaica being the place of choice to live, work, raise families, and do business. I took a little time to parse that out. To live. I guess the only thing it could mean is to live better. Better living. Adhering in balanced, temperate ways, a famous word from the Greeks. Temperance was such a value of theirs. To be doing things that are health promoting, enjoying wellness. There's no sense in being well and not enjoying it. There's a quality of life component to it that is what living is about. Preventing illnesses, yes, and diseases. And indeed, healing the hurts. Again, my former presenters have focused on the big work we have in front of us to research those areas and to use the facts to help us to be doing better living. Growing or maturing in appropriate ways. Those are some of the things, and I leave you for homework, other things that you could see that you would like to use to focus on as ways that in such a country we could be doing better living. Working. Let's look at that word. What I added was the word meaningful. Meaningfully working. You know, being wise about the things that you prepare yourselves to do, preparing our jobs better. This very effort goes to exalting the importance of STEM education, and that is wonderful. And there are other areas that need to be not neglected as well. Making effective efforts to address needs that we have is a wonderful way to have meaningful working. There are felt needs, those needs that people who we serve tell us about. We have perceived needs, those that we who are trained think they're telling us about, and measure it, etc., and do research on. Working in a way that is balanced, because that also makes it meaningful. Working with commitment, because that breeds excellence. And working in a way that the rewards are commensurate with our labors. Fair, and I know you're thinking of remunerations, but I'm also thinking of the rewards of, as you work, enjoying the relationships that you rub shoulders with. I'd like to pause to just say to you that, to Professor Figueroa, what a joy it was when in the 1980s he was at the Kingston and St. Andrew Corporation in the Public Health Department, and I had gotten a job with the Seventh-day Adventist Church with the Adventist Development and Relief Agency, and we had got a sizable amount of money to go into Trenchtown and to improve things there in a true primary health care model. It was my first serious administrative job, and I was 28 years old. And I made sure that at least once a month I would pass by just to talk with Professor Figueroa. and he was such a mentor. That's something that I could take back to Trenchtown. We only did the project for 6 years, and then the grant was over. And after that, I got a scholarship to go and really study public health to see if I could really understand what I was doing and to do it better. It was useful for us to build that kind of relationship, and you don't know how much of an honor it is to be following him after his really comprehensive presentation today. The other part of that laudable statement is successfully raising families. Well, I put successfully, because anybody can raise families carelessly. In fact, we have too much of that. And slavery has taught us too well how to be responsible about that. And it's taking too long to disappear. We have too many single family homes, etc. So I could list out a variety of things there to you. Let me mention a few. Procreating jubilantly. Too many children are being born, and it's not a joyous experience. That needs to change. Much collaboration as families work together. Respect for the institution of marriage, and so forth. Decent housing and shelter. Interdependency as we work together on these things. And building a legacy that we can pass on to others, among other things. And of course, flourishing in doing business. All of these things I mentioned needs research and in the wider sense of the Vision 2030 endeavor. But that particular one is calling to me for faithful stewardship. It's calling for integrity. It's calling for mutual trust as we do business. Less corruption. No corruption, in fact. Okay, we're not in heaven yet. But even in the Garden of Eden, corruption found its way. But being attuned to the marketplace, that is really a marketplace that will help us to be developing, and surrounding that with good business ethics. Well, let me just finish this here. So, all of that for us in health, where we work, is housed in a framework where we are hoping that the day will come when we will have universal health coverage that supports all of those 4 things that I just commented on and explicated to a bit, and universal access to health. What we really want to be doing is reducing mortality and morbidity. Forget the question sign, it should be a slash. Disabilities related to non-communicable diseases and their risk factors, again, those were covered very well. We want to move to modernization by upgrading our infrastructure, building centers for excellence, as was just mentioned not too long ago, a few minutes ago. Not just in the services that we have traditionally rendered, but we really need to grow seriously in emphasizing centers for wellness, along with the ones for the diseases like cancer and heart disease and the various mental disabilities and behavioral problems. And utilizing appropriate technology, meaning some of which we can develop for ourselves based upon research that we have done. I remember when I was in the Bahamas, the outgoing neurosurgeon, when he came, he was the first neurosurgeon in Bahamas I'd ever seen. And those were back in the days. And he designed and developed every single one of his neurosurgery instruments right there in the Bahamas. We were a little more comfortable, and Jamaica was really under colonialism, favored in some ways, and we have a good legacy of several of our specialties being treated well. Things have changed much better in the Bahamas now. In fact, they like to say that it's better in the Bahamas, but I always retort, but it's best in Jamaica. But and I hope they'll smile, because having spent 14 years and 4 months and 4 days there, I actually have found it to be a wonderful family that I really appreciated mingling with. Mention has been made that as we transform, we need to transform digitally and do the research that accompanies that. Telemedicine, health information systems, and digital transformation to improve access across access to care across Jamaica. Health information systems strengthening of data reporting, particularly for mental health and suicide, reducing reporting gaps and so forth. And I would even add things to deal with also molestations. Our reporting of molestations it could stand for some improvements. A team of us published in the West Indian Medical Journal on some suggested ways that we could improve that several years ago. And those are some of the things I'm talking about. Digital transformation by supporting the roadmap for the digital transformation of the health sector in the region of the Americas to ensure security, ethical, and inclusive health data usage is a must. And as we look at structure and systemic reforms that we need to face, primary care hospitals and community-based services are what we're focusing on. And for primary care, restructuring it for equitable services by a three-tiered system reorganization: the community, the district, and comprehensive primary health care. We could do a far better job of that. It is too long now that the idea of the hospital being the kingpin organization has lingered in the minds of our Jamaican people as the place where you finally will get good care. That paradigm must keep shifting. I know it is shifting, and it needs to keep shifting, where primary care becomes the place that you go to. I hope one day we'll even have primary care where we'll be doing wellness activities at the primary care center. And we will also be marrying with the environment health people and with the One Health people and so forth at the community, the district, and the comprehensive care level. Hospital transformation, it goes without saying, because that needs to happen. And what a joy it is to hear that plans are in the works for doing some of the wonderful hospitals that we have here in Kingston and St. Andrew, also in other parts of the country. And of course, mental health, there is that serious gap that we continue to make sure, need to make sure that that gets the proper treatment as well. And research will have to pave the way for that. Some of the key drivers are our social determinants of health, resilient facilities, and evidence-based decision-making. And the prevailing social determinants of health are needed to be better addressed to thereby improve resultant biopsychosocial or whole person outcomes. We need to look at persons now as whole persons more so, and have research that drives that so that it becomes just a natural way of doing things. Instead of the reductionist way that we like to be doing things, copying from countries who are richer and actually who have probably taken the wrong model that makes them spend a lot of money for health with very inadequate returns, where specialization is more so their things, and we need to find ways to find people who are not following their model. Even in primary care, we seem to be following their model. I have gotten into trouble over and over telling family medicine people that you're not a specialist, you're an extensivist. Just like the hospital extensivist is helping to coordinate so that all these specialists that come into the hospitals, the patient, seeing the same patient, the patient is confused, but there's one person who coordinates that care. Well, we have that in the form of family care and primary general practice, and we need to use that term more rather than the term a family care specialist, because how can you specialize in generalizing? You can be extensive, though, in generalizing. I know I'm in trouble there, but I've been in trouble for a long time about that. Supporting climate-related, shock-proof, resilient health facilities. Need I say any more on that? We've just had a lesson 2 years in a row, and we might have it again this year. There's only 20 weeks left to hurricane season. Sorry to be a downer on that, but let's prepare ourselves. We were very providentially saved in the majority of the population of our country, and our hearts bleed for the parts that were ravaged. Evidence-based decision-making, we're utilizing research such as the Threefold 21 model to inform policy and project future consequences on health research strategies are some of the drivers that we're thinking of. Implementation and monitoring was well emphasized by Mr. Lynch, and I appreciate that, and so by Dr. Figueroa and all of the speakers ahead of me. You have heard the term with relationship to this 2030 vision, in terms of medium-term framework, as was spoken of at length by our first speaker, and how useful that is, and stakeholder engagement. They all need research to drive them, and research of a health-related nature. So, I'll say no more on that, but that, and this is my last slide, the kind of research that we need, just to complement what others have presented, and not to be redundant, is good quantitative approaches. That's the most familiar one to us. Policymakers understand percentages and counts and a little bit of correlations and looking at the statistical and effect size and statistical significance of results. Most of us have been well grounded in statistics. And that is wonderful. And that should never change, because there is a beautiful thing that goes on in our minds when we can sense the quantity of something that has happened. But more and more now, we are to embrace what is already growing, which is qualitative approaches to research. Because most of our national publications and official ones are mostly the quantitative things, but they are quantitative things mostly of a descriptive nature. Now we need also some quantitative research that goes and looks at why is this, and in what way is this, the manner, the mechanism of things. You can use both qualitative and quantitative to advance that, and in fact mix them together. And as Mr. Lynch again emphasized very strongly, you have to have monitoring and evaluation with that. But I would also add one other thing, which is we need to better appreciate and really do cost-effectiveness analyses as well, in a way that is really meaningful, whether it is be as cost analyses, pure and simple, or cost-effectiveness analyses, where we are looking at the outcomes from different perspectives, whether the perspective of society or the perspective of our institutions, etc., or cost-benefit analysis, where we are looking especially at the money and how the money is benefiting us. Again, I thank all of you who have put this wonderful conference together, and I ask that you have a wonderful day as we move into the next section.
Thank you, Dr. Franson. Okay, so we are a little bit behind time, and we are going to take 2 burning questions for our esteemed panelists. I see a hand there. You can go ahead.
Right. So you talked about the ministry's role in research and in ensuring that pilots have evaluation and clearing pathways. How do you reconcile that kind of research with the health information systems that we've been piloting for years? I didn't see that in your recommendations.
Oh, that sounds like a head-scratcher question. All right. You're talking for years that we have been piloting health information systems.
Yes, but you talked about the research in terms of ensuring that those systems have evaluation and clearing pathways.
All right.
So if you could relate that, it would be
Boy,
helpful.
I can't fix the historical pilots, but I can tell you about the current EHR that is being piloted in 13 sites, 3 hospitals, 10 health centers. From the Policy Planning and Development Division, we have done a preliminary evaluation of the EHR, right? What do you call it? Well, we did an evaluation, but it's not the final evaluation of the thing, and it's a going forward type of situation where things have happened inside the Ministry of Health and Wellness, where the Policy Planning and Development Division has been restructured to enable it to undertake some of these type of interventions. In the past, that has not been done. And as I did say in my presentation, many times the idea of a pilot, right, is treated in 2 ways. One, it is treated as a phase. All right, so we say we're piloting, we don't evaluate, but we roll into the second phase, or we expand. The next issue with pilots is that we don't put out the full intervention, the full design out there to test. We put a piece of it, and then we say, okay, we will look at what this piece can do, which may be what some of those information systems have been. All right, our PAS that exists is not a full information system. It's just the registration module as opposed to the full gamut, right? We have had other pilots. So it's, in a sense, it's not a true pilot. So it's reconciling with what I've said, that we test a piece and we call it a pilot. And we have been struggling trying to understand back then why it wasn't delivering the things we wanted it to deliver, because it couldn't. It was never that. It was just one module of a full information system. So the historical problems are there, legacy matters, right? And I would also add that sometimes having invested in a thing, this is outside of the pilot and the evaluation argument now, is that having sunk resources into an intervention, and resources are scarce, sometimes it's hard to step back from it, even if you realize it's not working. I don't know if that answers it. All right.
Any other questions? I see a hand there.
Okay, good afternoon. We have a question also for Mr. Lynch. It says, in light of continuous migration of nurses and doctors, what policy-driven research framework is being used to generate ongoing evidence for health workforce planning, retention, task shifting over the next decade?
Boy, those questions are hard. Maybe I should ask the moderator to answer it. Repeat it, let me hear it again.
So it says, in light of continuous migration of nurses and doctors, what policy-driven research framework is being used to generate ongoing evidence for health workforce planning, retention, task shifting over the next decade?
Boy, I'm wondering if I could lay a hand on this lady, could I?
Okay, all right, so There are a number of initiatives that the Ministry of Health is undergoing, one of which is the development of a human resources for health policy and action implementation plan. Now, we would have commissioned that policy and we would have been in receipt of the draft policy, well, the finalized, and it is going to go to Cabinet for decision on the implementation plan that was accompanying that policy, because we do realize that migration continues to be an issue for Jamaica, or healthcare workers, and so that policy looks at the encompassing problem that we're having. We're also in the process of doing a health labor market analysis, just to look at what we have or what we need to do. This would include, and I'm glad that Northern Caribbean is here, this would include the training institution, and how is it that the partnership between the government or the health sector and the institutions, so training for need. So it would look at different avenues that we can take going forward. And so that is the policy framework that we are crafting to address the human resources for health issue in particular, which migration is a part. Sure.
Thank you.
Yeah. I think people will always migrate in and out. But for me, I think the thing that will make most difference, I think the policy is important. But I think that if we were more responsive and more effective and efficient in addressing the concerns that our staff have, that people have, because people have all sorts of challenges. I was looking at a couple of the comments. Someone said they had a difficulty getting their P24. Another one trying just to be moving between one region and another. So, you get feedback about the kind of challenges people face. And I think we have to be much more proactive in addressing the difficulties they face, supporting them, and then making the working environment much more satisfying. Even when you do that, some people will migrate, but I think more people would stay and feel that they, can contribute.
Thank you as
And
well.
thank you. And just the final part of your question, the task shifting, it is an initiative that is being looked at. It's outlined in the Ministry's primary healthcare renewal document. And so it's an avenue that is also being explored.
Thank you.
Dr. Grant, question?
Thank you. So first of all, I'd like to commend all of our presenters. I think it was an excellent presentation and much food for thought. Oh, I'm being asked to stand. I thought with my height I would be able to be seen. I just wanted to start with a comment, though, because a lot of what was being discussed and what I'm seeing in the chat, we have initiated some of those actions already. Mm-hmm. So we do have our Essential National Health Research Committee, which is currently promulgating our National Health Research Agenda. We are promoting knowledge translation, etc. But I also want to bat for our national policy on research for health, because a lot of what we have been speaking about in terms of the funding for research, the different types of research, capacity building, etc., that would promote and be promoted through a national policy on research for health. So we have initiated it, but we know it is a long process. So that's my comment. And that leads me to the question, and I'm going to pose that question to Prof. because he had mentioned it in his presentation, that balance between the slow and the fast, because government works very slowly. Professor? And what we learned, for example, from COVID-19 was that there was a demand for information, but in order to conduct a research study, it has to go through ethical approval, and we have to get funding, etc. And so many times there is the risk that whatever need would have passed before we get through all of the hurdles. So I'm just wondering how it is that we can facilitate that process so that we will be able to better respond to the needs as they would arise. Thank you.
Okay. Well, I appreciate your comments, Andreen. As I said, opportunity is fleeting. We can only do what we can do. So I like the approach of having a health research policy. And meanwhile, whatever we can get done quickly, we do quickly. So I'm not sure I'm following what you want me to specifically address when you said, we can only work to streamline things. For instance, going right back to Barry Wint, he wanted to find a way that the University Ethics Committee and the Ministry Ethics Committee could work together so that the researcher only needed to submit to one committee, right? Or merge the committees so that if someone wants to do research in Jamaica, it doesn't have to go through 2 ethics committees. So that is, now it will take a little negotiation and working through, but it would help researchers. There are lots of things I think we could do to facilitate research as well as implementation. And as we see the problems, we have to work together to try and improve. It's just a constant process. There are always going to be challenges. But we have to keep the faith and keep going.
On that matter, I'd like to just make 2 little points. One is, remember your definition of research. Research is not just getting something approved and collecting data and, doing the wonderful experience of making sense of that data through good analyses, etc. The moment you ask the research question, you have begun research. And that is something that I noticed that a lot of folks don't take seriously, because if you start to take the first part seriously, whether you are in the infrastructure part where you are part of an ethics committee, etc., or whether you are the actual person doing the research, it really focuses you on what needs to be done to expedite this in the way that is responsible. So the moment you are raising your research question, the moment you are cleaning up your research question with a proper literature search, the moment you are collaborating with others so that you can get to use their instruments to actually be part of the measuring devices that you use, etc. All of that is research. What I notice is that in the final report, very few people report in their final report some of the challenges that they had in doing these studies. And that is, to me, an area that is a defect that we could fix, because we can learn from that also. That, too, is proper reporting, proper conduct of research. We need to have those experiences documented so that when we go to try to the various places to change these things, we can put those things that are documented in front of people too. It's one thing to say, I had a tough time. It's another thing to say, these were the barriers that I had, and these were the things, and these were the things I had to do. So I've seen people even publish on the challenges of doing something like not getting participants to complete the original research, and they've published on the challenging of getting that study even out into the participants, and etc. So I would like to just add that as well to what is said. As to the issue of ethics, that's a sticky one, because it has to be committees that are sensitive to the particular populations that are being researched. And for some issues, you're going to have the National Ethics Committee being the more appropriate things for them. And for other issues, you're going to have those entities that are housed in institutions like universities and colleges. And what we had done, Prof., at one point when I was 2004 to 2006 when I was at Mona, is we had come up with an agreement that first we had parameters that the ministry said they wanted those kinds of research to come to them firsthand. And then you had those that the university could have the full power to be able to approve, but if we didn't do that, students would never graduate on time. And in fact, that would be a frustrating experience. But what we also did as part of the stewardship there was all of those projects, we would carry them and let them be transparently housed, a copy of them in the ministry, and also expect feedback and so forth. So those are two little things that I want to mention there.
Thank you. There's a question online.
All right. So there's a question for... Well, there's several questions. I'm just trying to find the... All right. Okay. So I'm guessing this also goes to policy again. It's with more than half of the applicable indicators not having data being produced, are there plans to address the data gap to increase our likelihood of achieving the SDGs?
Is it PIOJ or Ministry of Health's policy?
It might be either or both.
Okay, Mr. Braithwaite, do you have a... Did you hear the question, sir? Okay.
All right. Well, in short, we're working to improve capacity to collect and analyze the data. The chart that I showed was actually an improvement from where we were at the baseline in 2015. I think we had around that time maybe 40 to 45%, and now we're over 50%. So through the Statistical Institute of Jamaica, and I think through the, well, Mr. Lynch's former office, would it be?
Yes.
Yeah, his former office and the epidemiology unit, we've been able to improve. But there are some indicators that we know we just won't be able to produce, but it's a work in progress. Given that we're coming to the end of the 2030 agenda, I recommend that MOH and partners actually lobby to have indicators that we can produce for whatever the next international development agenda. It makes no sense reporting on things or having data and indicators that you simply will never be able to report on. So that's food for thought for whatever comes next.
Thank you.
Okay, thank you very much. Now, that is all that we have time for today. And I had my list of questions, because I came prepared for Mr. Lynch. But we'll discuss in the office. You want me to ask? Yes, Dr. Grant, thank you. All right, so Mr. Lynch, Dr. Grant said I should ask. So given the Caribbean vulnerabilities, Jamaica, of course, climate shocks, debt constraint, health inequities, how can research more effectively guide policy trade-offs and prioritization under our limited fiscal space?
I don't know why you never leave that question for the office. All right? Say it again, man. It's so complicated.
So, given our vulnerabilities, climate shocks, debt constraints, health...
Debt constraints?
Yes. Health inequities. How can research more effectively guide policy trade-offs and prioritization under our limited fiscal space?
All right. I guess the first thing we have to understand is that we have multiple problems. Those are some of them, and multiple policy problems. Right? So the first thing we have to do is to prioritize which one is the most important thing we need to look at and to understand more of. to dedicate scarce resources to research to undertake any such study, right? Because despite the circumstance, resources are always scarce. And problems, I don't want to say problems are infinite, but we are experiencing a whole heap of problems. And in every jurisdiction is the same. So we have to decide. Maybe the first thing then is to establish the criteria to determine what we select to look at. Right? Which problem is the most pressing one that requires our attention? We may need to decide. Then channel the resources to undertake the research, to understand more as to the cause of that problem, determining the theory of change, and then design the intervention to fix it. Climate, you mentioned climate. We have no control over that. No, we have no control over that. We can respond to it, but we cannot prevent it from occurring. You understand? And what's the other one? Something can help you. The debt?
Debt constraint.
Right. And debt, well, debt is not a bad thing if you utilize the borrowed resources effectively. Right? And we, over the years, you would have seen that the country has been taking steps to minimize its level of debt. However, maybe a climate shock event can force you into a situation where you may now have to seek more debt. Right? But at the end of the day, we still have to apply some mechanism to determine what is the most important thing we need to respond to, and then apply the research, right? Not just to understand it, but to understand it and to determine what interventions, cost-effective interventions, can remedy it.
Thank you. All right, so you're already clapping. Put a little more gusto in your clap for our panelists. Mr. Braithwaite, Mr. Lynch, Professor Figueroa, you don't remember me, but I used to bug in my years when I was at UE, and Dr. Franson. Thank you all for joining us, and now we are going to our lunch break. Do have a good one. God bless.
And we're moving now into section 5, the scientific section, and it is titled Health Economics. We'll be having 3 presentations in this session. All the presenters will make their presentation, and it will be followed by our question and answer section. All right, so I am tasked today with introducing our wonderful presenters, and I hope I do get this correct, given their esteem. All right, so I'm starting with Mr. Devon Keith. He is a statistical analyst at the Ministry of Health and Wellness in the same division as myself, Policy Planning and Development. He holds a bachelor's degree in actuarial science and a master's degree in applied data science with distinction from the University of the West Indies. Mr. Keith considers himself a student of the Word of God and a disciple of Christ. His favorite maxim is from Henry Ford, and it goes, "Failure is simply the opportunity to begin again, only this time more brilliantly." It also ties well with a verse from the Bible, Psalms 40, verse 8. "I delight to do thy will, O my God. Yea, thy law is within my heart." Mr. Keith is a husband and a father to a beautiful daughter. So the wonderful lady on the panel, Miss Selena Lewis, or is it Selena? Selena Lewis, has built her career around research, statistics, and data analysis, with a focus on strengthening public health system. Selena earned a master's degree of science in epidemiology and a bachelor's of basic medicine in anatomy from the University of the West Indies, Mona. Ms. Lewis has been recognized for her research, earning the Best Overall Oral Presentation Award at the 14th Annual Health Research Conference in 2023, and was awarded the Jamaica National Postgraduate Scholarship in recognition of her excellence and potential to advance research in public health. Ms. Lewis currently works as a monitoring and evaluation officer at the Ministry of Health and Wellness in Jamaica, where she applies her expertise to strengthening data systems, monitoring health programs, and inform programmatic decision. And our final presenter, Dr. Owen Hyatt. As stated, he's a medical doctor with a focused interest in general surgery. His research centers on surgical outcomes and training, evidence-based practice, and health policy improvement. Outside of medicine, he enjoys tennis, snorkeling, and cycling. So I had a little conversation with Dr. Hyatt when he was entering. So he did his BSc in medicine and surgery at the University of the West Indies, and also had a BS in medical science. All right. Now, Dr. Hyatt lives by the philosophy Kaizen, to live a life of continuous improvement. And as we are all here doing research, we want to improve upon our lives and the lives of the future generation. I will now turn over to our first presenter, Mr. Keith.
Thank you. Good day. It's a pleasure and a privilege of mine to present to you our research on the cost effectiveness of abemaciclib plus endocrine therapy in the high-risk HR plus HER2- early breast cancer in Jamaica. Before we begin, I would like to provide some context to help underscore the relevance of this study. Breast cancer is the most prevalent malignancy among Jamaican women. It is known to encompass multiple biological subtypes, one of which is the HR plus, HER2 minus subtype, for which comprises about 51% of breast cancer diagnoses in Jamaica. Current treatment options include surgery, radiation therapy, chemotherapy, and adjuvant endocrine therapy. Oncologists believe these endocrine options are simply insufficient and recommend abemaciclib, a novel drug that targets and inhibits two key cell cycle regulators, proteins known as CDK4 and 6. Given this context, our objective was then to evaluate the cost effectiveness of adjuvant abemaciclib versus endocrine therapy alone. To achieve this objective, our methodology was conducted in two phases. Phase 1, we performed a systematic review by searching key literature databases to identify controlled trials, open label trials, retrospective cohort studies involving HR plus, HER2 minus, high-risk early breast cancer patients. Now, high risk was defined as adults aged 18 years or older at stage 1A to 3C breast cancer who had either 4 or more pathology confirmed positive axillary lymph nodes or 1 to 3 pathology axillary lymph nodes and accompanying high-risk factors. Studies outside of this scope were excluded. From our eligible studies, we extracted details of participants' characteristics, key outcomes, safety data, and quality of life information. The information was pooled and presented as hazard ratios and proportions. Key outcomes included invasive disease-free survival, IDFS, distance relapse-free survival, DRFS, and overall survival, OS. From here, we conducted phase 2 of our methodology, the cost-effectiveness analysis using a 4-state Markov model to estimate lifetime costs, life years, and quality-adjusted life years in order to calculate the incremental cost-effectiveness ratio known as the ICER. This model considered a hypothetical cohort of HR plus, HER2 minus high-risk early breast cancer patients. Patients could either occupy or transition between one of the 4 following stages: disease-free, non-metastatic, metastatic, or death. The model was configured so that members of the cohort enter at age 52 in the disease-free state following initial treatment. Over time, they could either remain disease-free or transition to a non-metastatic state. From there, they could progress to a metastatic disease and ultimately to death, or they could remain disease-free for multiple cycles before moving directly to death, among other possible pathways. These transitions occur once per model cycle and are really governed by probabilities that were estimated from clinical data. These were estimated by extracting 5-year clinical data, survival data, and fitting parametric models, extrapolating beyond follow-up periods, and we estimated health state proportions, derived non-metastasis to metastasis, that's downstream probabilities, and mortality rates from national death statistics. With regards to the economic inputs, only direct medical costs were considered and stratified by model stage. In the disease-free state, we considered drug costs, treatment monitoring costs, adverse event costs, and costs of hospitalization. With regards to the non-metastatic and metastatic state, costs include diagnosis, imaging, surgery, chemotherapy, and endocrine therapy. We applied a 6.25% discount rate over a time horizon of 20 years, assuming the government as a payer with a willingness to pay threshold of 1 to 3 times GDP per capita. All costs were standardized to the 2024 Jamaican dollars using the health CPI. Treatment comparator was that of adjuvant abemaciclib versus ET alone. We conducted sensitivity analysis that were deterministic and probabilistic in nature. Deterministic sensitivity analysis sought to isolate individual parameters by varying them plus or minus 25% around their base case. Probability sensitivity analysis investigated joint uncertainty using 1,000 Monte Carlo iterations. We prepare and present safety and efficacy data that were pooled together, treatment costs, cost-effectiveness outcomes, and the corresponding sensitivity analysis. From our systematic review, we identified 628 studies, of which only one met the eligibility criteria. But this was consistent with our expectation given the novelty of abemaciclib. For the 5-year efficacy analysis, both IDFS and DRFS showed a hazard ratio of 0.68 with a confidence interval being 0.6 to 0.77, suggesting a 32% reduction in risk. Overall survival was 0.9. Crossing the survival was, the confidence interval rather, was crossing 1, which suggests that the data was immature. With regard to the safety profile, adjuvant abemaciclib was associated with more serious AEs and that of the hematological nature. Regarding the health-related quality of life, we found that this declined as the disease progressed. Treatment cost was broken down by model stage, and the total cost in the abemaciclib group for the drugs was 14.2 versus 3.9 in the ET-only group. This was a main driver of cost. For the other stages, non-metastatic totaled approximately 5 million versus 3.1 in metastasis. Regarding cost-effectiveness output, lifetime cost for the adjuvant abemaciclib group was about $24 million versus $16 million in the ET-only group. This approximate $7.6 million increase in lifetime cost affords a patient 0.89 years of life or 0.71 adjusted life. Together, this gives us an ICER of approximately $10.8 million. Sensitivity analysis was conducted to find out how this ICER would fluctuate with uncertainty in these parameters. At the crown of the tornado diagram, we see the 3 parameters that highly affect the ICER, namely disease-free utility, discount rate for cost, and the cost of abemaciclib. Discount rate for cost yielded the lowest ICER of $8.4 million. Now, experts recommend that we summarize a probability sensitivity analysis using a cost acceptability curve. This shows the probability of cost effectiveness of the intervention across varying willingness to pay threshold. We found that 0.1% of the iterations were cost effective at 2.5 times GDP, rising up to 2.3% at 3 times GDP. Pulling all these results into perspective, we see that adjuvant abemaciclib was found to be efficacious with tolerable AEs, and the World Health Organization recommends that intervention should fall below 3 times GDP per capita to be considered cost-effective. Internationally, we see studies from countries applying this framework like China reporting cost-effectiveness at 3 times GDP, while India reported that ICERs overcame their national threshold. Our model, in comparison, reported an ICER of about 9.8 times our GDP, and deterministic and probabilistic sensitivity analysis confirmed these results. However, our study is not without limitations. The monarchy trial was immature and could bias or limit the lifetime study outcomes. Jamaican-based utilities were not available, and the clinical pathology characteristic of the clinical trials were not a complete representation of the Jamaican populace. In conclusion, adjuvant abemaciclib, in comparison to ET alone, is more effective, has a worse safety profile, increases lifetime cost by $7.6 million, and provides patients with an additional 0.89 life years, but from their perspective, that translates into 0.71 quality adjusted life year. As per WHO's recommendation, adjuvant abemaciclib may not be cost effective for Jamaica. This kind of study, a cost-effectiveness analysis in general, provides evidence-based advice to the efficient allocation of our limited healthcare resources. It can help determine what treatment strategy among the plethora should be considered. These are my references. I thank you for your attention.
Thank you, Mr. Keith. And now, our beautiful Selena.
Good afternoon, everyone. Okay, thank you. I am Selena Lewis, and I just want to thank the National Health Research Conference for having my team and I present our study findings on. I'm just waiting on. I think oh, this is the wrong one. Oh, damn. Thank you for allowing my team and I to do our presentation on our study findings. Yes, okay, thank you. Okay, so we conducted a study on retention in care among PLHIV accessing care at public sites in Jamaica. Just to define a few key terms, retention status, this is a measure that indicates whether a person living with HIV is still in continuous HIV care at a given point in time or during a defined follow-up period. Retention status is usually categorized as retained in care, which is PLHIV actively engaged in care with no missed appointments for more than 90 days, or lost to follow-up, PLHIV with a missed last appointment by more than 90 days. First CD4 count, this is the initial measurement of immune function taken at or near the time of HIV diagnosis or entry into care. This is used to assess disease stage, guide clinical management, and identify risk of adverse outcomes such as morbidity, mortality, and loss to follow-up. The last viral load results, this is the most recent measurement of HIV RNA in a patient's blood prior to a defined outcome or time point, used to assess treatment effectiveness, level of viral suppression, and ongoing risk of disease progression and transmission. Now let's just take a look at our national 90-90 cascade as of July 2025. Jamaica has an estimated PLHIV persons living with HIV of 28,000. We have diagnosed 26,500 of that 28,000. That's 95% of our estimated number, or estimated PLHIV. Of the diagnosed, we have 14,930 PLHIV retained in care, 56%. And of those on treatment, we have 12,019, 81% being virally suppressed. Now, as you can see, our biggest gap is between the PLHIV diagnosed and the retained on ARV pillars, and that's what we'll be focusing on. Now, what is the problem? What are we trying to solve? The HIV 90-90-90 cascade focuses on three critical outcomes: diagnosing 90% of people living with HIV, initiating and sustaining 90% of PLHIV on antiretroviral therapy, and achieving 90% viral suppression. Although progress has been made in HIV diagnosis and treatment initiation, loss to follow-up remains a major barrier to achieving the second and third 90s. Individuals who disengage from care after diagnosis or ART initiation are less likely to remain on treatment. These disruptions can lead to increased morbidity, the development of drug resistance, and ongoing HIV transmission within communities. Consequently, loss to follow-up undermines the effectiveness of the HIV response and limits progress toward achieving the 90-90-90 targets. Our objective for this study was to characterize Jamaica's HIV population based on retention status, that's retention in care versus loss to follow-up, to identify the factors associated with retention in care, and to develop actionable recommendations based on the findings to improve retention in care. Our population exposure outcome framework consisted of the population persons living with HIV who access or accessed care at public sites. Our exposure variables were age, gender, parish or facility, marital status, distance from the facility, SMS reminders, first CD4 results, employment status, number of days between diagnosis and ART initiation, comorbidities, last viral load results, number of times lost to follow-up, key population, disclosure of status, and financial assistance. And our outcome variable was the retention in care status, retaining care or lost to follow-up. Our source of data is a treatment site information system, TSIS2. TSIS2 is a centralized web-based system that links all HIV treatment sites across Jamaica. This includes the public and private sites. It is designed to facilitate better management of people living with HIV. We excluded PLHIVs within our data set that had duplicates that were transferred from one site to another. That included PLHIV attending non-RHAs or private entities, PLHIVs that died, migrated, or were case archived. Our sample size after doing those exclusions stopped at 12,542. And when we broke down the 12,542 between our retaining care and lost to follow-up categories, we had 10,466, 83% of our PLHIVs being retaining care, and 2,076 PLHIVs, 17% being lost to follow-up. Our data analysis consisted of chi-square test and regression analysis. Characteristics of sample and chi-square test outcomes were we found that some characteristics that were significant or had a significant relationship with the retention status were males, those 20 PLHIVs, 20 to 49-year-old, PLHIVs that were single, PLHIV attending a treatment site outside of their parish of residence, PLHIVs that had multimorbidity, and PLHIVs that had that were virally suppressed. Also, those attending a treatment site in Kingston had a first CD4 of greater than 350, and those not receiving a SMS reminder. Some characteristics that we did not find to have a significant relationship with retention status was employment status, number of days between diagnosis and ART initiation, number of times lost to follow-up, key population, disclosure of status, and financial assistance. However, when we did look at our literature from prior studies done internationally, we found that there were mixed findings with suppression and unsuppressed viral loads when it came on to lost to follow-up population, high transportation costs, lack of family support, busy work schedules, and childcare responsibilities, mixed findings, high and low CD4 counts, lower educational level, financial instability, and men who have sex with men, and transgender for other studies in other countries found these to have a relationship with retention status. Our regression analysis identified the 20 to 49-year-old age group to have were significantly less likely to be retained in care compared to those 50 plus. And if we take a closer look at the 25 to 39 age group, we find that they have they are even less likely to be retained in care compared to the other ages. We found that the PLHIVs who were married were 2 times more likely to be retained in care compared to those who were single. We found that our females were 1 times more likely to be retained in care compared to our males. We found that in terms of proxy for distance from their health facility, those attending a treatment site outside of their parish of residence were less likely to be retained in care compared to those that attended a treatment site within their parish of residence. We also found, and very interesting to us as well, and very important, we found that those PLHIV that were receiving SMS reminders were 20 times more likely to be retained in care compared to those that were not receiving an SMS reminder. Those PLHIV that had a first CD4 result less than or equal to 350 were more likely to be retained in care compared to those that had a CD4 greater than 350. The PLHIVs that only had diabetes or had some form of substance misuse, asthma or COPD, depression, psychosis, or schizophrenia were less likely to be retained in care compared to those that had multimorbidity. The PLHIV that had a last viral load result that were undetectable or suppressed were more likely to be retained in care compared to those that were unsuppressed. And lastly, in terms of the regression analysis, for the treatment sites located in Hanover, Manchester, Portland, St. Elizabeth, St. James, St. Mary, St. Thomas, and Trelawney, they were more likely to retain their PLHIV compared to those in Kingston. Of course, no study goes without limitation. Lack of data in thesis for financial assistance, disclosure status, key population, employment status, and comorbidities were not available. That's our limitation. Some key recommendations from the team: targeted intervention required for PLHIV in the 20 to 49 age group. Targeted interventions are required for males for improved retention. Treatment literacy and risk perception to be routinely implemented, as the majority of PLHIV lost to follow-up were virally suppressed. Expansion of integrated clinics to address retention in PLHIV with comorbidities. Also, to address factors that contribute to PLHIV not accessing care at sites within the parish of residence, such as increased sites that offer expanded clinic hours, increased sites that offer weekend clinics, stigma, and addressing stigma and discrimination, improved data management in thesis 2, completeness of entry, timeliness of entry, routine data quality checks. And lastly, increased uptake of the SMS reminder feature in thesis, implement and qualitative aspect to further investigate the study findings. Of course, we would like to do future research, conduct a comparative study with the private entities to determine if there are significant differences in retention status, and conduct further investigation to understand why same-day initiation on ART was not associated with low retention. I just want to thank my team. I know my time is up. I just want to thank my team, Mrs. Rahana Khan Francis, Mr. Andre Williams, Mr. Akeem Whitehead, Shaniel Brissett, Amoedos Moish, Sheldon, Colin. I could not do this study without their help. And these are my references, and thank you so, so much.
Thank you very much, Ms. Lewis, a very informative presentation. And now to close out the session, we have Dr. Hyatt.
Good day. I'd like to thank NHRC for giving me the opportunity to present my abstract today. Additionally, I would like to thank my collaborators, Dr. Jason Copeland and Dr. Kadeem Knight, for assisting me with this research project. Now, we will start by talking about the evaluation of the mammogram unit density and access to breast cancer screening in Jamaica. Now, in Jamaica, as we know, breast cancer is the most common cause of cancer in the female population. In regards to the female population, this is highly likely due to the limited access to screening, which results in increased late-stage diagnosis and increased morbidity. A study done by Chin et al. Highlighted that 5% of eligible women in the screening population are actually undergoing screening, and most cases are actually diagnosed through diagnostic mammography. Now, this study is needed to highlight the gaps in regards to the screening population. Now, we wanted to quantify the mammogram unit density in Jamaica as per the target population of women aged 40 to 74, as well as 50 to 69. Now, in regards to the methodology, this was a descriptive cross-sectional analysis done in 2025. We ascertained a total number of 24 mammogram units across Jamaica, whether public and private, and this was compared against the total female population for the women aged 40 to 74 to 50 to 69. And this number was obtained from the Jamaica census of 2011, which was the most updated census at the time of this research. Now, this data was calculated per 100,000 women at that time, and the information was charted on the geographical information software, which we'll highlight later. Now, the information highlighted on the screen is highlighting the target female population throughout each parish. Now, in the population 40 to 74, we can see that Kingston and St. Andrew has the highest female population of 105,000 females for the 40 to 74 age group, as well as a population of 48,000 for the 50 to 69 age group. The total national population for the 40 to 74 age group is actually 388,000 across all parishes for the 40 to 74, while 195,000 for the population for the group of 50 to 69. Now, Kingston and St. Andrew accounts for at least 27% of this female target population, and when combined with St. Catherine, this accounts for at least 47% of all females in the country. Now, this diagram actually highlights much better what was elicited before. So as you can see, the dark blue highlights the concentration of females in that parish. So St. Catherine, St. Andrew, as we highlighted earlier. And then next we have St. James, Manchester, Hanover, Westmoreland, and Clarendon, and St. Mary. And then, as you can see, which is almost white, St. Elizabeth, Trelawney, St. Anne, Portland, as well as St. Thomas has the lowest female population. Now, as we can see, with the highest female population, Kingston and St. Andrew also has the highest number of units in the country. So Kingston and St. Andrew has a total of 11 units versus Manchester, which Manchester and St. James, which are the next highest, which are 3. And all other rural parishes are either 2, 1. But what I want to highlight are the parishes that actually have 0. Portland, St. Mary, St. Thomas, Trelawney, as well as Hanover, they all have 0 units in their parishes. Now, here we can see this being illustrated on the map of Jamaica, where we see a clustering in the urban center of Kingston and St. Andrew, while as we look at the rural parishes, we see a very scarce picture of mammogram units in these areas. Now, the mammogram unit per density. So as highlighted, the numerator would have been the mammogram units, and the denominator would have been the population itself. So for Kingston and St. Andrew, we see that the units per 100,000 females is 10.4 versus Manchester and St. James, Manchester 10.6, and St. James 11.9, which has the highest. Now, the total national average for the 40 to 74 age group is 6.2, while for 50 to 69, it's 12.3. And as you can remember, the 50 to 69 age group had at least half the number of females compared to the 40 to 74 age group. So this better highlights what is happening. While we would think that Kingston and St. Andrew would have the highest density, it actually has the 3rd highest density compared to St. James as well as Manchester. And as you can see, the following. And this is the same thing that we're seeing for the age group 50 to 69. Now, this better highlights what is happening here. So as you can see, the yellow highlights the highest density, the highest populated areas in the parishes, and that's where you have most of the clustering of the mammogram units. Now, let's look at the regional comparison. So as you can see, Jamaica is highlighted in red. Now, when we look at the United States of America, for the population of 100,000 females per, the mammogram units per 100,000 females for the population 50-69 age group, we see that United States have about 52 units per 100,000 females, while in Jamaica we're averaging about 12.3, and we're below the median. Now, one of the key factors that we wanted to highlight for this research as well was the minimum distance required to travel from one of the areas which were not very populated with mammogram units. And as we can see here, the minimum distance needed to travel for Portland was actually 82 kilometers. And if you should translate that into time, that's at least 2.5 hours to travel to the nearest mammogram unit. And as I'll highlight later, you will see that being illustrated. But for the minimum distance traveled, the median was around 20 kilometers throughout the entire Jamaica. So as you can see here, this is a representation of what is happening from the parish centroid of Portland to the closest mammogram unit. So I just wanted to highlight the time it takes from Portland to the closest mammogram unit, which, as you can see, 2.5 hours would be the required time to travel from Portland to get a mammogram. Now, when we consider things such as taking off time from work, when we consider things such as the fare required to get to this area and then to pay for the mammogram, this is something that cannot continue in terms of we need mammogram units in areas which are severely underserved. So in conclusion from our presentation, this highlights that Jamaica's mammogram units are maldistributed and insufficient. As we can see, Portland, St. Thomas, Trelawney, St. Mary, as well as Hanover, they have no mammogram units. And in regards to recommendations for this, there should be public-private partnerships which would allow for placement of mammogram units in these areas so that we can have increased screening in these areas as well. So thank you, and thank you for the opportunity.
Okay, I want to extend thank you to our three presenters. And what we have looked at in this section is the economics of health, right? Our health is our wealth. We spoke about accessing care or diagnosis of breast cancer before it gets too late. We also looked at the costs to treat persons when they are diagnosed. We looked at persons living with HIV and the social implications of that. So with that being said, I now open the floor if there are any questions for the presenters.
Thank you. All right. The first question I want to ask, excellent presentations from all of you. Thank you very much. Can we clap for them then? Thank you. The quick question I want to ask the last presenter. Those in the area that have zero outlets, is it that they don't pay taxes?
I cannot answer that.
You cannot answer, sir?
I believe they do pay taxes.
Exactly. They do pay taxes.
They do pay taxes. Yeah.
So they deserve to have a place.
They deserve to have a place to actually have screening, because what we can see is that a lot of persons are actually coming in with actual stage 3, stage 4 breast cancer. And at that point, we're using too much, as the presenter before me, he had highlighted that the cost for treatment, for endocrine treatment itself, is actually 60 million. And that's before we actually do the surgery, etc. So it's actually very important that we actually approach this from the screening aspect so we can prevent late-stage diagnosis. So as you said, we do need some in those areas.
Thank you. That is one, because those people are taxpayers. They deserve to be served accurately. Correct. And then the next question is for the young miss. Yes, thank you. The question I want to ask, based on your presentation, those ages 20 to 49, what happened to them? Why are they not staying in the care when they have? Are they paying for the drugs?
No, it's free.
It's free?
It's free.
So why are they not staying to receive the care that is free?
Well, there are a few factors. You can look at stigma and discrimination. You can look at the fact that they're busy. They're the working population. And as we saw, distance as well from their facilities. So,
Hold on, miss. Can you really agree that stigma and discrimination will be a problem? When you have a problem and there is a free solution,
yes,
you're still thinking that there is
stigma?
stigma?
It's still a big problem. It's still a big problem in Jamaica.
So how do we solve that? We go to their homes and give to them? What is the condition, miss?
Okay, so there are a few institutions or organizations within Jamaica, like JN Plus, that targets these problems, such as stigma and discrimination, as well as the Ministry of Health and Wellness as well, puts out certain things to ensure that the level of stigma and discrimination reduces by informing the public of HIV. So it starts from the individual looking on to know that HIV is not transmitted by mosquito bites or by sharing food with somebody else. So by doing these little things, we hope that stigma and discrimination will be reduced in Jamaica.
A last one for you.
Okay.
Will it be okay for us to tell them the lifestyle is wrong?
No, you can't tell somebody it's their lifestyle. What we can do is ensure that we educate them on how to live better, have safer sex, and do the things that they need to do to protect themselves. You're welcome.
Good afternoon, everyone.
Good afternoon.
Excellent presentation. Dr. Hyatt.
Hello, good day.
Good day. For the areas that had no mammogram
Units, yeah.
units, right? Did you look to see what condition when the women got screened they were in? Because that would be interesting. For us to see the areas where they had to travel far.
No, because this research itself was just carried at the units themselves. But there is research that is ongoing, looking at that information. Yeah.
Thanks.
1, 2, 3. Yes, I'm interested in the retention and care among people living with HIV/AIDS, accessing care at public treatment sites in Jamaica. Did you look at access to oral health care? I'm a dentist.
Access to oral care, no, we did not. But it can be noted for further
because
research.
it is shown that when people have access to oral health care, which is very expensive and hard to get, they tend to cherish it and want to come back more. Probably could look at if we integrate the treatment modalities, if it could lead to greater retention.
My team member.
There is integration within the health facilities, in the health centers. So when a person living with HIV attends a treatment site within our government setting, they do have access to all services that are available. And what we tend to do, the healthcare team at the site level is to try and twin their appointments so that, it reduces their wait time and so on. But the access is there, certainly, to all healthcare facilities that are offered.
Yeah. The reason I asked is that we have two modalities of integration. One in which we call co-location, in which oral health and other services are located at the treatment site, like the clinics. But the services are not integrated in that the referral pathways are not there to say if a patient with HIV/AIDS is accessing care, then oral health evaluation should be part of the referral process. But once you come to see me, I'm sending you to see your dentist. Because very often the oral cavities are not being examined.
Right.
And there are other issues there. So when we see them, like the mental health practitioners, it is usually too late.
So our clinical manual
that is used to guide the treatment at the sites. Oral care is also included in it.
So it's there?
It's there, yes.
Okay, thank you.
Before you move on to those on the platform, thank you so much. I must add that it was an excellent presentation. Thank you for your presentations. All right. And my question now is for Mr. Keith. Right. Based on your presentation, what additional data or studies would be needed to improve the economic evaluation of adjuvant therapies for breast cancer in our Jamaican setting?
Well, based on the limitations that we would have faced from our study, we would have said we'd want to see Jamaican-based utilities. That's one. We'd want to see a deeper look into the clinical pathologic nature of Jamaica in terms of a trial. We imported information from the Monarchy trial, but we could have such trial locally. If we had local data, we would have seen a direct matchup with the clinical pathologic nature of the patients. So those are two things that would say would improve the data quality for the analysis.
Thank you so much, Mr. Keith.
All right, thank you everyone for giving an ear to our three presenters who they spoke very well on their topic of discussion. And if there are no further questions, thank you for joining, and we will now break for commercial. Bye-bye.
The struggle, I removed my home. I thought I'm finished with cancer. 2016, cancer come back. There's hope for your daughter. My experience don't have to be her experience. So mothers, give your children the vaccine. It will be good for your sake and for the children's sake.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
I love my children, and I will do anything to protect them. So that's why, as a mom and as a doctor, I made sure that my daughter got the HPV vaccine to protect her from cervical cancer later in life when she becomes a woman. The HPV vaccine is very safe and effective.
I was afraid of the injection at first, but I got it and it really wasn't that bad after all.
If there was something you could do to protect your child, wouldn't you do it? Protect our next generation. Ensure that your daughter gets the HPV vaccine today.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
I want to see a Jamaica that is cervical cancer free. Cervical cancer is one of the leading causes of cancer in women in our nation, and I want this to stop. The HPV vaccine has been proven to be the most effective method to prevent cervical cancer. It is a safe vaccine, and it is best to give the vaccine to young girls before they've even been exposed to the HPV virus. So parents, I want to encourage you to let your daughters get the HPV vaccine. Let us protect our next generation against cervical cancer.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
Meet Jess. Jess knows a thing or two about her health.
Measles and rubella virus still circulate in the world, right?
Yes, Jess.
So could I possibly get sick if I travel to those countries and I am not vaccinated?
That's right.
Wow. We all need to be vaccinated on time.
She understands the value of vaccination.
Mommy, did you know that vaccines work to prevent 2 million deaths in children each year?
Wow.
Mommy, thanks for ensuring that I'm vaccinated.
You're welcome, Jess. Let's give our children the gift of health. Vaccines strengthen their defenses against harmful diseases for life. Get vaccinated.
A message from the Ministry of Health and Wellness and PAHO.
Your health is your wealth, so come we start the conversation. Make we rise and immunize all across the nation. The ministry is giving us the motivation to get your infants routine immunization. Protect the toddlers from all diseases. Tetanus, rubella, whooping cough and the measles. Polymyelitis, mumps and the flu, plus tuberculosis to name a few.
Rise to immunize. Eliminating diseases saves lives. Visit your nearest clinic or health center for more information or log on to www.moh.gov.jm. A message from the Ministry of Health and Wellness.
Vaccines are the safest, most cost-effective health measure, saving over 2 million lives a year.
Every year, over 1 million children die from measles, meningitis, and pneumonia.
Jamaica has had its own immunization program for a number of years, and because of that, our children have been living longer and healthier.
I'm a mother, and all 4 of my children are fully vaccinated.
It is our responsibility to ensure that every child is fully vaccinated.
Today, only 2 countries have wild polio.
If our children are not fully vaccinated, polio can come back.
Vaccination is a gift of love.
Do your part.
Get vaccinated!
A message from the Ministry of Health and Wellness and PAHO.
I was first diagnosed with cervical cancer at age 33. The treatment was not pretty. It was terrible. I couldn't go to work, and I spent the whole 5 years out of work. The pain, the struggle, I removed my womb. I thought, I'm finished with cancer. 2016, cancer come back. There's hope for your daughter. My experience don't have to be her experience. So mothers, give your children the vaccine. It will be good for your sake and for the children's sake.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
I love my children, and I will do anything to protect them. So that's why, as a mom and as a doctor, I made sure that my daughter got the HPV vaccine to protect her from cervical cancer later in life when she becomes a woman. The HPV vaccine is very safe and effective.
I was afraid of the injection at first, but I got it and it really wasn't that bad after all.
If there was something you could do to protect your child, wouldn't you do it? Protect our next generation. Ensure that your daughter gets the HPV vaccine today.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
I want to see a Jamaica that is cervical cancer free. Cervical cancer is one of the leading causes of cancer in women in our nation, and I want this to stop. The HPV vaccine has been proven to be the most effective method to prevent cervical cancer. It is a safe vaccine, and it is best to give the vaccine to young girls before they've even been exposed to the HPV virus. So parents, I want to encourage you to let your daughters get the HPV vaccine. Let us protect our next generation against cervical cancer.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
Meet Jess. Jess knows a thing or two about her health.
Measles and rubella virus still circulate in the world, right?
Yes, Jess.
So could I possibly get sick if I travel to those countries and I am not vaccinated?
That's right.
Wow. We all need to be vaccinated on time.
She understands the value of vaccination.
Mommy, did you know that vaccines work to prevent 2 million deaths in children each year?
Wow.
Mommy, thanks for ensuring that I'm vaccinated.
You're welcome, Jess. Let's give our children the gift of health. Vaccines strengthen their defenses against harmful diseases for life. Get vaccinated.
A message from the Ministry of Health and Wellness and PAHO.
Your health is your wealth, so come we start the conversation. Make we rise and immunize all across the nation. The ministry is giving us the motivation to get your infants routine immunization. Protect the toddlers from all diseases. Tetanus, rubella, whooping cough and the measles. poliomyelitis, mumps and the flu, plus tuberculosis to name a few.
Rise to immunize. Eliminating diseases saves lives. Visit your nearest clinic or health center for more information or log on to www.moh.gov.jm. A message from the Ministry of Health and Wellness.
Vaccines are the safest, most cost-effective health measure, saving over 2 million lives a year.
Every year, over 1 million children die.
That goes points, okay. Is there a thing? Or? Oh, I was just wondering if there's a laser pointer.
And because of that,
Laser, maybe this? I don't want to press it on then.
I'm a mother, and all 4 of my children are fully vaccinated.
It is our responsibility to ensure that every child is fully vaccinated.
Today, only 2 countries have wild polio.
If our children are not fully vaccinated, polio can come back.
Vaccination is a gift of love.
Do your part.
Get vaccinated!
A message from the Ministry of Health and Wellness and PAHO.
I was first diagnosed with cervical cancer at age 33. The treatment was not pretty. It was terrible. I couldn't go to work, and I spent the whole 5 years out of work. The pain, the struggle, I removed my womb. I thought, I'm finished with cancer. 2016, cancer come back. There's hope for your daughter. My experience don't have to be her experience. So mothers, give your children the vaccine. It will be good for your sake and for the children's sake.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
I love my children, and I will do anything to protect them. So that's why, as a mom and as a doctor, I made sure that my daughter got the HPV vaccine to protect her from cervical cancer later in life when she becomes a woman. The HPV vaccine is very safe and effective.
I was afraid of the injection at first, but I got it and it really wasn't that bad after all.
If there was something you could do to protect your child, wouldn't you do it? Protect our next generation. Ensure that your daughter gets the HPV vaccine today.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
I want to see a Jamaica that is cervical cancer free. Cervical cancer is one of the leading causes of cancer in women in our nation, and I want this to stop. The HPV vaccine has been proven to be the most effective method to prevent cervical cancer. It is a safe vaccine, and it is best to give the vaccine to young girls before they've even been exposed to the HPV virus. So parents, I want to encourage you to let your daughters get the HPV vaccine. Let us protect our next generation against cervical cancer.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
Meet Jess. Jess knows a thing or two about her health.
Measles and rubella virus still circulate in the world, right?
Yes, Jess.
So could I possibly get sick if I travel to those countries and I am not vaccinated?
That's right.
Wow. We all need to be vaccinated on time.
Good afternoon, ladies and gentlemen, and welcome to Scientific Session 6. We'll be focusing on mental health and workplace wellness. I'm Dr. Charmaine Mignot, the supervising psychologist for the Mental Health and the Suicide Prevention Helpline. We have 3 research presentations in this session. All 3 presenters will make their presentations, followed by the question and answer section. Allow me to introduce our esteemed presenters. Our first presenter will be joining us via Zoom, and the person is zooming from the U.S. Virgin Islands, and I speak of Dr. Smith. Dr. Hesdeen Smith is a retired fire chief, paramedic, and military veteran with over 37 years of service in the emergency services profession. He currently serves as the Chief Executive Officer of Global Emergency Services Consulting Group, LLC, GESCG, His professional expertise spans healthcare simulation-based training, fire and EMS system design and operations, strategic planning, medical and social science research, along with crisis leadership. Across the Caribbean, he has led numerous initiatives advancing EMS development, research, disaster preparedness, and workforce development. Dr. Smith is the president of the National EMS Management Association in the U.S., the chair of the Caribbean Emergency Services Registry, a research mentor, and a peer reviewer for the International Journal of Paramedicine. Dr. Smith is a proud son of the soil and was born in Lucy, Hanover. Our second presenter, Dr. Aiken, had another engagement and is unavoidably absent. However, her recording was pre-done. Dr. Joyette Aiken is a registered nurse midwife with over 40 years of professional experience. She's also a lecturer at the University of the West Indies School of Nursing, where she has taught at both the undergraduate and graduate levels for the last 18 years. As a researcher, she has authored several research publications, collaborated in international research, and supervised graduate student research projects. Dr. Aiken has a special interest in patient-caregiver and dyadic relationships, as well as professional nurse well-being. And our third presenter is Dr. Zachary Ramsey, who is seated on the platform. Dr. Ramsey is a clinical epidemiologist at the Sickle Cell Unit of the Caribbean Institute for Health Research. He has served as an investigator on major clinical trials and observational studies, including research on hydroxyurea, neuropathic pain, and universal health care. His primary research focuses on pain in sickle cell disease, and he recently led a study supported by the Foundation for Women and Girls with Blood Disorders, examining the relationship between menstrual cycles, female hormones, and pain in women with sickle cell disease. He was awarded a Chevening Scholarship in 2022 and is currently completing a PhD in epidemiology. So we now go to our first presenter, who has joined us via Zoom, and we follow in the order as introduced. Thank you.
Good afternoon, everyone. Is my screen showing okay? Yes, I think it is. So good afternoon. I'm Dr. Hezadine Smith. I appreciate the warm welcome, and I want to thank NHRC and the Ministry of Health and Wellness for the wonderful work being done there in Jamaica. And thank you for the opportunity to be here today. I'd also like to commend the previous presenters. The last 2 days have been very insightful thus far. So I'm looking forward to having some engaging conversation here over the next several minutes. The topic of our research has to do with exploring mental well-being and psychological distress in Caribbean EMS and fire service personnel. This was a quantitative cross-sectional study that was conducted by myself and my team. And I would be remiss if I did not acknowledge my team. Dr. David Beyer, medical doctor, emergency physician consultant out of Barbados. He was a co-investigator. Olawale Akogon is a co-investigator as well. He was our statistician out of Nigeria and Canada. Dr. Winston Warren, co-investigator as well. He's an educator and a paramedic, also a researcher with my team, and he's originally from Barbados. So I'd like to thank them and acknowledge them before we move on. First, I'd like to ensure that I address the disclosures part of my presentation. There are no conflicts. I received IRB approval through the University of the West Indies, Cave Hill campus in Barbados prior to conducting this study. My previous work involved a dissertation that examined the attitudes of emergency medical services stakeholders in Barbados, and this was a convergent parallel mixed method study that was conducted in 2008. Just a little bit about the background. So EMS professionals and firefighters, they face a lot of stress, and we would all agree, especially after Melissa and even before Melissa, their exposure to long hours, critical decision-making, it really increases their risk for PTSD, as cited by Lowe and Gallia and Janke and others in previous research. But despite the global evidence that links these conditions to poor job performance and absenteeism, I think research, basically, there's a paucity of literature out there to support Caribbean-focused research in that area. So this study examined the mental well-being and psychological distress among our EMS and fire personnel across the CARICOM. The problem statement. Despite global recognition of mental health challenges faced by emergency services personnel and firefighters, there is a lack of region-specific data and evidence-based interventions that address psychological distress and the mental well-being among our public safety personnel in the Caribbean. So my goal was to fill that gap with some primary research. Objective 1, we wanted to assess the prevalence of psychological distress and their overall well-being among these providers and examine whether gender or role-based differences can inform the evidence-based strategies in the future. The second objective had to do with comparing well-being and psychological distress across the different roles. And then the third objective focused on identifying targeted interventional and policy recommendations as a result of the findings. So we had 3 hypotheses. The first hypothesis looked at no association between well-being as categorized by the World Health Organization Scale 5 instrument, and also psychological distress, which was the Kessler model, and we'll talk about that in a few, among EMS and fire providers. The next hypothesis had to do with looking at a difference to determine if there's a difference between females and males in terms of the reported psychological distress. And third, we wanted to examine whether the frontline role or behind the desk roles had an influence, or there was a difference between the two in terms of mental health and well-being. So let's talk about the 2 instruments that were used. Please note, both instruments were previously validated. The World Health Organization 5 instrument basically is a subjective measure of well-being, and it has 5 items, and I'll discuss that. And then the K10, which is the Kessler instrument, also was validated in previous studies, but not in this particular population of members. So the WU5, there's some examples of the questions. Those are actually the questions. There was no need for me to change any of the questions, no need for our team to really change any of the questions because we didn't want to have to go through the revalidation process, but we still did a reliability and validity analysis subsequently. So the questions are there, feeling good, in good spirits, feeling relaxed, feeling active, vigorous, wake up feeling rested, and so on and so forth. So those were the 5 questions, in addition to the demographic questions that were asked. The K10 instrument was a little bit different, obviously. It has 10 questions, and it basically wanted to get information about feeling of tiredness, feeling of nervousness, feeling of hopelessness, things of that sort, restlessness, fidgety, things of that sort, being so nervous that the person couldn't calm down in terms of their reporting. It also talked about, are they unable to sit well? Do they feel depressed? How often do they feel depressed over the last 30 days? Or feeling sad over the last 30 days. So those were some of the questions those were the actual questions that were asked of the participants. So when we talk about research, we have to discuss the methods and design. This was a non-experimental cross-sectional study. We utilized anonymous surveys using SurveyMonkey, and I already spoke about the World Health Organization 5, which is the Wellbeing Index, and the Kessler Psychological Distress Scale. And we utilize SurveyMonkey to collect our anonymous data. So cross-sectional self-reported questionnaire. We utilize SPSS version 29 to get our numbers and also to do our analyses. And also we wanted to make sure that we examine the validity and the reliability of the instrument because this was the first time that both instruments were used together in this particular industry. So the process, we moved through the process, we finalized the questionnaires, we wanted to make sure we had appropriate demographic information, went through the IRB process, collected our data, entered our data, made sure our data had good quality, computed the Cronbach Alpha for both the World Health Organization 5 scale and the K10. And then we continued with the testing of the hypotheses and prepared our figures and tables. So as we get into the descriptive analysis and the descriptive information, what you're seeing here is that we wanted to kind of get a sense of who was involved in terms of the sample of the sample. So you had fire brigade officers, you had EMS attendants, you had administration on either EMS or fire, and then you had folks who were just firefighter only or folks who had dual certification, as in firefighter and EMS certification or credentials. And as you can see, majority of the participants had about 36%, 37% were mostly in the fire brigade. And if you add the additional ones at the bottom, it actually shows that quite a bit of them were from the fire brigade. So we also examined their level of certification just to get a sense of who we're evaluating. And a lot of them, most of them actually were EMT basic, at least half of them were EMT basic, emergency medical technicians at the certified level. And there were others spread throughout. There was low numbers with the paramedic level, as you can see there. About 7 of them were paramedics out of the total of 84. We had a total of 87, but 4 did not complete it. And in a couple of areas, some of them missed a couple of questions, even though they were mandatory. I don't know how they got around that. We wanted to find out, how many years they've been in the profession because future analysis could be done with the data that we had collected. A lot of them actually were experienced providers. So that was very interesting to see that a lot of experienced providers participated in the research. When we look at the countries that were involved, what we saw was that Bahamas had a pretty good response. Jamaica, interestingly, had the best response, and then Trinidad and Tobago. And then others were the other countries that were not well represented, but so we basically put those all together. But you can see here, we had a pretty good mix in terms of a cross-section of providers across the CARICOM. So in terms of the instrument validation, we conducted the Cronbach Alpha analysis to confirm that the instrument being used in this particular research, it maintained consistency and reliability. And as we all know, that reliability is gauged on the percentage, right? So ultimately, anything above about, depends on the book that you may read, I should say, it's about between 80 and higher is usually very good. And as you can see, the K10 came back at a 0.94, 95%. The Wu didn't do so well, but it was still at about an 89%, a 0.88. So we're pretty confident that the instruments can be used to evaluate further additional providers, or should I say in particular countries more specifically. And we'll talk about that later in terms of implications for future research. So we conducted the chi-square test, and the first analysis looked at whether psychological distress and well-being were associated when both measures were grouped together. And we grouped them and wanted to kind of find out, okay, is there a significant relationship there? We had the alpha set at 0.05, and as you can see, the results there indicate that it was significant, highly statistically significant. So this pattern did not occur by chance. What I believe this is telling us that participants who reported higher psychological distress on the K10 were significantly more likely to report poor well-being. So as we move from low distress to moderate to high to very high distress, you see a steady shift towards poor well-being in this group. So in simple terms, as distress goes up, well-being goes down. So in another way to say it would be that the more distressed the firefighter or EMS provider is, the worse their sense of well-being becomes. So that kind of sounds obvious when we look at it just based on the data, right? So as we continue looking at some of the additional findings, we were able to identify that, this confirms that distress and well-being, they're tightly connected. They're really tightly connected. So if we want to improve well-being, we cannot just ignore psychological distress. They're part of the same story. So that was hypothesis one. And we'll continue with that, talking about the relationship again, speaking about the significance there. So we move on to hypothesis two that examined the whether there's a difference between the genders, right? A difference in terms of psychological distress between males and females. And again, the findings were statistically significant with a P of less than 0.05. So females were notably higher in terms of distress scores, with a mean of about 26, I think it was 26, yes, 26.15 compared to males at 21.1. This is not a small difference. It's both statistically significant and also meaningful in terms of practicality. So this finding tells us that female firefighters and EMS providers in this sample are experienced significantly higher psychological distress than their male counterparts. And again, this has direct implications for targeted mental health support and gender-sensitive interventions. Now, we can probably have some conversation about why did it look this way? Was it, were females more honest in their responses, or were the males holding back? There's a lot of things that could contribute to that, but we're not going to say one way or the other because we don't have enough information to make that determination. Let's look at it another way, right? Looking at it another way using the same t-test in terms of gender and distress. This is the second finding where it gets very interesting, right? Here we're looking at whether distress levels differed and to what level, right? They were statistically significant, as I've indicated. And you can see in the bar, there that the female mean score, as I indicated earlier, it's there, it's higher than the male counterpart. So this is not a small gap, I believe. We believe this is a meaningful gap and a meaningful difference. So as we said before, this isn't speculation. This is what the data is clearly saying based on the sample that we examined. So the data tells us that female responders in this system that we evaluated are experiencing significantly higher distress, and our support strategies must reflect that reality. Here's yet another perspective. Here's yet another one. The categories, again, moving from low, moderate, and distress, looking at it in a number of different ways. What stands out again is the high distress category. So the high distress category, you're seeing the percentage there. Females, again, about 14 females based on the sample. So only 33% are males. So this is a striking difference, as we talked about already. So as distress level increases, the proportion of females increases based on the information there. So this pattern is not random. Now we examine role. We talked about that as being our third hypothesis, where we wanted to examine role-based influence, whether folks in the front line versus folks that are not in the front line. We can also acknowledge the fact that oftentimes folks that are behind the scenes, they've likely been exposed to things in the field. But regardless of that, we wanted to look at that. This particular analysis, it examined whether there was a difference between frontline and non-frontline roles. And we utilized, again, the independent samples t-test to look at it. And interestingly, the results were not statistically significant. And some may say, well, folks that are actually in the field engaging with customers may experience stress in a different way. However, folks behind the desk may not, right? So that could be the perception, but based on the information, there doesn't seem to be a statistically significant difference. As you can see, the p-value there is greater than 0.05. So when we look at the means as well, the means are almost identical. You can see the means, they're almost identical. So the difference is practically zero. And the columns confirm that, the statistics confirm that. So well-being challenges, though, in this group are not limited to those exposed to the front line. They're limited to everybody. Everybody is exposed to operational stress. So I think whether someone's administrative, whether they're in a support role or they're in an operational role, they're experiencing similar levels of stress or well-being potentially. So we kind of wanted to look a little bit further into it and say, well, if the well-being, there was no difference in well-being, is there a difference in distress as well, psychological distress? And again, no significant difference noted there. So basically what we're seeing is the difference is trivial statistically, and it's not really meaningful, but what it's saying is that frontline versus non-frontline, potentially there's still same influences, whether it's well-being or whether it's having a significant amount of distress or any distress at all, depending on how you look at it. So those are the three results that we looked at. And then we wanted to ask some additional questions because one of the speakers earlier spoke about the qualitative side of things. And as a mixed methods researcher, I thought it was important to throw in a couple questions like this. Certainly, it wasn't an open-ended question, but this speaks to the feelings of our providers. And what we're seeing here is the perception about management and management prioritizing mental health and safety within the organization that they represent. And what you're seeing is there's a strong disagreement. So when you add the disagreement and the disagree by itself, it's almost 60%. That is alarming. And we've shared this research in a recent conference in Jamaica, actually, at the Caribbean Association of Fire Chiefs, where we were talking to a lot of the fire chiefs from across the CARICOM. And we wanted them to be aware that there are opportunities to improve how they treat mental health and the services they provide and the support that they provide for employees. Here's another qualitative question, essentially. How do you feel when we talk about mental health in our organization after a critical call, after a bad week, after the Melissa, things like that? People want to talk about it. The providers want to talk about it. So nearly 75% of them responded favorably to that. So that was encouraging as a researcher to hear that, you know what? People really want to hear and feel and talk about it ultimately and get the support. So in conclusion, the impact of public safety stresses on our firefighters and EMS providers in the CARICOM, it's impactful. There's a greater burden of psychological distress that was found among females. There's no significant difference between the frontline and the non-frontline, certainly. But 6 to 7% of the likely severe group is female, based on the information. So peer support, mental health counseling, and team building exercise will definitely strengthen mental health in our profession. Furthermore, in conclusion, the impact of public safety stressors on firefighters and EMS professionals is significant in terms of ensuring long-term survival in this profession. After 37 years in this business, I'm still passionate about it because I was afforded the opportunity to get the help that I needed to survive and be in this profession and continue to help others. So factors such as peer support, mental health counseling, and team building exercise, we mentioned that. We cannot miss that. The findings further underscore that there's a need for targeted approach. And I like what's going on in Jamaica, particularly because I've been involved in the post-Melissa recovery and the engagement through mental health experts that are working with the Jamaica Fire Brigade. So kudos to that. And certainly across the Caribbean, I'm sure they're continuing to do mental health initiatives, but I believe that there's opportunities for continued engagement. So future opportunities, as with any research, this was just a cross-sectional study. Not able to generalize, certainly, but the idea is that we need to have a better understanding of mental health and psychological distress in our public servants. We need to identify opportunities for improvement there. So I think the next phase of this research project should look at not do we have a problem, but what system changes will fix these problems that are influencing the psychological distress among members and their mental well-being. The evidence is present. It demands system-level changes in fire and EMS across the CARICOM. It's not only individual resilience training that is needed. We need to look at the system as a whole, the system design, and how we can address the system opportunity needs for improvement there. So the takeaways for well-being in the fire service and EMS service is not about where they work. It's about the system in which they work. And where you work in the fire service doesn't change your well-being. It's the system that oftentimes influences what's going on with individuals. So we use two different instruments, two different types of analyses, same conclusion. The entire system is experiencing it, and it's not just on the front line. So with that, I'd like to wait for questions after the other presenters. My information is there. If you can use your phone, scan it, you should be able to contact us, and you should be able to also go to our website. I want to thank you for this opportunity and look forward to answering some questions.
All right. Thank you, Dr. Smith, for your extensive presentation on your study and the findings that you shared with us. We will have the question and answers after the last presenter takes a stand. We now go into our second presentation, which was pre-recorded, and that is by our Dr. Joyet Aiken. Thank you.
Good afternoon. My name is Joyet Aiken, and I'm presenting Burnout and Fatigue, the lived experience of nurse anesthetists in Jamaica. This study was done in partial fulfillment of a Master of Science in Nursing Education at UWI Mona. Nurse anesthetists are advanced practice nurses who provide anesthesia-related services to patients requiring surgical care, both elective and emergency surgical procedures. They work mandatory extended hours in any combination of 12 or up to 24-hour shifts each week, and there are no restrictions placed on the number of hours they're assigned. Many nurse anesthetists feel exhausted or they even experience burnout from their intense work schedule. The literature suggests that the provision of anesthesia requires a high level of knowledge, sound judgment, fast and accurate responses to clinical situations, and the capacity for extended periods of vigilance. The American Association of Nurse Anesthetists in 2013 expounded that this continuous clinical observation and vigilance are the bedrock of safe anesthesia care. With that in mind, I would like you to picture this. A nurse anesthetist sprints down the corridor of the operating theater trying to stay awake at 3 o'clock, 19 hours into a high-intensity 24-hour shift. Moments earlier, the nurse anesthetist had received a call from the emergency room stating that a patient suffering from multiple gunshot wounds was being rushed to the operating theater for an emergency laparotomy. Considering that vigilance is the foundation of safe anesthesia care, the scenario raises questions. Is vigilance possible during periods of exhaustion? Will burnout and fatigue compromise the nurse anesthetist's response to clinical situations? These questions fueled our research objectives, which were to identify if the three key dimensions of burnout, which are emotional exhaustion, depersonalization, and reduced personal accomplishment, exist among the participants. Second objective, to describe nurse anesthetist's perception of the factors that contribute to fatigue and burnout. And thirdly, to describe their perception of the impact of fatigue and burnout on their personal health and well-being, as well as on patient care and safety outcomes. For the purposes of this study, fatigue is a temporary state of mental or physical exhaustion brought about by lack of sleep or extended work hours, resulting in cognitive impairment and diminished performance. And among anesthetists, it results in poor record keeping, communication breakdown, delayed reaction time, deficient response to clinical situations, and poor decision making, according to Sinha et al. In 2013. Burnout is a psychological syndrome of emotional exhaustion, depersonalization, and reduced personal accomplishment, and it results in deterioration in employees' health, and job performance, according to Maslach et al., 1996. We utilized a qualitative study methodology and a phenomenological research design. We included nurse anesthetists in active practice. There are 34 in Jamaica, and we sampled 6, who were all members of the Jamaica Association of Nurse Anesthetists, or JANA, and they participated voluntarily. Data were collected one-on-one using Zoom interviews and a semi-structured interview guide and a personal information data sheet. Interviews were recorded and transcribed verbatim, and confidentiality was ensured. Full disclosure, the first author is a practicing nurse anesthetist and a member of JANA. To minimize this impact on the study conclusions, the researcher exercised bracketing. The recruitment process was completely managed by JANA leadership, and the research supervisor, which would be me, vetted all the steps of the research process and confirmed that the findings and conclusions drawn about the lived experience of nurse anesthetists are a true reflection of participants' perception and devoid of the student researcher's personal experience and viewpoints. Our results. The results revealed 4 main themes which aligned with the 3 key concepts of Maslach's model of burnout. The study results showed that emotional exhaustion and reduced personal accomplishment existed among the participants, but depersonalization did not. Participants perceived fatigue as excessive, resulting in negative mental and physical consequences. However, patient care and safety were not compromised, but rather they were prioritized over participants' needs. The themes we identified were working long and hard, theme 1, which described the extended working hours that nurse anesthetists had. And a typical quote was that they started at 8, but whatever time the cases were finished, they were finished. We have to continue to the end. We have to continue to the end. Theme 2, working above and beyond or going the extra mile. And this described their long and unpredictable working hours. So nurse anesthetists were working long hours in long cases, going on for hours with nobody to relieve them. You can't leave because the patient, if anything happens, you're going to be liable. Theme 3, making it work or working with the system. In this theme, participants shared their experience of fatigue and burnout in different ways, identifying signs and symptoms in themselves and in their colleagues. So they realized that when they get tired, they get miserable. Some days they were more tired than others, and sometimes they were unable to get things done because they didn't have what to work with, and that also accounted for some of their burnout. Theme 4 spoke to fulfillment in work, and despite their expressions of job-related stress and fatigue, all the participants spoke about their love for what they did and how satisfying anesthesia was for them. I love this work. I enjoy it. It empowers me. There's never a day that I get up and I don't feel like I can go to work. And there is this joy that you feel to say, I'm a part of the process when a patient recovers. So how do these themes align with Maslach's inventory? So the 3 key dimensions, emotional exhaustion and depersonalization, are described here. The first dimension, emotional exhaustion, was supported by themes of working long and hard, working above and beyond, making it work. The lived experience of the nurse anesthetist demonstrated strong support for this key component of burnout. Depersonalization was not supported at all because nurses were very caring towards their patients and passionate about their jobs. In terms of the reduced personal achievement, Our nurse anesthetists described fulfillment in their work. Despite the challenges that they faced, they were motivated by an innate personal drive to get their jobs done. Nurse anesthetists' perception of the factors that contribute to fatigue and burnout, they identified their excessively long working hours as a significant contributor. And they identified health changes at the physical, mental, attitudinal, and cognitive levels. They talked about behavioral changes and physical changes that they experienced. And these findings are reported in the general literature. In terms of the impact of fatigue and burnout on patient care and safety, while the nurse anesthetists reported high levels of fatigue among themselves, they felt that fatigue and burnout they experienced had no significant impact on patient care and safety. This finding is contrary to the literature, which speaks conclusively about the negative impacts of high levels of fatigue, which would be associated with decreased productivity, increased risks of adverse events, increased risk to personal safety and well-being, and increased risk to patient safety. And generally, burnout affects the health of healthcare workers and their ability to provide effective patient care. So one possible explanation is the team approach to patient care that some nurse anesthetists describes. And another possible reaction is that participants may have been reluctant to report negative incidents. So what are the implications for these findings? First one is that the nurse anesthetist has to have individual responsibility for their health and well-being. They must prioritize that. They also have to be strong on advocacy, advocating for organizational changes that value their contribution, changes that address the risk factors for burnout that they face, like their high caseloads, their long working hours without scheduled breaks, as well as ensuring safe staffing levels. And their high levels of self-motivation and intentional behavior in securing their mental and physical health also has to be a priority. They all have to adapt healthy lifestyles as well as maintain healthy, supportive collegial relationships at work. Further research, of course, needs to be done to quantify the extent of the burnout that is experienced and the possible threat to patient outcomes. Thank you so much for listening. And I now share my references. Thank you again.
All right, so we thank Dr. Aiken for her commitment to healthcare and for providing us with that pre-recorded session. We now call to the platform Dr. Zachary Ramsey, who will make his presentation. Make him welcome.
All right, so good afternoon, everybody. Special thanks to Dr. Grant and her team for inviting me to present this important work to you. So, as many of you know, sickle cell disease, it's an inherited blood disorder in which abnormal hemoglobin S causes red blood cells to basically become sickle-shaped, and that can lead to blocked blood vessels, anemia, pain, and organ damage. As a result, many patients living with sickle cell disease experience very high morbidity, frequent hospital use, and increased rates of depression and anxiety. And actually, these rates tend to be higher among women. Now, in the general population, dysmenorrhea, which refers to menstrual pain, along with heavy menstrual bleeding, these tend to have be associated with higher risks of depression and anxiety. There is also plausible biological evidence that sex hormones such as estradiol and progesterone, that they can be associated with depression and anxiety through their effects on different neurotransmitters such as serotonin. but none of these relationships have been assessed prior to this study. So our objectives in this study were to, for the first time, prospectively examine the relationship between both dysmenorrhea and heavy menstrual bleeding with the risk of major depression and generalized anxiety disorder among women with sickle cell disease and regular menses. We also wanted to test the hypothesis that estradiol and progesterone may confound or modify these relationships. So we conducted a prospective study at the sickle cell unit, and we recruited women with sickle cell disease of all genotypes who were 18 years and older if they had regular menses. We excluded them if they were pregnant and if they had any hormonal contraceptive use within the last 3 months. And participants completed 2 study visits, so one in each phase of the menstrual cycle, and that was basically based on an expert-recommended schedule that aims to optimize the best timing of measuring sex hormones in epidemiological studies. So what we did is that at both visits, we measured their serum estradiol and progesterone and conducted pregnancy tests. We also administered a study questionnaire to look on sociodemographic and medical history factors. And we did validated questionnaires to look on their quality of life and to screen for depression and to assess for these menstrual abnormalities. So we used the patient health questionnaire and the generalized anxiety disorder 7 to screen for depression and anxiety respectively. And these basically use Likert scale questions to look at the frequency of symptoms over the last 2 weeks. And we assessed persons as being at risk of having, each one of these respective conditions if they had a score of 10 or more on each of those questionnaires. We assessed heavy menstrual bleeding using the menstrual bleeding questionnaire. And what we did is that it is a Likert scale questionnaire as well, and it aims to estimate the heaviness of menstrual bleeding during the past month. So that includes pain, irregularity, and how that affects their quality of life. We use it as a continuous score so that higher scores actually indicate more severe menstrual bleeding and worse associated quality of life. And we use the menstrual symptom questionnaire to assess dysmenorrhea, which also uses a Likert scale set of questions to assess both congestive dysmenorrhea, which we, tend to refer to as the premenstrual syndrome, as well as spasmodic dysmenorrhea. And this was in reference to their menstrual periods in general. So we also use this as a continuous score, where higher scores indicated more severe menstrual pain and worse associated quality of life. So we performed 2 mixed effects logistic regression models, and our main outcomes were major depression risk and separately generalized anxiety disorder risk. Some of the different measures, the different variables that we're measuring, they may appear similar, but in fact, they do look at distinct, different constructs. But just to confirm that, we performed variance inflation factors to assess for multicollinearity. There is more to that, so if you want to ask questions about that, you can after. So we recruited 125 women. They had a mean age of 29, approximately 7% were obese, 79% had a severe genotype, and approximately 22% were on hydroxyurea. In terms of their menstrual characteristics, there was a mean duration of the menstrual cycles of 28 days with a mean of 4.9 days of menstrual bleeding. And the median age of menarche was 14 years, and approximately 41% had at least one pregnancy. So this table is basically showing us the values of the sex hormones that we measured. And as you can see, they actually were lower than available ethnic reference means. Now, in terms of the heavy menstrual bleeding assessment, The severity score, there was a mean of 11.4 out of a possible scale of 0 to 24. When we asked them what was their concern of bleeding staining their clothes from 0 to 10, the mean was 2.6. More than 2/3 of the sample reported that the number of pads that they had soaked completely on their heaviest day of bleeding was actually 0, and the number of times that blood clots were passed was never, whereas about a quarter of the sample reported 1 to 4 pads soaked and 1 to 3 blood clots passed. Okay. In terms of dysmenorrhea, the mean score was 62.6 on a possible scale of 24 to 120, and more than 1/3 of the sample reported premenstrual symptoms as occurring often or always, including breast feeling tender and sore a few days before their period, and their abdominal pain feeling bloated for a few days before their period as well. So this figure is just showing us the quality of life scores across the menstrual cycle, where higher scores indicate better quality of life. So you can see for sleep, social impact, stiffness, and pain impact, and there were actually no differences between the phases for any of those quality of life scores. Now, in terms of the screen positive rates, for major depression, it was 44.8%. For generalized anxiety disorder, it was 39.2%, and almost 1/3 of the sample reported passive suicidal ideations. Now, this figure is showing us the frequency of depression symptoms across the luteal phase in blue and the follicular phase in green, and the lightest shade tells us having a frequency of not at all, and then darker shades sequentially tell us more frequent reports, so including several days, more than half the days, and nearly every day. So just explaining it in case it doesn't project very well. There were no differences in any of these symptoms between the phases, but more than 2/3 of the sample reported symptoms such as trouble falling or staying asleep, or sleeping too much, feeling tired or having little energy, and poor appetite or overeating. In terms of anxiety, similarly, there weren't any differences in the frequency of the symptoms between the phases of the menstrual cycle. However, again, more than 2/3 reported not being able to stop or control worrying on several days or more, and also becoming easily annoyed or irritable. So in our mixed effects logistic regression model, higher dysmenorrhea severity scores were associated with higher odds of major depression risk and having better quality of life in terms of sleep and pain were associated with lower odds of major depression risk. Additionally, having a severe genotype was actually associated with lower odds of generalized anxiety disorder risk, and having better quality of life in terms of sleep and stiffness were associated with lower odds of generalized anxiety disorder risk. So in this study, we found that the screen positive rates of major depression and generalized anxiety disorder were 44.8% and 39.2%. And I just want to emphasize that this is strikingly higher in terms of prevalence than what we've seen previously reported in the literature. Right, so I'm wrapping up. So for example, using different but similar questionnaires that assess the same domains of depression, the prevalence of depression was much higher as compared to the general population in the GHLS3 survey, and it's a lot higher than when we last measured it in 2010 at the sickle cell unit among patients with sickle cell disease. However, using the same questionnaires and the same cutoff thresholds, when we compare it to a landmark longitudinal study in the United States, the rates that we found for both major depression and generalized anxiety disorder are actually 3 times what we're seeing in the United States. So we think that this is definitely a public health crisis and that further exploration is certainly warranted. One possible explanation is that a recent national survey in the United States found that the prevalence of having depression or anxiety has actually doubled since the pandemic. So that's one possible explanation. And of course, I'm coming up to my last slide. But of course, one possible contributor is the main finding in our study, which is that worse dysmenorrhea was significantly associated with higher odds of major depression risk. It is interesting that although we selected women who had regular menses and had a benign gynecological history, the women in this study still had much higher dysmenorrhea severity scores than healthy women in other populations. Taken together, we believe that this provides some evidence that we need to do routine screening for these menstrual and mental health disorders in this vulnerable population, and also to consider multidisciplinary care. Quality of life did appear as, or did emerge as a potentially modifiable factor. And of course, this multidisciplinary care could enable us to carry out interventions that could improve some of these factors like sleep and stiffness that could affect both menstrual and mental health outcomes. It is worth noting that although dysmenorrhea was severe in this cohort, menstrual bleeding heaviness was actually generally low. So this is my last slide. Hormone levels actually did not appear to be associated with the risk of major depression or generalized anxiety disorder. Now, we still reported it because inconclusive or negative findings are actually still important findings. There could be a possible limitation in the sense that we only measured one measurement despite there being known circadian variation in these sex hormones. But of course, we did actually use that expert recommended schedule, and the fact that there is no relationship is important. So this is my last point, which is that we found that patients with mild genotypes actually had worse anxiety. And of course, that's, counterintuitive to what we would expect. But this is an emerging finding that we have seen in the literature in recent studies. And the reality is that we know from our care that persons with milder genotypes, we tend to offer them less care, including disease-modifying therapies and curative therapies. And as a result, that can cause more illness uncertainty, which has been linked to poor mental health in the past. So thank you very much for listening. I want to leave you with this limitation, and many thanks to our sponsors and my co-authors.
All right, so thank you to our presenters. We now moving to the question and answer section. So in the absence of Dr. Akin, right, in absence of Dr. Akin, our questions will be posed to both Dr. Ramsey and Dr. Smith. Any questions from the audience? Dr. Smith? Dr. Smith, are you still online?
I did not see any questions in the chat.
All right, so there are no questions. Okay, well, this wraps up our section 6. Thank you for joining us, and we will now take a commercial break.
I was first diagnosed with cervical cancer at age 33. The treatment was not pretty. It was terrible. I couldn't go to work, and I spent the whole 5 years out of work. The pain, the struggle, I removed my womb. I thought, I'm finished with cancer. 2016, cancer come back. There's hope for your daughter. My experience don't have to be her experience. So mothers, give your children the vaccine. It will be good for your sake and for the children's sake.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
I love my children, and I will do anything to protect them. So that's why, as a mom and as a doctor, I made sure that my daughter got the HPV vaccine to protect her from cervical cancer later in life when she becomes a woman. The HPV vaccine is very safe and effective.
I was afraid of the injection at first, but I got it and it really wasn't that bad after all.
If there was something you could do to protect your child, wouldn't you do it? Protect our next generation. Ensure that your daughter gets the HPV vaccine today.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
I want to see a Jamaica that is cervical cancer free. Cervical cancer is one of the leading causes of cancer in women in our nation, and I want this to stop. The HPV vaccine has been proven to be the most effective method to prevent cervical cancer. It is a safe vaccine, and it is best to give the vaccine to young girls before they've even been exposed to the HPV virus. So parents, I want to encourage you to let your daughters get the HPV vaccine. Let us protect our next generation against cervical cancer.
Don't wait. Vaccinate against cervical cancer. A message from the Ministry of Health and Wellness.
Meet Jess. Jess knows a thing or two about her health.
Measles and rubella virus still circulate in the world, right?
Yes, Jess.
So could I possibly get sick if I travel to those countries and I am not vaccinated?
That's right.
Wow. We all need to be vaccinated on time.
She understands the value of vaccination.
Mommy, did you know that vaccines work to prevent 2 million deaths in children each year?
Wow.
Mommy, thanks for ensuring that I'm vaccinated.
You're welcome, Jess. Let's give our children the gift of health. Vaccines strengthen their defenses against harmful diseases for life. Get vaccinated.
A message from the Ministry of Health and Wellness and PAHO.
Good afternoon, ladies and gentlemen, fellow colleagues. Welcome to the 7th scientific session, adherence, that we're going to be focusing on adherence factors. I am Dr. Irving McKenzie, Chief Dental Officer in the Ministry of Health and Wellness. Thank you for staying with us for this very important final session of the day, and I'm sure you're going to enjoy it. Adherence remains one of the most critical challenges in healthcare delivery today. Whether you're discussing medication compliance in chronic disease management, preventive oral health behaviors, or engagement in treatment protocols. Today, we have the privilege of hearing from 3 distinguished researchers who will share their work on various aspects of adherence. Each presentation offers unique insight from different healthcare contexts and populations, ranging from older adults with chronic illness conditions to oral health behaviors and medication adherence in the primary healthcare settings. We will have 3 research presentations in this session. All 3 presenters will deliver their presentations. Our colleague from India, I think that one is pre-recorded, so we'll hear that, and I'm very happy for that. But let me introduce our esteemed panel of presenters. First, we have Dr. Katrina Calander, who is a native of Barbados, who moved to Jamaica to attend medical school here. She completed her MBBS degree from the University of the West Indies Mona campus in 2010. Dr. Calinda's worked in primary care both in Barbados and Jamaica. and earned a Doctor of Medicine degree in Family Medicine in 2025 with a search focus on physical activities in older persons. She currently works at the Westmoreland Health Department, serving as the coordinator of the Sickle Cell Disease Program and assisted in piloting the first men's health clinic in the parish. She should be congratulated for that. Then we have Dr. Kiran Rathod from India. He's joining us online. Dr. Rathod is a third-year postgraduate student in public health dentistry at the university in India. He will complete his Bachelor's of Dental Surgery and is presently pursuing advanced training in community-oriented dental practice with a focus on preventive and promotive oral health. Dr. Rathod has a strong interest in research epidemiology and evidence-based approaches to improving population oral health outcomes. His academic journey reflects dedication to professional excellence, ethical practice, and contributing to the advancement of public health dentistry through both clinical and community-based initiative. And for that, I'm really appreciative of having this oral health presentation today. Now we have our third presenter. I call him the final batsman, the night. Dr. Devon Malcolm Brewster, a medical doctor and recent graduate of the Master of Public Health at the University of the West Indies, Mona, where his research focused on medication adherence amongst patients with chronic non-communicable diseases in primary care. He practiced as a general practitioner at Arden Medical in Kingston and is deeply committed to advancing health equity, health education, and community-based approaches to chronic disease management. His broader professional interests include primary care system strengthening, chronic disease management, geriatric care, and home-based medical services. The session is on adherence. I think it is indeed a very important aspect of healthcare today, and our colleagues will be presenting. So stay tuned and listen up. Thank you.
Good afternoon, everyone. My name is Katrina Callender, and this topic was chosen to explore if older persons who receive care at our health centers in Westmoreland perform 150 minutes of moderate and vigorous physical activity weekly, because physical activity has numerous benefits for older persons and is a key modifiable risk factor for some non-communicable diseases, including hypertension and diabetes. Previous research has shown that globally, 20 to 60% of older persons meet the recommendations. And while the studies were not specific to older adults, studies done in the Caribbean on physical activity in persons living with type 2 diabetes showed that in Jamaica, 39% of persons had low physical activity levels, and in Trinidad, approximately 52% of persons were physically inactive. The Jamaica Health and Lifestyle Survey 3 found that physical activity levels were lowest in the 75 and older age group, and that rural residents performed high levels of physical activity, with 63% of persons in the 65 to 74 age category performing at least 600 minutes of weekly activity. Studies on physical activity in older persons have shown that increasing age, having fewer years of education, less social connection, depression, and pain were factors associated with inactivity, while social support, motivation, and higher levels of self-efficacy were associated with higher levels of physical activity. In Barbados, higher neighborhood walkability was associated with increased total physical activity and lower 10-year atherosclerotic cardiovascular disease risk scores in adults. And in studies exploring physical activity in rural areas, there was a positive association between recreational physical activity and the availability and accessibility of places for exercise. So this research aimed to determine the proportion of adults 60 years and older who receive care at public health centers in Westmoreland, who perform at least 150 minutes of moderate and vigorous physical activity per week, and to identify some of the barriers and facilitators of physical activity in these older persons. The study was a cross-sectional quantitative study. The calculated sample size was 415 persons, and convenience sampling was used to recruit participants from the Negril, Grange Hill, and Savannah Lamar Health Centers in March 2025. Persons were included in the study if they were 60 years or older, community dwelling, and received care at public health centers in Westmoreland. Persons were excluded if they were not ambulant, had a history of a neurocognitive disorder, were institutionalized, unable to give informed consent, or unwilling to participate. Ethical approval was obtained from the Mona Campus Research Ethics Committee and the Ministry of Health and Wellness in Jamaica, and written informed consent was obtained from all participants. The data collection instrument was a questionnaire which comprised the Global Physical Activity Questionnaire and questionnaire developed for this project. The questionnaire was interviewer administered, and participants were asked to recall the total amount of time spent doing moderate and vigorous physical activity for work, travel to and from places, and time spent in moderate and vigorous recreational activities during the last 7 days. Moderate intensity activities at work and for recreation were assigned 4 metabolic equivalents. Vigorous activities for work and recreation were assigned 8 METs. Performing cycling or walking for transportation was assigned 4 METs. The duration of physical activity performed each week in minutes was multiplied by the MET value assigned to each activity to determine the total number of MET minutes per week. Persons who performed at least 600 MET minutes per week were considered to have met the recommendations for weekly physical activity. Univariate analyses were performed using linear regressions, Kruskal-Wallis tests, Wilcoxon-Rank sum tests, chi-square tests of association, and logistic regressions were performed to explore the relationship between internal and external factors and performing at least 600 MET minutes weekly. The results showed the participant age ranged from 60 to 91 years. 43% of persons were male and 57% female. 75% of the participants reported a monthly income of less than 50,000 Jamaican dollars. 35% of persons reported that they were employed, with 18% being employed full-time. Most physical activity performed was in the transport domain, with a median of 600 MET minutes weekly, and moderate intensity work domain, with a median of 560 MET minutes. The level of significance used was 0.05. Total weekly MET minutes did not vary significantly with age, and there was no significant difference between MET minutes per week and persons in the 60 to 69, 70 to 79, and over 80 age categories. However, there was a significant decrease in transport-related MET minutes and a decrease in moderate intensity recreational activity with increasing age. There was no significant difference between males and females and total weekly MET minutes. However, females reported less time spent in vigorous intensity work-related activities and less time in transport-related activity than males. Total MET minutes per week varied significantly by employment status, with persons who were retired performing less activity than those who were employed full-time and those employed part-time. So, in this sample, 59.5% of persons reported performing at least 600 MET minutes per week. Employment status, receiving encouragement to perform physical activity, and having an area at home to perform physical activity, all had significant associations with performing 600 MET minutes weekly. 45% of persons in the sample reported concerns about vehicular road traffic, and this was associated with a 42% decrease in the odds of performing at least 600 MET minutes weekly. Active commuting is a cost-effective form of transportation utilized by many persons in the sample, and it may provide health benefits through reducing inactivity. Developing the built environment in Westmoreland to include sidewalks and cycling lanes would require a significant financial investment. The physical activity paradox refers to the findings that recreational physical activity may be associated with better health outcomes, while occupational physical activity may be associated with negative effects on health. In this sample, work-related activity in both formal employment and household tasks contributed significantly to the total weekly activity performed. But it is unclear if this is beneficial, as this study did not assess health outcomes. A study previously done found that only 15% of persons 75 years and over report being given advice about physical activity at public health centers, which suggests that increased efforts may be made to provide exercise prescriptions and recommend recreational physical activity to older persons. This is one of a few local studies to report the proportion of older persons attending public health centers who perform at least 150 minutes of moderate and vigorous physical activity weekly, and to illustrate the domains in which these older persons are active. Convenience sampling was utilized, and the findings have limited generalizability. Self-reported measures of physical activity are often used in population studies. However, they may be prone to recall bias, and persons may overestimate their physical activity when compared to objective measurements such as accelerometers and pedometers. The 2020 World Health Organization guidelines also recommend balance and muscle strengthening activities for older persons. Their participation in these activities was not examined in this study, and there is an opportunity for future research in this area. Additionally, qualitative studies may provide valuable insight into the factors which influence recreational physical activity in older persons. In conclusion, this study found that 59.5% of older persons in the sample met the recommendations for weekly physical activity. Most physical activity performed was related to work and transportation, and recreational physical activity decreased with age. Strategies such as exercise prescriptions, creating recreational physical activity clubs for older persons, and developing the built environment in Westmoreland to include sidewalks, cycling lanes, and parks may support active commuting and increase older persons' participation in recreational physical activity. I wish to acknowledge the invaluable contribution of my supervisor, Dr. Willie Tyndale, and thank the members of staff of the Westmoreland Health Department. These are my references. Thank you.
Thank you very much, Dr. Kalinda. With the WHO showing that elderly populations will explode and probably double by 2050, your study is indeed very, very timely, and I hope you pay keen attention to what was presented. We should now have the presentation from Dr. Kiran Kathod from India. Thank you.
District Narsiba Patel Dental College. Good morning, respected judges and my fellow delegates. I am Dr. Kiran Rathod, third year postgraduate student, Department of Public Health Dentistry, Narsiba Patel Dental College and Hospital, Visnagar. Today I will be presenting my research title as Impact of Oral Health Status and Oral Health Related Quality of Life among the Geriatric Population of Mehsana District, Gujarat. These are all my table of contents. Coming to the introduction, the smile is a curve that sets everything straight. The functional definition of elderly adult is primarily based on their capability to travel and seek services. Geriatric population categorized into three large functional groups. First is elderly adults, that functionally dependent elderly adults, frail older adults, and functionally dependent older adults. The world is going through dramatic shift in the population characteristics, specifically in the percentage of geriatric population. In total of 13% of world population was changed into elderly 60 or extra in 2017, and it miles grow at the rate of approximately 3% per year. The World Health Organization defined quality of life as an individual perception of his or her living situation, understood in the cultural context, value system, and above objective expectation and standard of giving society. Oral health is a mirror image of standard health, and any sickness affecting the oral health situation will affect the standard health and quality of life on individual. The effect of oral health on quality of life broadened the study barrier beyond the just clinical indicator. Hence, with the clinical indicators, use of oral health related quality of life of an instrument would assist appraise the oral health problem and elderly population in the powerful manner. Now, coming to the null hypothesis, there is no relation present between the oral health status and the oral health related quality of life of the geriatric population. Now, coming to the alternate hypothesis of the study, there is some relation present between the oral health status and the oral health related quality of life among the geriatric population. Now, the aim of the study to assess the impact of oral health status of oral health related quality of life among the geriatric population of Mehsana district. Now, to achieve the aim, we set the objective of the studies are to assess the oral health status using WHO Performa 2013, to assess the oral health related quality of life by using the GOHI questionnaire, and to assess the assess the between oral health status and oral health related quality of life. Now, coming to the material and methods, it is an cross-sectional study design. Source of data, the geriatric population of Mehsana districts. Related approval or ethical approval was taken from the ethical committee of Narsiba Patel Dental College and Hospital, Sakajan Patel University, Visnagar. The time scale of the study is August 23 to January 2025. The sample description and selection. Sample size was calculated was using the formula, and the sample size is about 400 at the confidence interval of 95%. Now, coming to the inclusion and exclusion criteria of the study. The first is the inclusion criteria. The patient who are cooperative and ready to give written consents, age of about 60 and older is included in the study. The participant should be permanent resident of the district. Now, coming to the exclusion criteria, the uncooperative patients, who are undergoing radiation or any chemotherapy, as well as the person with the drug, trauma, or surgery on the head, neck, or face. The patients who are in mental disorders, and the patient who are unable to communicate are excluded from the study. Now, coming to the methodology, it is a cross-sectional study conducted among the 400 geriatric individuals using the simple random sampling method from the different zone of the Mehsana district. The calibration was done for the examiner and the pilot study was conducted. The clinical and oral examination assessed the oral health data. They analyzed the SPSS version 20 and statistical test chi-square, t-test, and the ANOVA test was used. Now, coming to the result part, the study reveals that the high burdens of oral health disease among the geriatric population include the dental caries, periodontal status, enamel fluorosis, and oral health lesions. The participants with the poor oral health rates demonstrated significant lower GOHI score, the found to be statistically significant. It indicates that the deterioration in the oral health lead to deterioration of the oral health related quality of life. The first graph shows that the distribution of study participants based on their gender, the 72% of the participants are male and 28% of participants are females. The graph number 2, it shows that distribution of the study participant based on the dental caries status. Among the participants, 92.8% of the participants present of dental caries and 7.2% show have no dental caries. The graph number 3, which shows the distribution of the study participant based on the oral mucosal lesions present in them. Among them, the 90.5% of the participants don't have any kind of lesion in their oral cavity, and the 1.3% participants have oral cancer. The 0.5% of participants have lichen planus. 2% of participants have leukoplakia. 2% of participants have ulcerations, and 1.8% of participants have abscess. 1.3% of participants are having smoker pellets, and 0.8% of participants are having oral submucous fibrosis. Now coming to the table number 1, it shows the distribution and association of the study participant among the dental status. The dental status of it shows that among the participants, the dental among the participant dental status of shows that it is a significant result with a mean score of 21.8% and mean score of the absent of dental caries at 24.41%. The table number 2 shows the distribution and association of a study participant among the denture bearing and the GOHI score. The patients who are bearing denture are present, who are bearing dentures and who are not bearing dentures. It's says it is a give us a significant results in them. Coming to the table number 3, it shows the distribution and association of study participants and among the gender and the mucosal lesion. Among the participants, it shows a significant chi-square test shows a significant result, non-significant result in the oral mucosal lesion. Among them, maximum number of participants are not showing any kind of lesion in them, and the maximum number of lesions are shown by the leukoplakia and the abscess in them. Table number 4 shows the distribution and association of study participants among the oral mucosal lesion and oral health related quality of life. Oral mucosal lesion shows the p-value 0.056, that is non-significant value. That means the maximum number of participants shows absence of oral mucosal lesion. Now coming to the discussion part, the findings of highlight that the oral disease present and severity among the elderly directly influence the functional ability, comfort, social confidence, and general well-being. The result supports that clinical outcomes translate into the measurable quality of life of impact. This emphasizes that the need to integrate a geriatric oral health assessment into public health strategy. They include preventive dental care, gender-based disciplinaries, and rural oral diseases burden to the demand of target intervention. The present study shows that no significant difference in the GOHI by the gender. In the contradictory study, the study done by Nilamana et al. In 2020 and the Narayan et al. In 2022. In a present study, we find out that the higher dental caries association with the lower GOHI oral health, or GOHI score. And the similar study result are shown by the Rakhi et al. In 2018 and one Nasser et al. The prosthetic status relationship with the GOHI. The similar study results was shown by the Rama et al. In 2021 and Kaushik et al. In 2018. Now coming to the conclusion part, the finding reveals that the significant burden of oral disease among the oral elderly in the high prevalence of dental caries, periodontal issue, enamel fluorosis, and oral mucosal lesion. Moreover, the need of the prompt and immediate dental care was evident in the majority of participants. The gender-wise analysis demonstrated notable disparity in the oral health condition and their association with the GOHI score, suggesting a need of the gender-sensitive public health intervention. Thus, the study also highlighted that the rural residents face the greater oral health challenges, although the difference in the GOHI score across residential area and statistically non-significant. These are all my references. Likelihood and benefit of the study. Oral health status may have effect the oral health related quality of life. We will assess the impact of the oral health related quality of life by improving the oral health status, and we'll able to improve the oral health related quality of life of the geriatric patients. Thank you.
It's great to have oral health, eh? That's why we can eat, speak, and smile. Right, Sharon? But we're going to have Dr. Brewster, and I'm sure he has great oral health. He has that Colgate smile. Dr. Brewster, your turn.
Good afternoon, Mr. Moderator, members of the panel, colleagues, and distinguished guests. I am Dr. Devon Malcolm Brewster, a recent graduate of the Master of Public Health program in the Department of Community Health and Psychiatry at the University of the West Indies, Mona campus. And today I will present the findings of my MPH research on awareness, attitudes, and practices related to antidiabetic and antihypertensive medication adherence among patients attending health centers in Kingston and St. Andrew. At this time, I wish to acknowledge the guidance of my research supervisor, Dr. Camilla Thompson, and thank her for her guidance. Diabetes and hypertension are leading chronic non-communicable diseases in Jamaica, and disease control remains suboptimal despite the widespread availability of effective pharmacotherapy. Medication adherence represents a critical gap. When adherence is poor, patients are less likely to achieve sustained disease control, and complications increase, and the burden on the healthcare system rises by way of more visits, admissions, and worsening morbidity. International evidence demonstrates that medication adherence is shaped more by beliefs, perceived barriers, and routines than by access alone. However, theory-informed local evidence in the Jamaican public primary care settings remains limited, particularly evidence examining how awareness, attitudes, and practices interact to influence adherence behaviors. Accordingly, this research was conceptually informed by the health belief model and the theory of planned behavior. These frameworks suggest that while knowledge and belief influence intention, adherence improves most when intention is translated into consistent routine behavior, and when perceived barriers such as side effects or perceived medication complexity are actively addressed. And so the objectives of this study are to describe the socio-demographic characteristics of adult patients receiving pharmacotherapy for diabetes and hypertension, to determine the level of adherence to prescribed antidiabetic and antihypertensive medications among these patients, to assess patients' awareness, attitudes, and practices relating to their prescribed medications, and to identify factors that are independently predictive of medication adherence. This was a cross-sectional study conducted between February and July 2025, for which ethical approval was sought and granted by the relevant authorities. A total of 304 adults, achieving the minimum sample size of 303 per Rheosoft, attending 2 public health centers in Kingston and in St. Andrew, were recruited. Data were collected using an interviewer-administered questionnaire incorporating the adherence to refills and medication scale or ARMS tool, which captures both medication adherence and refill behaviors. Of note, this tool has not yet been validated in the Jamaican context. However, it is a well-used and widely utilized adherence measurement tool internationally, especially in chronic disease populations. Analysis was conducted using SPSS version 29 and included descriptive statistics, bivariate testing, and multivariable logistic regression analysis to determine independent predictors of adherence. Participants were predominantly female, comprising about 76% of the sample, and the modal age group was 61 to 70. Overall, socio-demographic factors were not primary drivers of medication adherence in this population. Background characteristics alone did not adequately explain adherence behaviors. As shown here, 68.1% of participants were classified as non-adherent. And so non-adherence therefore represents the majority pattern among patients attending primary care clinics. Participants reported high awareness of complications associated with diabetes and hypertension. However, awareness variables were not independently associated with medication adherence after adjustment. As for the attitudes, higher adherence was associated with belief that medications were essential for disease control. Meanwhile, lower adherence was associated with the perception that the medication regimen was complex. The strongest associations with adherence were observed at the level of practices. Participants who followed specific routine associated with taking the medication, were significantly more likely to be adherent with their medication. Lower adherence was associated with behaviors such as adjusting medications due to side effects, stopping medications when the condition felt controlled, and the use of herbal or home remedies. These behaviors reflect what patients do between clinic visits. This figure shows us the independent predictors of adherence derived from multivariable logistic regression analysis. Adjusted odds ratios at 95% confidence intervals are shown there, and values greater than 1 indicates greater odds of adherence, while values less than 1 indicates decreased odds of adherence. And so as we see here, following a specific routine emerged as the strongest predictive factor of adherence. In contrast, adjusting or stopping medication due to side effects, or stopping medications when the condition felt controlled, or perceiving the regimen as complex, were independently associated with reduced adherence. In fact, rather, it was independently predictive of reduced adherence. And so overall, the model reinforces that practice-level behaviors and perceived barriers outweigh awareness and socio-demographic factors as determinants of adherence. These findings indicate that education alone is insufficient for medication adherence, to improve medication adherence. And so at the level of individual clinical encounters, adherence support should prioritize routine building. Clinicians can help patients link medication use with consistent daily cues, such as eating their breakfast or having their lunch, or bedtime habits, so that adherence becomes less dependent on memory and more dependent on their habits. The findings support proactive management of side effects and perceived regimen complexity early, rather than waiting for non-adherence to appear. During visits to manage chronic non-communicable diseases, asking about missed doses, side effects, and what happens when the patient feels better may help to improve and prevent, rather, unsupervised medication adjustments. The association with herbal and home remedy use and non-adherence, though it was not independently predictive of adherence, underscores the need for greater individual and national conversations and research on safe use of traditional medicine in patients' disease management algorithms. If clinicians do not ask, patients may substitute rather than combine therapies where necessary safely, and important adherence-related behaviors may also go undocumented. These recommendations, friends, aligns adherence support with the behavioral realities of patients' daily lives and are feasible within public primary care settings. At the policy level, this underscores the need for allocation of resources for a national medication awareness campaign and to equip clinicians with standardized adherence assessment tools, continuous provider training, and an appropriate monitoring and evaluation framework to reshape routine doctor-patient consultations. Several limitations should be acknowledged. The cross-sectional design limits causal inference, as we know, and observed associations cannot be interpreted as causal relationships. Medication adherence was self-reported, which may introduce recall and social desirability biases. As the study was conducted in a public primary care clinic using convenience sampling, findings may not be generalizable to private care settings. However, this context is also a strength as it reflects routine care for a large portion of patients accessing NCD management services. As I conclude, this study demonstrated a high prevalence of medication non-adherence among patients attending public health centers in Kingston and St. Andrew. Although awareness of disease complications was generally high, knowledge alone was insufficient to ensure adherence, as practices outweighed awareness as independent predictors of medication awareness. These findings, therefore, point to the need for behavioral-focused strategies to support medication adherence in public primary care settings. And finally, overall, medication adherence should be understood as a behavioral challenge and not an informational one. Thank you very much for listening. These are my references.
Thank you very much, Dr. Brewster. Wow, what can I say? Adherence, very serious matter. If I could rename the theme of this presentation, I would not only say adherence, but I'll also speak to quality of life issues. So I want to thank our three presenters for the outstanding presentation and for sharing their important researches with us today. What we have heard this afternoon reinforces a fundamental truth in healthcare. Even the most effective interventions are only as good as patients' adherence, if I should follow what you said, Dr. Brewster, which is very, very good. Whether we are examining physical activities in older adults, Dr. Kalinda, or look at oral health behavior, as Dr. Kira has shared with us, or medication compliance in chronic disease management, the gap between what we perceived and, or what we prescribe and what patients actually do remains a critical challenge. The research presented today highlights several key themes and cut across different contexts. the importance of understanding barriers from the patient perspective, the need for tailored intervention that accounts for socioeconomic and cultural factors, and the critical role of healthcare provider patient communication in fostering adherence is important. As healthcare professionals and researchers, we must continue to ask not just what works, but what works for whom, under what circumstances, and why. The multifaceted nature of adherence demands multifaceted solution from healthcare system strengthening into individual behavior and interventions. I want to encourage you today that this conversation goes beyond this session, to translate these into research findings, into practice, and to remain committed to addressing adherence as a cornerstone of an effective healthcare delivery. Right now, I'll open the floor for any questions. Yes, Doc?
All right, good afternoon. So there is a question from online for Dr. Calendar. And that question is, did you exclude retirees with mobility issues from the study? There was an additional comment to say that other safety concerns in Jamaican neighborhoods, such as poor street lighting and stray dogs, can also be considered as barriers in future research. But the question really, did you exclude retirees with mobility issues from the study?
Yes. So if persons were not ambulant, they were excluded from the study. And yes, I agree with the other factors that can influence persons' willingness to come out and engage in physical activities such as walking in their neighborhoods.
Thank you.
Okay, before you sit,
sure.
Just have one more question for you. How did you actually measure the internal and external factors that would have influenced physical activity in this study?
Okay. So on the questionnaire, we had considered some internal factors, such as having a chronic illness, history of a fall, a positive depression screen, and we looked at some of the external factors, including the road traffic safety concerns, access to parks and gyms and public recreational spaces. And we did chi-square test of associations with the internal and external factors and those who had achieved at least 600 minutes of physical activity.
Thank you so much.
Sure.
Thank you very much, Dr. Cullen. Any more questions? All right, I take the liberty of asking Dr. Brewster one question. And I heard, when I heard policy, something just jumped out at me, and I thought about for a moment health system and provider aspect. Like, what role, Dr. Brewster, do you think that the provider-patient relationship plays in adherence, and how this can be strengthened?
Thank you very much for that question. If you listen to the recommendations which you did, I'm sure, you'd realize that most of them are based primarily in that room where the doctor and the patient are, right? And that is because the relationship between a doctor and a patient is a sacred one. You assume that a patient comes to you, they come to you in their point of greatest vulnerability, but they trust you because of your degree and your competencies. And as such, it is important, therefore, as physicians, for us to combat whether it be misinformation or just genuine ignorance with the facts. Educate them and ensure that it is delivered in a manner that is palatable, a manner that they can understand. And it is something that I think definitely needs to be introduced as a policy directive in terms of, by way of training, giving our physicians greater training in terms of how it is that we incorporate, not just as a by the way, but as a mandatory part of chronic disease management interventions within the clinical setting, questions about adherence, and also responding to these questions with proven solutions that we can then track as we continue to see them, whether it be on a 4-month or a 6-month interval.
I just want to, before you ask, just want to add the patient-centered aspect to this care, because so many times we're with the patient, but what we think we know and perceive may be different from what the patient, as you mentioned, the health believe. How do you see patient-centered care in this? And what are your perspective in terms of patient care, patient-centered care and compassion, even from a curricular perspective?
Well, the thing about it is that I don't think that there's an alternative to patient-centered care. This is what we are in the business of, caring for our patients, and it therefore means that it must be the focal point of our approach as physicians when we interact with our patients. What are the needs of the patients, where they are, how can we meet them, and how can we ensure that we respond appropriately to those needs. So I will use, for example, one example, and it comes from my experience in the clinical setting at a public primary care setting. I remember interacting with a patient who had been diagnosed with diabetes for about 15 years. And so in the interaction, I asked, what is diabetes? Do you know the medications that you're taking? What is the intention of the medication? And she was not able to answer, right? And the first thing that came to my mind was, she's been in the clinic for 15 years. And after 15 years, she knew nothing about her disease processes. And therefore, how can we expect this patient who has no knowledge of what she has beyond the name, why she's taking the medication, how can we expect her to prioritize taking those medications over any other manner of thing in her life? It therefore means that and I would say further, what I did next was to educate her, and I told her that you must come back to me in 1 month. Much to the dismay of my supervisor at the time, because, we have to deal with a lot of patients, and you don't want them to come back so fast, because then you're going to be full. But I made a decision as a junior doctor that any patient who came who was uncontrolled is going to return in 1 month. And that patient returned in 1 month, and her pressure was controlled, her sugar was controlled. And it was because I challenged her. This is what I want you to do. Let's just try it. It might work, it might not work. But if it does work, you will know that you should do it going forward. And I think, if I should say so myself, her life was changed in that moment when she saw that the actions that she took as a result of our discussion, yes, the discussion probably took about 10 minutes. And so it extended the interaction beyond the average, beyond the comfort of the average physician who wants to go home by 1 p.m., even though they're paid to be there until 4. But the impact is undeniable. And so we have to ensure that a patient-centered approach, even if it takes a little more resources, even if it takes a little more time, we apply that. And if enough of us as physicians do that, then we will see a material impact on disease control in Jamaica.
Thank you very much.
Dr. Brewster.
Thank you very much. I could have as well said I wouldn't ask my question, but I will still ask. Thank you. Now, if a patient comes to you and the person takes, let's assume, some herbal products.
Could you repeat that?
Some tea, bush tea.
Yes.
And the person feels better whenever they take that bush tea. I believe that because they feel better, they might not want to adhere to whatever medication they are getting. So if they come to the doctor and say, Doc, you see, when I take this, I feel better. But if you brush it away and say, no, that's bush, you just write them off. So that will stop them from either speaking to the doctor what they are doing, and then they will not adhere, they will do what they want to do. I hear you talk about disinformation and misinformation. I remember cases when persons were not they think something, and when they share with the physician just dismiss it and dismiss them. What did they do? They dismissed the physician and went about their way. So we have to really be mindful on you listening to the patient as well as guiding the process.
Absolutely.
Thank you.
Absolutely. I would like to just add one thing to that. I think it is important as physicians that as part of meeting the patients where they are, you have to acknowledge, first of all, that you don't know everything. When a patient comes to me and says to me that I drank some Ceracity because XYZ and it definitely helped, I say, really? Tell me some more. And then I go and I research it myself. And for me, my priority is not to invalidate their traditional approach. My priority is to ensure that their additional traditional medication use does not compromise the medications that I want them to take. And I present it to them as something that is potentially complementary and not an antagonistic relationship. Because my goal as a physician, in fact, is to ensure that at all points in time, a patient is as on little medications as possible. So my goal is to reduce. So if I can reduce it while you safely use your traditional medicine, then it's a win-win for all of us, isn't it so? We need more I think there's a question at the back.
Yes, there's another question for you. And that question is, chi-square demonstrates association, but your conclusion suggests that beliefs predict adherence. Did you perform any multivariable regression analysis to support that inference? And if yes, then what confounders did you find for your study?
Well, yes, I did do...
control for your study, sorry.
Right. So in terms of the independent predictors, that was the product of multivariable logistic regression analysis. And so the key takeaway really and truly was the independent predictors as a result of the multivariable analysis and not necessarily as a result of the associations found in the chi-square. But you would notice that, for example, the herbal use and traditional remedy use, that was not found to be independently associated, independently predictive. It was an association on chi-square, but though it is not independently associated, it is still worthy of note. And I do think that it is an area that requires further research to identify those confounders. Identifying the confounders was beyond the scope of this research.
Okay. Thank you.
Sure.
Wow. What a spectacular ending for today. Adherence. Can we give our colleagues a round of applause? And to those who are in cyberspace, you too are welcome, and we thank you for being there. And to the organizers of this conference, and to our colleagues and others who are here, and our videographers and others who make today a real meaningful experience, along with our caterers and the staff of the Jamaica Pegasus Hotel. We just want to say thank you very much.
So we have come to the end of a second day of excellent presentation, and we want to thank persons online for their overwhelming support. So I'd like to just give another round of applause. Still have over 500 views at the end of the day, and that really shows the commitment to research and the interest. And we want to thank you for the excellent not only questions, but the enthusiastic participation. And so, in addition to the excellent oral presentations today that covered the topics of health economics, mental health, and workplace wellness, as well as adherence factors, We also had special presentations on the marketing of breast milk substitutes, AI and robotics in healthcare, and the role of research in the 2030 agenda. In that latter presentation that generated quite a lot of discussion, we were encouraged to focus on health systems research as well as knowledge translation. We have one more day of research, where tomorrow we will focus on Hurricane Melissa and childhood trauma, substance use disorders in Jamaica, the prevalence of HIV drug resistance and its determinants, and ethical concerns on the integration of artificial intelligence in research. And there will also be a workshop on abstract writing. Where else can we get this rich information that is free of cost to anyone who is interested? So let us give a round of applause for that. And I want us to stick around, as some people will say, stick and stay, as tomorrow will serve as the culmination where we will be unveiling our research award winners. So please join us again at 9 o'clock. See you then. Thank you.